Oh, that looks fabulous. I think we have a lift off in the sense, Miguel, we can now live stream on Facebook, on YouTube and LinkedIn, and that really is that really it changes the game, to be honest. If that had happened, not trying to make any flippant comments, but if that was possible, then Alexander the Great would have never left Macedonia. He would have just stayed home and streamed everything from Macedonia. So let's see. Let's see whether it's going to YouTube as well. Let's scan. Good. Excellent. Very good. Very good. This is impressive. Oh, that's fabulous. Good. Miguel.
Good morning.
Good morning, Miguel. How are you?
Fine, thanks. Ready.
Excellent, excellent. How is Sinta and Miguel doing?
Yes, they are. Thank you so much. They are doing great.
Excellent.
Sinta is now working because, as I mentioned, we had to operate on yesterday.
Yes.
In one of the hospitals we are running in Marbella.
Oh.
So she had to go to see the patient, and hopefully she's going to join us. But now she's working. She's doing great, and also Miguel. Thank you so much. Miguel is involved in banking.
Oh,
He's
excellent.
worked for the Bank of Paris that has
fantastic.
several euros in Europe, and we are very happy because he's having this good job.
Excellent.
He has a very fluent French because he was educated in French language, so he has this ease. And he's going from Madrid. He's now based in Madrid and flying from time to time to Paris.
Oh,
and
good.
I'm very much looking forward to have you. I hope this pandemic is going to be over
I hope
very
so.
soon. We have created a chair that is called a chair for advanced neurosurgery.
Oh, wow.
It means we will have some possibility to, invite
Fantastic.
people to our department, and you will be one of the first one.
Oh, thank you. Thank you very much. Thank you very much.
Will be Fred Gentili, because
Yes.
I was visiting professor in Toronto 1 year ago, and we were having dinner with Andres Lozano and Fred Gentili, and we went there invited under the basis of and possibilities of the chair for skull-base and neuro-oncology. They created the Somago. You know that in the Saxon countries there is a custom regarding donation and things like that. It's not the same thing, unfortunately. So we are trying to create it atmosphere for donation and things like that for that purposes. In any way, they were supposed to be the first to come to Malaga, and you will be the first one.
Thank you very much.
They transmit me the idea, and insofar as I was back in Malaga, I started to do all this sort of paperwork under the umbrella of the university. I have a position of professor there, and it allows me to do that. Otherwise, you cannot do that. To direct the chair for those purposes. So it will ease the possibility to have you here in Malaga, and I'm truly saying you that we are very much looking forward. You will also have the opportunity to meet more people, because our department has been increased the number of staff. And also we are now under construction, the third operating room that is hopefully to be very well equipped. And for 2021, we have a formal project already approved of intraoperative MRI, a hybrid intraoperative MRI. The MRI is now working at the pediatric facility, and he has all the requirement for that, even the door. So we need just to build next door the operating area that has been approved. You know that one of the limitations for that project are architectonic limitation, because usually you don't have in the same area radiology and our area. It usually is not like that.
Yeah.
So in that reason why we cannot do that at the let's say at the main hospital. But the pediatric pavilion does have this opportunity. So the new MRI just started to function maybe almost 1 year ago. Is in some area we can make that sort of construction. So all this project we have there. Also, we are in the process of trying to create a nanotherapy department. Well, we have many things, and we will be very pleased having you in Malaga.
Thank you.
Miguel, can I ask something about that, because it's interesting. Good to see you actually on the screen. With intraoperative MRI, when we built that more than 10 years ago, an MRI that is only available in the OR and was for urology, ENT, so for many specialty, gynecology, neurosurgery, it was not sustainable. So it was then also used not for really outpatients, but at least, let's say, for children that need a short term of anesthesia. And that was easier to do because it was really inside the whole OR building. So some built the MRI at the side of it so that also outpatients can go in to have more patients, because it is very expensive. But when we did that, and also some people with claustrophobia and so on, with some short anesthesia, that was easier to do for the anesthesiologist while they are still in the OR. And we have 2 ORs that are adjacent to the MRI scan, and it can be turned, so you can just go in. But it needs to be not only for neurosurgery, it needs for all specialties. The ENT surgeons do the dissections in the neck. The gynecologists are doing oncological surgeries there. So it is, and that OR has also an O-arm and this Zigo robot arm. We can do vascular cases there. We do angio. So it is, you need to have a big exposure of a lot of cases to make this sustainable. Otherwise, at least for our hospital directors, it was not possible to finance it.
Thank you for this comment. I completely agree. And reason why we not even asked for intraoperative MRI, because I thought it was something, the benefit and cost wasn't, reasonable. But the system we have planned is the hybrid intraoperative MRI. That means we have the radiology pavilion, and today, Monday, patients are coming from the hospital or outpatient studies are done. So for the occasion, you need the intraoperative MRI, as the MRI can be in 20 minutes can be converted into surgical
Oh, okay.
in
Because there
terms.
is sterility, of course. You are always a little bit afraid when people just from, let's say, outside just arrive by car and then enter that MRI facility. That would be not so easy to do. And oddly enough, in the beginning, we thought when we have the MRI, we will use it more and more and more. To be very honest, we have been using it less and less, and that's an unfortunate thing. And I tell you why. Especially, I mean, in neurosurgery, initially we did that with all the gliomas, the pituitaries. I went to put pituitaries in there, but there were only a few cases where it was really helpful. So we limited that because it is time consuming. People saying that you can do it in 15 minutes, I don't know how they do it. I can't, simply, I can't. And that's, so it takes more time. And for some resections, but also for, let's say, skull-based meningiomas, I put him into the intraoperative MRI. But then I realized that, okay, I see in the petroclival area there is still tumor. But when you look back in, you simply can't remove it without adding enormous morbidity. And that was the thing that you would more or less already say in vestibular schwannomas. Yeah, I can see there is a remnant close to the facial nerve. I already see it intraoperatively, but I decided, because the signals were still very good, I wanted to leave it that way. So we stopped doing those cases.
Can I just say, if that's okay, sort of, I think just a small point. I know that what you call Miguel with the chairmanship of the WFNS Foundation. Could I please ask you to just for 5 minutes talk about the foundation to those who are here, so the message gets spread, what you do, what you can do, how you can do. I know Professor Groton is now the chairman of the European Foundation. Believe me, I am behind you. I have got a cunning plan cooked up. I'm just waiting for the COVID to finish. What do you call? But so I will just first of all, to be, I just mentioned to Miguel, Professor Grotonius, you wouldn't believe, now I can simultaneously stream in Facebook, YouTube, and LinkedIn. And this just, as I said, if good old Alexander, Great had this ability, he would have never left Macedonia. He would have stayed home and just done this. I mean, the reach is just unbelievable. I mean, it's just mind-boggling how the technology just has gone from, within 1 year, the technology, I can't imagine where we are going to be in 5 years. So the reach is just incredible. And and I think this COVID is, I wish it never was here, but I think in terms of medical education, I think it's going to have in 10, 15 years time, I think you are going to see that this has a huge impact on global medicine and neurosurgery. So I'm sure that every other specialty is carrying.
Fully agree. Yes.
So what I will do is that although your lecture starts, Miguel, in 5 minutes or 4 minutes, but if I could just ask you to give an ad lib about your foundation, just to mention, Miguel, your audio is slightly breaking, so I'm going to stop my video, and if I could ask Professor Grotonius and Daniel to just stop the video, and Miguel, maybe that when you are giving the talk, we'll see how the audio goes when we stop our video, but when you are giving the talk, maybe you might want, I'll let you know if you need to stop your video just to get the audio great. But so welcome.
I will also mute and stop video.
Great, thanks. So welcome to Miguel, you keep your video for the moment, please. Thanks.
Sure.
Great, thanks. Welcome to the late morning session of the World Neurosurgery Webinar Conference. This is our third day, and we have a fantastic session ahead of us. We have got Professor Miguel Arez. He's the professor and chairman of Department of Neurosurgery in Malaga. He is former president of the Spanish Neurosurgery Society. He was the chairman of all the committees of the WFNS in the previous cycle, and now currently the chair of the WFNS Foundation. I'm going to invite Professor Miguel Arez to just give 5 minutes on what is WFNS Foundation. Certainly, WFNS Foundation has been exceptionally helpful to the listserv when we started our webinar courses, and also the international neurosurgery course we ran. So, thank you very much, Professor Arez. But I've visited his department 3 times, and as a surgeon, he's fabulous. You will see his operative videos. But I tell you, like with Professor Grotenius, and yesterday I mentioned to you about Professor Hugus Dufu, and when you see his residents, how they are with Miguel Arez, this is a family. They are, they feel at home. They are inspired by the man. It's not a hierarchy, and it really is something to learn from. So, Professor Arez, could I please first of all ask you to give us a 5-minute synopsis on the world, the foundation of what is WFNS Foundation and what it does, and then we'll go to your lecture. Thank you, sir.
Thank you very much, Enar, and thank you first of all for the kind invitation to take part of this wonderful international symposium, and thank you also for giving me the opportunity to mention something about WFNS Foundation. The WFNS, World Federation of Neurosurgical Societies, everybody knows about it, is the association of societies that are gathering, we can say, all the neurosurgeons and all the societies all around the world. It's a complex organization because it's gathering the richest societies, the poorest societies, north, south, all religions, or everything is included in this, association. More than 20 years ago, the WFNS Foundation was created under the initiative of Professor Sami and also Professor Martin Rodriguez from Spain, who is a lovely person, now retired, but it has been working very hard for the federation and for the foundation. They initiate the foundation, and after that, Dr. Armando Basso from Argentina, also past president of WFNS, has been chairing the foundation over the last year. After that, I took over, and I've been very proud, and I'm very happy trying to contribute. What is WFNS Foundation doing? WFNS Foundation has 2 main goals. One of them is in regard to education and training, basically related to developing countries and developing areas all around the world. We have such areas in Central America and some part of Latin America, South America. We have some areas in the east part of Europe, and also Africa is the largest area with more countries and societies in need. Also, some areas of Asia are also the target for WFNS Foundation purposes. So one of the targets is regarding education and training. Regarding that, there is a WFNS committee, Education and Training Committee, that nowadays chaired by Isabel Germano, and WFNS Foundation Educational Committee is organizing courses in developing countries, trying to put their big professor, prominent professor, just do not only theoretical lecture, but also hands-on courses. And this is one of the ways WFNS Foundation is trying to contribute to education. There is another aspect regarding education, very important, in the hands of the training center. We have two main categories of training center. One of them are called full training program training center or reference training center. So we have several centers, one of them in Rabat, that was the first one, some other in Africa, Latin America, and Asia, where young neurosurgeons from developing countries are there to receive a full cycle training in neurosurgery. The scholarship for that is paid by the foundation, and after this 5-year cycle, the trainees are going back to their country of origin just to contribute to develop neurosurgery and in many cases to create neurosurgery in large areas with millions of people without neurosurgical assistance. So we create those centers in that way, first of all, educating young colleagues from developing areas. We have a second category of training center that are called postgraduate training center. We are very proud to have one of them in Malaga. You have a basic requirement for that. You have to be a center qualified in your country in order to be able to train neurosurgeons. And second, you have to make some big effort in the sense of contributing to accommodation and food for the trainee who is going to spend a variable period, something between 2 and 6 months. We also try to provide some scholarship in Malaga. I was telling Maren, who knows very well our department and our way of trying to do things in that aspect I'm commenting, that we have created recently a chair for developing of neurosurgery, and we try to get some funds for the young colleagues that are coming from some areas all around the world. So we have a network of around 30 centers that has this commitment with the foundation in order to provide that education for a period of time that is varying between 2 months and 6 months, contributing with accommodation and food, because otherwise for people coming from poor areas, it is not possible to survive in Europe or America and some other expensive areas. This is a basic aspect regarding education. And we also have another aspect, another target in WFNS Foundation, that is the interest to contribute to improve the neurosurgical armamentarium in poor countries. In that way, we donate instruments and we donate equipment. What kind of equipment? Microscope, thanks to the generosity of SACE, who is putting in a very low price microscope, the Pico microscope, to be bought by the foundation and to be distributed in target areas. We also distribute bipolar, we also distribute drills, we also distribute stored endoscopes and basic instruments regarding craniotomy and spinal operation. We just have some policy, and in that policy, the second vice president, I'm very happy, Professor Grotenius is among us because he's second vice president for Europe in the WFNS Foundation structure, and they are taking a very important, they are going to have a very important role in the policy regarding the decision and the criteria just to distribute that equipment that are expensive, and of course with a limited number of equipment. So I like to make a comment regarding the philosophy of the foundation in the way of creating center where no neurosurgical structure was before. So we create, I put some example, Mombasa in Kenya has a 5 million inhabitants area without 5 million inhabitant area without any neurosurgical care. We have the Mombasa Coastal Hospital, a general hospital without neurosurgery. One of the fellows was trained in Nairobi under Dr. Qureshi direction, and after 5 years he went to Mombasa to create the unit at the Mombasa Coastal Hospital. Foundation did provide microscope, drill, instrument, bipolar, and so on. So we have created a neurosurgical unit in this particular example in Mombasa. So this is the way we are trying to do things. This is not so simple. We need some structure that we have been created and let's say amplificating. We have a global neurosurgical committee that is nowadays directed by, is chaired by Dr. Kipar and Dr. El Wahabi from Morocco. We have another committee that is a fundraising committee. We have another committee of liaison with WHO. We have some infrastructure trying to finally go to those basic aspects as education in developing countries and provision of neurosurgical equipment are. This is basically what we are doing, and we are very much willing to have people, commit people with those targets. I'm very happy to hear about any comment or any issue. You can go to wfns.org, that is our website. You have all the info regarding the training center and the possibility to contribute. Naren, thank you for giving me this opportunity to mention something about WFNS activities.
Thank you very much, Professor Aras, and I hope to at the end of this session to get Professor Grottenhuis, who is the president of the EANS Foundation, to see what his plans are for the EANS. So again, it gives me a great privilege and honor to have Professor Miguel Aras. It is I have known him now for 10 years, and as I said, I have visited his department and I've seen his surgery. And he's a master surgeon, and he's going to talk to us about adult brainstem surgery. He's one of those speakers who will engage you from the beginning to end with this talk, with this surgery. So it's going to be a riveting session. Thank you, sir.
Thank you very much, Naren. Again, I'm going to share my screen.
I'll just make sure that I've got that.
You have to allow me to go.
Yeah, you can. Sorry about it. Yeah.
Thank you so much. So,
as I mentioned, that this is the first, to my knowledge, a neurosurgery webinar that's going live on not only in this webinar, but in Facebook, as well as YouTube, and as well as LinkedIn. So, it is a momentous talk in many ways than one. Thank you, Professor Aras.
Thank you very much, Naren. Again, I'm going to start my talk. I hope you can hear me and also see my screen. My topics will be about the treatment of adult brainstem tumors. And unlike children, brainstem tumor in adult is basically related to brainstem cavernoma. Some outline regarding brainstem cavernoma. We have to mention that 30%, 1 out of every 3 cases of cavernoma is going to be located at the posterior fossa and brainstem. One crucial issue is the rate of bleeding. It's not very high, but once the cavernoma has bled, the rate of the rebleeding, we consider that high because it's no less than 30%. It's also very important the concept of hemorrhage, because the main indication for the treatment of cavernoma is hemorrhage, not the only one, sometimes because of the mass effect, or sometimes in some instances because of growing of the lesion. But going back to the concept of hemorrhage, we have to see evidence of blood, not only inside cavernoma, that is something very frequent, but also outside of the cavernoma. And very important to combine that issue with the onset, usually acute onset, and also the existence of neurological deficit. We have to go to the indication for surgery because this kind of operation, brainstem surgery for adult cavernoma, is very rewarding. But if you keep several rules, one of them is the appropriate indication for surgery, basically acute extralesional hemorrhage and or mass effect, repeated hemorrhage and clinical deterioration. But we have to mention something more regarding indication for surgery. We have to take into account the good indication for surgery. First or second symptomatic hemorrhage, recurrent hemorrhages, as we have mentioned, lesion at the medullary area that are very prone to provoke a disaster and the death of the patient, exophytic lesion that can be somewhat easier than lesion inside brainstem, of course, mass effect with deterioration of the consciousness, big size, severe and or progressive neurological dysfunction. But along with the good indication for surgery, we have to take into account the bad indication for surgery. Patient with no symptoms or few symptoms. Majorly, if it is combined with a small and or deep lesion, not easy to be accessed and removed. This is a terrible combination for the patient because you will make this, you will convert this procedure and your choice in a disaster for the patient. Minor hemorrhages with rapid improvement, asymptomatic lesion, or lesion located in the area below the foreventricle, that is to say the medullary region, because this is a very sensitive area. Here we see good indication when the patient is deteriorating or repeated hemorrhages, and we will have the worst indication there because we can kill the patient if the lesion is small and without symptoms. Regarding our goal in the operation, the goal of the operation is the total removal of the lesion. Because if not, 50% of the patient, we will rebleed after a certain period of time. And regarding the general outlook and the general perspective after resection, this is an analysis of more than 700 patients gathered from 45 studies. 85% of the patients are in the same condition or even improve after the operation. A little less than 15% of the patients were worse before, after surgery, and almost 2% of the patients may die due to complication after the operation. This is more or less the robot picture. And we will deal regarding brainstem cavernoma with the surgical indication. That is the number one issue, as I mentioned before. We will make some comment about the timing that is important in order to get the best possible result. And from the technical point of view, more and more the concept of safe entry zone has been coined in the medical literature. And to carry out a safe removal, we have to take into account the safe entry zone, that is to say where we should get inside brainstem without provoking morbidity, and also some important issues as like the situation in the supratentorial cavernoma, the plane between the lesion and the normal tissue is absolutely crucial. So we will, after saying that, we have to take into account the location, the exact location at the MRI, beautiful MRI, usually showing where the lesion is and how close to the surface of the brainstem, because one of the principles is getting inside the safe entry zone. We will deal with that in my presentation. But the other concept is just to try to remove the lesion, entering where the lesion is abutting the pile surface of the brainstem. Needless to mention how important intraoperative monitoring is. We have the classical techniques, done in many operations, and we have to add monitoring of the mapping of the foreventricle, and we will see a couple of examples. We will go over the different areas. We will start with the medullary region, lower medullary region, posterior approach. We have to do a suboccipital craniotomy, as we all know, and we have several possible entry zones. In the same way as in intramedullary tumor at the spinal cord, we have the posterior median fissure. We have also the posterior lateral sulcus and posterior intermediate sulcus. Basically, we will try to remove the lesion at the posterior medullary fissure, and we can have one of these examples. This is a young patient, sudden tetraplegia and respiratory arrest. This is the MRI done in the ultra early moment with the blood completely black in this moment, and the way we can just make the operation in the same way as in intramedullary tumor. I will go forward. We have to go through this posterior intermediate sulcus and just debulk the lesion and trying to find the clean plane we can see over here that is announcing that we will have a good postoperative course. This is the postoperative MRI, very satisfactory, and also the patient went very well and was discharged 3 weeks after the operation, just walking and breathing by herself in a very satisfactory context. We have here another example. This is a clear indication for surgery. This is a patient, 43 years old, transient hemiparesis. See the lesion at the medullary, pontomedullary region, and the patient had 1 month later tetraplegia and respiratory arrest. This is a clear indication for surgery, and this is some step of the approach. And I like to call the attention of this very clean plane in between the tumor and the normal brainstem tissue. This is a very important step in the operation, trying to preserve and trying to be fortunate to find that nice view. Because in some cases, and regarding to the timing, we can have a different problem, and we will mention about that in one of the forthcoming examples. This is the postoperative MRI. The patient recovered little by little, and this is a very satisfactory result. Good indication for surgery. The patient just rebled 1 month after the initial one. It is clear that we have to do something. This is a good indication and good result, not difficult operation. Ventral medullary region is completely different. Safe entry zone, that is the retro between the exit of the 12. There is some noise somewhere. Okay, so between the exit of the glossopharyngeal nerve and first root. For some cases, we have to do okay.
Thanks.
So you can hear me?
Thanks.
See my screen?
Yeah.
Well, this is one of these examples. See this exophytic lesion, that is a good indication. And this is a far lateral approach. Okay. And the way we can expose the lesion in that way, very easy to be removed. The lesion sometimes need a complex, if it's very anterior, you will need some transcondylar far lateral approach. In that case, we managed to remove the exophytic component, and we also took advantage of endoscopy just to have a look to the ventral part of the medullary region, as you can see in this video, trying to be sure. We have this structure. We interpret that as some venous anomaly along with the lesion, and this is the postoperative MRI with this funny image and the tubular normal appearance of the medullary region. If we go to the pontine anatomy and we look for a safe approach, posterior safe approach, we have to, of course, use the fourth ventricle. We have the median sulcus, again, that is a safe entry zone, and we have to keep in mind the supra and infra facial triangle. We have that way to avoid the fibers of the sixth and seventh nerve, and we can have some very important help by means of the mapping of the fourth ventricle. We have to, of course, do again a suboccipital craniotomy. In cases like this one, you can see this exophytic lesion, several stages of hemorrhage, a patient with transient and progressive diplopia, and enlargement of the lesion, and the way of exposing that. The lesion, we don't need any safe entry zone. The lesion itself is self-exposed. We have to follow the principle of debulking of the tumor because, as customary in neurosurgery, this is the way we can work in a more safe way, trying to find the plane between the tumor, whatever the tumor is, and the normal brain tissue. This is, I like very much this dissector and the way you can identify and preserve the tissue. Keep in mind that sometimes this racemose lesion may have some part of the lesion that could be left behind. Look at this big part of the tumor embedded inside the brainstem, and the way you can remove that, and the way you could leave behind that part of the tumor. So our goal of diminishing to zero the rate of rebleeding is not achieved. This is fourth ventricle, and this is the tumoral bed inside brainstem, and this is the postoperative MRI with satisfactory result. This is the patient, and this is the picture. The patient is an artist, and this is the painting with his conception about what his cavernoma was. I have that nice picture in that nice painting at home. So this is another patient, 28 years old, 2 episodes of brainstem bleeding, hemiparesis, left sixth nerve palsy, 2 episodes in a very short period of time. Clear indication for surgery. The lesion is abutting the fourth ventricle, and this is the way we have to get inside. It seems to have 2 intermediate sulcus. Sometimes it's not easy to make the choice of the best entry point, and intraoperative mapping may help. This is the way we just try to open the posterior median sulcus. I try to use cottonoid to protect in as much as possible. And going forward, you can see just bottom right, the clean plane in between the tumor and normal tissue. And this is the patient several months after the operation with pretty good postoperative MRI and result. Some tremor. The patient was very much disabled due to hemiparesis and diplopia. And the patient now is doing a normal life with a small limitation. Pontomedullary region, what to do with a lesion like this one? This is the anatomical point, taking advantage of the beautiful anatomical preparation of Pablo Gonzalez and his colleagues in Alicante, wonderful anatomical lab. I'm very much grateful for the anatomical specimen they provide to me. This is the location of the lesion. We have to make the choice how to get inside the brainstem. We have several possibilities. One of them, the fourth ventricle, you can see here. But if you have several possibilities, try to avoid brainstem entrance through the fourth ventricle because it has a potential morbidity. And on the contrary, the patient was approached through the simple retrosigmoid approach. This is 7 and 8, this is 9, this is 10, and in between, retrosigmoid approach, basilar artery, and the way of retracting, I use this small spatula. This is the lesion, and we won't see any clear plane after the removal of the lesion. You can see here that we don't see a very nice white or yellow appearance. So we remove the lesion. This is a postoperative MRI, that's okay. But the patient impaired her previous, was a lady, her previous situation with increased hemiparesis, sixth nerve palsy, and dysphagia. And it was due to the timing of the operation. We have to make the choice of the proper time, because if we delay very much the operation, and this patient was at the waiting list, waiting too much, we will have several episodes of microbleeding, and we will get some gliotic plane around the tumor that precludes a clean operation and the preservation of the delicate tissue in very small volume of CNS tissue as this one. So we have to avoid that. We have to avoid an excessive delay in the operation, but also on the contrary, we have to avoid the operation in the ultra early moment of bleeding. But sometimes we have to do surgery in acute stage. This is a patient, young patient, see this lesion inside the pontine region. We just see that the closest surface to approach the lesion is the fourth ventricle, no other around the lesion. And we went through the fourth ventricle. The patient has a bleeding, and the day after did deteriorate. We took the patient to the operating room in emergency basis. The lesion was bleeding like a real AVM. It was a nightmare, just coagulating and working inside pontine region. We managed to control the situation, remove the lesion, the patient can round, but look, the postoperative MRI with some remnant over there that is announcing that we have to follow very closely this patient, because some rebleeding may happen over time. This is the patient. Now it was several years ago. The patient did not have any other episode, but we have to very much closely follow the patient. This is another patient, 24 years old, a female, young patient with sixth nerve palsy, diplopia. You can see this lesion. We were discussing first episode, only sixth nerve palsy. We just discussed with the patient and her mother. Finally, we decided to do the operation, because they were very much scared of further bleeding. And we just scheduled the operation. But in the meantime, just 1 week before the operation, the patient was admitted due to impairment of diplopia and hemiparesis. And 4 or 5 years after this bleeding, cardiac arrest did coma tetraparesis. See this patient, and we took the patient to the operating room and removed the lesion, fortunately, completely, as we can see in this scan. I don't have the MRI, but the lesion has been completely removed. So what about the timing? What is in summary, what is the best moment for the operation? There are several publications concerning that important point, but we just gathered that within 6 weeks after the bleeding could be the appropriate moment for the removal, the safest moment to remove the lesion and to find this very good clean plane that is absolutely beneficial for the outcome of the patient. Cerebellar peduncles are also a matter of interest. This is a young patient. You can see the venous anomaly that frequently is accompanying the cavernoma. We don't have to do anything about that. Everybody knows that. But this patient had several episodes of bleeding. A young patient, 16 years old patient. We have several possibilities: retrosigmoid approach, transcerebellomedullaris approach, fourth ventricle approach. In that patient, we gathered that fourth ventricle could be the easiest one. And you can see the way we did expose mapping. This is the lateral recess, more or less over here, the lateral recess of the fourth ventricle, and just escaping with a small maneuver and trying to avoid the fibers of the 7th and 6th nerve. And the way you can see this black appearing just right underneath, we could find the hematoma and the cavernoma. I will move forward. This is the way we try to elongate the fibers, and the way of finding, in that case, a clean plane and removal of cavernoma. This is after removal, and this is the MRI and the patient just 3 days after the operation with a pretty good result. Some tremor that the patient had before and some diplopia, but there is no sixth nerve palsy. There is no major facial nerve deficit, and the patient did well and recovered little by little. I have to mention that those operations are challenging, of course, but if we do we just are working under a good indication, operations are really, really, really rewarding for the patient and for the team. Inferior cerebellar peduncle, see this lesion. We could go through the fourth ventricle, but the lesion is just beside. And if we look at this MRI, just at the bottom, this is the lesion. The lesion is not exactly put in the fourth ventricle, and we have some way over here just to get inside the inferior cerebellar peduncle. And I like to, this is the clinical picture of a young patient, loss of balance, diplopia, and I just recommend, highly recommend the writings and the publication of Dr. Kawashima and Dr. Matsushima, transcerebellomedullary fissure approach with a special reference to lateral root. You can see the way you can just dissecting the area of the cerebellomedullary fissure, and you can just, without damaging the fibers, you can get beside the area of the lateral recess of the fourth ventricle, that is to say, just to approach the inferior cerebellar peduncle. By the way, in this case, areas of hemorrhage, fibrin, no tumor. I like to mention that sometimes we have the classical histology and we have some prediction of the possibility of cavernoma, the most frequent adult brainstem tumor approach. In some other miscellaneous cases, we don't have any idea about the histology, and we don't have to presume that it's a cavernoma, either cavernoma or a glioma, because there are many other possibilities. In that case, a very enigmatic lesion that was removed, and no abnormal neoplastic tissue was found. Pontine region, the ventral pontine region. We have the peritrigeminal area and also a safe area in the exit, in between the exit of the 5th and 7th and 8th nerves. We can have the anatomical explanation for that in this wonderful presentation from the Alicante group in Spain. This is the exit of the 5th nerve. These are the fibers, the corticospinal fibers that are here, as you can see, in this loosened distribution, disposition, and we have some area that is in between the 5th nerve and the corticospinal tract. This is the peritrigeminal area and is a safe entry zone in order to avoid any damage to the corticospinal tract. We can get that area by means of presigmoid approach, transpetus approach, retrosigmoid approach. I like to make some short comment because we are all very much in favor of endoscopy. I do love endoscopy. I have tomorrow 2 cases, but this is just mainly addressed to the youngest colleagues in the audience. We have to keep in mind, if you want to do certain kind of operation in neurosurgery, to classical open skull-based techniques, transpetus approaches, presigmoid approaches in your armamentarium. This is a patient. You can see this lesion. big lesion growing little by little. You can see the lesion nearby fourth ventricle, but also the lesion is near the lateral surface of the pontine region. As mentioned before, we have to try to avoid the fourth ventricle. In that case, the shortest and direct way is the presigmoid route, as you can see in the right. You can see we are just cutting the inferior part of the temporal lobe. The left spatula is reflecting cerebellum. We just did cut tentorium, and we are just see the Dandy vein complex. And this is the fifth nerve. This is the best way and the shortest way to get the fifth nerve and the peritrigeminal area, as you can see here. And the way we make some small incision, and unlike supratentorial cavernoma, we don't do linear incision. We try to make a small opening and some elongation. And this is the case. Time-consuming operation, a short period of time to remove this easy cavernoma. And you can see the reconstruction with fat graft, and you can see the root of the peritrigeminal area. And this tissue, after releasing the pressure of the tumor, showing that the tumor is not abutting the fourth ventricle. We have some compression of fibers and nuclei, but the best way, in my opinion, in that case was this lateral aspect. See this other, this case. This is a patient, anterolateral pontine region cavernoma. We can do transpetrous, you can do presigmoid, but for those cases, we have been more and more moving toward retrosigmoid approach, the simple and wonderful neurosurgical strategy for the CP angle. You can see the fifth nerve, this is 7 and 8, and the way, this is not real time, but almost a small opening, identification of the tumor, very clean plane at the end, very easy case by means of this retrosigmoid approach. This is the postoperative MRI showing the result. And let's mention that irrespective of how big the lesion is and how complex, retrosigmoid approach is a very good one. This is a patient with cavernomatosis. See this other lesion. This is a long-standing tumor. You can see the progressive growing over the years in this patient in the mid-50s. Several stages of bleeding, gliotic plane over here, difficult lesion in summary. But no matter how big or how complex the lesion is, retrosigmoid approach is very good. This is the entrance and exposure of the lesion. This is after removal. Sorry for the quality and distortion because it's taken from a 3D video. And you can see the MRI on the right. This is with contrast, no lesion over here. And this is the patient at the immediate postoperative period during his admittance, and this is the patient. The patient was living far from Andalusia, and he sent several months after the operation this clip with the right side working very well at the gym. Mesencephalon is the last part of our trip, and we have to mention that the anterolateral mesencephalon, this is more or less over here, has only one safe entry zone, that is the lateral mesencephalic sulcus. But for anterolateral lesion like this one, we can do a subtemporal approach, and it has been described, the COC approach, as you can see here, trying to basically assist the aim always in skull-base surgery, working very hard with the bone, sometimes time-consuming operation, but trying to improve the entrance, the angle, and diminish the retraction of neural structures. But for cases like this one, subtemporal approach, we just do some limited instead of the time-consuming and morbidity-provoking COC approach, we do this limited zygomatic osteotomy because the aim is just only reflect downward the temporal muscle, improving the angle of retraction of the temporal lobe. We can see this is a fixation with microplates, very easy. This is a 16-year-old patient with progressive hemiparesis. You can see this mesencephalopontine region, solidocystic lesion, indication for surgery. You can see right side, spatula is reflecting the temporal lobe. You can do this movement, lifting up the temporal lobe that is very well tolerated. And this is tentorial incisura, this is carotid artery, this is PCAM. By definition, if this is the third nerve, this is the posterior cerebral artery, superior cerebellar artery, and the way, of exposing the lesion is abutting the surface, as you can see here. Very easy operation, clean plain cystic area, but the patient, after this nice postoperative MRI, but the patient immediately after the operation became hemiplegic with a dense hemiplegia. This is the patient several months after the operation, fortunately with partial but good recovery. The patient is a piano player, and he sent 9 months after the operation this video, playing perfectly well piano. And on the right side, you can see the explanation why mesencephalic area is so risky. This is the corticospinal tract, and you can see the loosened distribution here at the pontine region, but unlike that, at the mesencephalic area, we have this dense corticospinal tract. So any manipulation there may provoke contralateral hemiplegia. This is another case at the mesencephalon. The patient came after episode of tremor, instability, difficulty to walk, and slight tetraparesis. It was reported as cavernoma by radiology. We weren't sure about that, of course, because we didn't see any clear image of chronic depot of blood inside or around. But the patient came back after conservative treatment because of impairment. You can see the tractography, you can see the lesion. Maybe this is where the lesion is abutting the brainstem, but yet we have perforator and we have the basilar artery. And for this case that had, I just avoid the initial MRI, that the lesion increased in its size. And we just took advantage of another safe entry zone, the infracollicular area. And by means of a very simple sub-occipital transtentorial approach, we managed to avoid the tectal plate and at the inferior aspect, just get inside. This is a tentorial, transtentorial, sub-occipital approach. We are at the right side. This is the exit of the fourth nerve, very seldom seen in our approaches, some staining over here, and the way of, this is the tentorium after having been cut, and this is the way we make this small opening, bottom left, after removal, bloody lesion with some vessels, and see this frightening view. This is from posterior, and after a resection of the tumor did follow us took us to the basilar bifurcation, as you can see here. This is bottom right inferior aspect of the tectal plate and the view of the cervical field. This is the patient that in the immediate postoperative period did bleed, and we took the patient to the operating room, removed the clot, and the patient came round. And this is the final MRI. This is a frightening view. Mesencephalon has disappeared, but we are just seeing the midline. And the patient now is disabled due to the previous tetraparesis and tremor. And the patient has also bilateral third nerve palsy that is partial but very much disables him. Histology, melanocytic tumor, benign tumor. As I mentioned before, we have to take into account that histology could be, quite variable inside the brainstem. Cavernoma is one of the possibilities, but not always. I'm talking about infiltrative lesion. This is not my main topic in this talk. We don't have to assume in all the cases that we are dealing with glioma, because there are many other possibilities, and some publication regarding biopsy at the brainstem showed that no less than 10% of the cases are not even tumor. When we go to the posterior mesencephalum, the tectum, we had the cerebellomesencephalic sulcus. This is a patient, 62 years old, with episode of diplopia. See the lesion, very easy lesion. You can see the approach, and you can see why sometimes the cavernoma is bleeding so much. This is one of the feeders. You can see the disparity between the caliber of the vessel and the size of the lesion. And top on right, you can see how that way we could remove the lesion in toto and see the very clean plane around that is pointing out toward a positive postoperative result. This is the MRI after the procedure, and this is the patient during admittance. The patient after the operation still had some limitation of the upward gaze that had before the operation, but in summary, we consider that a very good postoperative result. Last part of my talk is concerning, to my mind, to one of the most difficult areas at the brainstem. This is a lesion that is not posterior, this is not anterior, this is not abutting toward the surface. In cases like that, we have to look for the for the lateral mesencephalic sulcus. This is a very well described area. It's a safe entry zone for lesion like this one. This is one of the publications for the group of Professor Spessler. This is one of the possibilities, extreme lateral supracerebellar infratentorial approach to the posterolateral mesencephalum. Basically, we have to do a posterior fossa suboccipital craniotomy. We have to expose transverse sinus. Sagittal sinus is not necessary to do that, but we have to do this sort of osteotomy that will allow us just to lift upward tentorium, trying to improve our approach. We are at the right side. This is the Vermian region. Right side, occipital lobe is displaced. To do that, you have to cut tentorium from below. And this is the way you can reflect the occipital lobe. The anatomical disposition of the tentorium is not much, has not been much described in the medical literature, neuroanatomical literature, but it's quite variable. Sometimes you have to cut from below the tentorium to display occipital lobe, sometimes not. In any way, we have here the lateral mesencephalic vein, that is the anatomical landmark of the lateral mesencephalic sulcus. This is the superior cerebellar artery getting divided. I'm just looking for the surface of the cerebellar region after completing, after ending the perimesencephalic segment. And this is the lesion almost itself exposed. And you can see here the easy way of exposing the lesion and removing the tumor, as you see bottom left. And histology, pilocytic astrocytoma. This is the wife of an orthopedic surgeon, very close friend of mine. The patient had been diagnosed at the MRI of malignant glioma, nothing to do, and so and so. But we just, young patient, we just decided to do the operation. and just fortunately histology was pilocytic astrocytoma. For unknown reason, spectroscopy has a very limited reliability when talking about brainstem tumor, and I do encourage to get histology, trying to remove lesion if it is reasonable, and or at least have histology. This is another patient with diagnosed, young patient in the mid-40s with a diagnosis of malignant astrocytoma. Same region as you can see here. See this funny image with a vessel, and the way we have to do the same approach. The lesion actually was bleeding like a real AVM, and you can see the postoperative MRI with pretty satisfactory result. See the complex area because this is just underneath thalamic area and so, and histology vascular malformation and some gliotic tissue around without evidence of neoplasm. This is the patient. The operation was quite difficult. This is why the patient had some impairment of her previous hemiparesis. You can see the patient several months after the operation, and you can see good postoperative result after some minor ophthalmological operation regarding some diplopia. So very satisfactory result. And this is the last example that is for the youngest colleagues in the audience. This is a patient sent to us because of the possibility of some astrocytic tumor at the medullary region. See growing of this area and change of the MRI image, and see the cavernoma here. The patient was complaining of progressive dysphagia, and the patient was sent for removal and evaluation of this possible associated lesion. But we just very careful examine the patient. We have to do that in every patient. We have to do a very careful clinical history, clinical examination and evaluation of the patient. And when doing that, so what we found, this is the tongue, this is the palatal area, and this chronic continuous movement is a palatal neoclonus. See the lesion, by the way, near the red nucleus. That is a very sensitive area to touch and to manage. And going back to the clinical finding, palatal neoclonus, that is pathognomonic of this situation, hypertrophic olivary degeneration, frequently secondary to punctine hemorrhage, but any lesion interrupting the dentato-rubro-olivary pathway, that is the Guillain-Mollaret triangle, is, enough to provoke the symptoms we have seen before and the palatal myoclonus. So, in summary, no indication for surgery, no bleeding outside the cavernoma. We wouldn't have improved the situation of the patient, and on the contrary, we have put the life of the patient at risk doing this operation in that sensitive area without any further improvement. So that this patient is under conservative treatment. And the last slide to be inside the time frame, surgical approaches to brainstem tumors in adults, anatomical definition of the lesion by means of the MRI, and also we have the knowledge of anatomy. Very important, the concept of safe entry zone, the choice of the best surgical approach, and the delicate microsurgical technique. That is one of the points that has to define the activity, the surgical activity of a neurosurgeon is the 4th point to be emphasized when dealing with brainstem tumors. This is the summary of my presentation. There are many nuances regarding brainstem tumor. I'm fully open for discussion and question. And as always, very grateful to Naren for the kind invitation to take part in this wonderful educational activity. My congratulations, Naren, because your endless and tireless activity all around the world in education is absolutely outstanding and with clear exemplarity. And thank you for your friendship, waiting for you and the other friends to be host here in the beautiful Malaga. Thank you very much.
Thank you very much, Professor Aras. That was a wonderful lecture taking us through the different brainstem gliomas and elegantly showing how to tackle them. I've got a couple of questions for you. I'm going to bring the my microphone, not microscope, I suppose. Dr. Alexandra Pabiniak, do you want to unmute your microphone and ask the question? Otherwise, I can't ask it. So what I will do is I'll ask it for him. So he's asking, do you frequently have postoperative CSF leak, and how do you prevent it?
Well, it depends on the approach you do. If you are doing the COC, the closure of dura is not a matter of concern. But many of the operations are done through the posterior fossa and CP angle. Well, basically, there are several policies. Professor Spessler group just put spinal drainage before the operation, open it, and keep that after the operation for few days. We don't do that. We don't do if we have to release a structure, we just open cistern and whatever. And we do not ordinarily put spinal drainage. What I do for the closure is by all means watertight closure that at the retrosigmoid approach include taking, we do usually a small craniotomy as everybody, we have some limited opening and we take advantage of some fascia, muscle and fat with the stitches, trying to have a very watertight suture. I'm very much obsessive about investing time in the closure of the operation, because if you want to save time in the operation, you want to save 15 minutes or 10 minutes in the closure, putting some alien material or wherever, you will pay tribute to that bad practice, having the patient complicated for maybe one more week or one more month or whatever. If we are talking about midline, I take advantage of the opportunity that the midline offers, and I'm very much a follower of the nuchal ligament. Nuchal ligament at the midline is amazingly good because of several issues. One of them, you have two layers. There are several anatomical studies about that, one of them from Professor Al-Mefti. If you go to midline, you have two layers. In between, you have some fat, and you can get something like an open book, and this is good enough to fill any defect after your approach, whatever the size of the and defect you can have after the operation. And on top of that, this tissue is very thick. So if you have a thick tissue and you have a thin dura mater, you can put thick tissue around and giving stitches, you can have a wonderful watertight suture. These are my strategies trying to prevent CSF leakage after, let's say, the two main approaches for brainstem tumors are midline approach or paramedian infratentorial approach and retrosigmoid approach.
Thank you, Professor Aras. I think just one comment. One of my senior colleagues, Mr. Girish Salanki, when he closes dura, when it's very tight, as we do so many pediatric posterior fossa cases, and he does it for the spines as well. I didn't initially think it will work, but it absolutely, I haven't seen any CSF leak within maybe 1 in 2 years, is that he puts the dura gen, actually rather than rather than tying side to side, what he does is he puts it in between the defect, and then as he closes, he catches the both ends on top and bottom, and so it becomes kind of a as much like a cement in between the dura, and it actually is, works absolutely fine. So this, with the suture he does catch the duragen, but rather than side to side, just that putting it in between and closing it, it nicely does the job as well. There's another question from Dr. Harshad Parak from Mumbai. Dr. Parak, do you want to ask the question, sir?
Yes, Professor. It's an excellent talk, Professor, you have given on the brainstem tumors. Various approaches have been described very beautifully and presented. My question to you is, when you are doing a supracerebellar, whether extreme lateral or a midline approach, going to the brainstem or to the pineal region, do you sacrifice the supracerebral veins which are attached to the tentorium while getting the cerebellar down, or how do you preserve it if you want to?
Well, actually, your approach usually doesn't need to sacrifice supracerebral veins that very frequently are sacrificed without any complication. But taking
Right.
into account that if this is the Birmingham area, we don't go midline, we go very, very, very lateral and paramedian. So we go
Right.
in that lateral route instead of this direct route to we can consider the pineal region. Pineal region we would go that way, but for the paramedian approach to the lateral mesencephalon, we need the most lateral, almost perpendicular route you can get. This is why you have to divide the tentorium in order to more reflect the occipital lobe and get lateral.
Right. Do you use endoscope most of the time?
Usually not.
Not. Okay.
We use the endoscope in certain cases. I have shown one example, just having a look to the anterior part of the medullary region, because the lesion in that case, because the lesion was basically anterior. For anterior lesion of the medullary region, you need a far lateral transcondylar approach.
Right.
No way. But in that case, the lesion was exophytic, and I managed to remove the lesion from lateral and posterior, but I couldn't see the anterior surface of the brain.
Right.
Reason why I use the endoscope. But usually in that case, maybe one of the rare instances I have used the endoscope. Usually microscope is good enough.
Do you recommend contralateral approach or the same side approach?
For what? What kind of
For
lesion?
the thalamic lesions or subthalamic lesions, do you advise contralateral approach or the same side approach?
Same side
Same
approach.
side. Right.
Because
Because,
we have to follow the principle that the lesion has to be approached near to the shortest distance to the surface of the brainstem.
right. Right.
Thank you very
Thank
much.
you very much.
Thank you.
Excellent. Excellent.
Thank
Thank you,
you.
Dr. Parak. Professor Aikananjali, do you have any comments? Thanks.
Yes. Hola, Miguel. Good Sunday. Good Sunday to all, of course. No, you say that we have to operate. It's suggested to operate within 6 weeks. But we found that it's even easier, very early operation because of the hemorrhage. If you have the hemorrhage already displaced the fibers. So almost the approach before the hemorrhage resorb could be easy. What do you think about this?
First of all, my very best regard, Mauricio, my very good friend in Ancona, and I completely agree with you. The time frame of 6 weeks could be considered. Weeks more or less the limit. But I do agree that the sooner you do the operation, the more fresh the blood you will have, less sticky planes, and so and so. But I am against, because of bad experience, and the literature is along with this idea, I'm against doing the operation in the initial nightmare period of the bleeding of brainstem cavernoma, because of the situation of the patient, unstable situation of the patient, and because of the potential, let's say, nightmare inside the operation, and potential risk of leaving some part of the tumor behind. But, you know, overcome that situation, of course, the initial period in general sense is the good one, before the clot has been reabsorbed or incorporate some sticky gliotic plane.
Yes, yes. Thank you, Miguel.
Thank you, my friend.
Thank you, Professor Akananjali. Professor Andre Grottenhuis, any observations or any questions or any comments? Thanks.
No, it is a beautiful lecture, and just adding to that last question, doing surgery of a pontine hemorrhage, the cavernoma, in the first 72 hours is extremely tricky, because you have a fresh coagulum, so this coagulated blood, and it makes it more difficult, at least for me, to really distinguish between the blood clot and the cavernoma. And I think Miguel just mentioned that there is a higher risk of leaving a remnant in the acute phase, because even if you have removed it, still this fresh blood is covering the whole area, and makes it more difficult to find out if you have left something, yes or no. You should, so I at least wait for 72 hours, also for the patient to somehow recover, because most of those patients with an acute hemorrhage, they do recover amazingly well, and also neurologically with the cavernomas. But you should not wait a month while it is a complete gliotic area. Some people say that the gliosis would protect the pons from our dissection, but it makes it much more difficult, because the edges of the cavernoma are so sticky. I have operated on people with after 3 or 4 hemorrhages and with gliosis around it. That's also a surgical nightmare for me. So I fully agree with your estimation. After 3 days, preferably before week 4, maybe 6. That's arbitrary. And you will see also, if you do MRI scan, you much better can see where the cavernoma is after some time. So I do always a second MRI. And then you can compare the acute MRI with the second, and then you see where it is and where the blood already has been resorbed a little bit. But amazing experience, Miguel. That's incredible. All the cases you do, and beautiful. Again, as we also saw with Dr. Lawton, this the choice of approach is one of the nicer things of neurosurgery, to this planning. Because mentally, you already are performing this surgery. And you think, I go subtemporal, I do that. And you think about subtemporal, and you think about lifting the temporal lobe, cutting the tentorium, seeing the midbrain. And then all of a sudden you say, I never can reach that dorsal part. So you make another decision. So also this mental process of surgery is, for me personally, is one of the nicest things to do. And if you have well approached it and planned it, the execution is also somewhat more easy, because you already know what you will do. And to this last question of contralateral approaches, I have done only 3 of these cases to the thalamus, but the dorsal thalamus, so the pulvinar. And the pulvinar, usually if you have a cavernoma there or a tumor there, it opens itself up in the ambient cistern. The nice thing of going contralateral is that you more easily can follow the basal vein of Rosenthal and then the P3 to reach where it goes into the P2, the pulvinar, where you usually see the hemorrhagin, but it is not far contralateral. It is like just crossing that midline. It's as you said, this tent is this way, the superior surface, and you go over this surface and then into that direction, and that is also very nice. I never really called it a contralateral approach because you make a midline craniotomy in any way.
That's great. Thanks. Thank you very much. We might lose Dr. Ares very quickly. Just one point is that, the reason that I got Dr. Ares and Dr. Lawton to give lectures is that, there are certain things that inspires every neurosurgeon, every resident is to operate on these amazing, challenging cases. Many of us will not be doing this operation. Many of us, it's very rare that we don't even come across it. But the thing is that you learn a lot of principles learning from these masters and these operations. It gets your brain thinking as well. But also the other question is that, at what point in your careers did you decide that you are ready to do surgery for brainstem gliomas? Miguel first, Maurizio second, and Prof. Grottenhuis next. Thanks.
Thank you very much. Well, I think that several circumstances may lead you to that kind of operation. First of all, the patient are coming. The patient are coming with, we are working in Malaga, you know very well Malaga, and Professor Grottenhuis as well, and many other friends. And we have a big catchment area. It means that from time to time, you have to face any difficult situation in neurosurgery. So due to that, the patients are coming and you have to do something. There are clear situations just pointing out toward the death of the patient, a young patient with several episodes of bleeding at the medullary region. This is clear, the patient is going to die sooner or later. You have to do something. And I have to mention that since before I arrived to Malaga 22 years ago in my former department, I was very much encouraged to promote the use of intraoperative monitoring. When I came to Malaga, one of my obsessions was to decide how to, where to address your effort. So one of the strategic points to my mind was intraoperative monitoring. And I have to mention the name of Dr. Victoria Fernandez. We have been working for almost 2,000 cases in general, and having a very good intraoperative monitoring is something that very much gives you a lot of confidence to go ahead with that operation. And at the beginning, I was very much scared about my initial case. I had to do that because the patient was about to die, several episodes of bleeding. By the way, it was a metastatic melanoma at the medullary region. And we just managed to remove the lesion and nothing happens, and the patient did well. And then another case came, and so and so and so. So we just have a lot of confidence in the intraoperative monitoring. We know some of the tricks. We have been, having our own experience in regard to that. I also do advise for the youngest colleagues to have the advice of senior and very experienced professor. I'm not talking about me. I'm talking about Dr. Grottenhuis has a lot of experience in everything. I'm mentioning Dr. Bertalanffy. I'm mentioning Dr. Spessler. When I had to face a difficult case, I had the luck and the opportunity to discuss with them. So little by little, you are gaining confidence and you are having good results. But this is not a merit of mine. This is a merit of the clear-cut good indication for surgery and clear-cut bad indication for surgery. If you have the bad indication, you will have a disaster. If you have a good indication, you will have a good result. Because even in the fact that you don't have intraoperative monitoring, you don't have that, the patient is a young patient, several episodes of bleeding at the medullary region, cardiac arrest, tetraparesis. You have to do that. You go through midline. This case, by definition, is a more or less big lesion inside, easy to be found and easy to be removed. because cavernoma inside brainstem usually is not difficult. The difficult point is the good indication and the good choice of the approach. And this is the way, little by little, you are gaining confidence. And this is the way I just went inside this beautiful aspect of neurosurgery.
Thank you. Thank you very much, Josh, for sharing that. Professor Aikananjali, anything on to add there?
I agree with Miguel. The first one, the indication, and then this is a progressive work. I hope that no one resident want to operate a brainstem cavernoma at the beginning, but then you acquire experience in doing trauma, in doing tumor. An insula, a low-grade tumor of the insula has almost, I would say, the same difficulties. And if you work, if you gain ability, if you gain the mental process in doing something, it's a question of time. The indication, the perfect knowledge of the anatomy, the importance of neurophysiological intraoperative recording, and as Miguel said, the everyday discussion with people that is much more expert than you in doing something. Even the rarest case that you at the moment you don't have, but that you will have in the future. That is my suggestion.
Thank you very much. Professor Groton-Hughes, do you have anything to add there, please?
Maybe I have a little bit different approach to when to start with a difficult case. But I agree, first of all, with Miguel and Mauricio about the indication is the most important. If you do a perfect surgery on a wrong indication, it is still a wrong surgery. So indication is very important, but I was extremely influenced by Axel Panetsky when I started to work in Vienna in early 1986, just before they moved into the new building at that time. So in the old, he had this, he was always very into planning and preoperative studying the approach, knowing the anatomy. And the only thing that will then hold you back is your experience in handling the tissue. So of course, initially it is very difficult. Your first glioma is you still are struggling with the tissue, and when you have done 100 cases, you start to feel that. So to be honest, I think brainstem cavernoma it's about the approach. If you do it right, your approach, then you just have to know how to deal with the tissue. But I remember, just to be safe, my very first case, I invited Helmut Bertalampe, who was we started in the same year with our residency training in Germany, because I did my training in Germany, and then I went to Austria and then Sweden and Canada. So I moved a little bit around in the world, but I asked Helmut, who had already some experience, to at least be kind of backup, but it went very well. And the same with my first petroclival meningioma. There was a senior neurosurgeon with me, but it depends on how to do that. And that is why my residents, at least nowadays with endovascular less, but they all, at least most of them, but some are clearly already going to spine or other things, but they learn how to clip an aneurysm. It's about the dissection, the way to go there, and before the clipping, what is important. And the same is they do cerebellar tumors, vestibular schwannomas, pituitaries. We usually say, oh, that's after your training. No, that's part of it. If you know how to handle the tissue, you can do this. So I did my first brainstem cavernoma when I was just a year as a consultant, but also simply because nobody else wanted to do it. And because they all were afraid of it. And that's odd. It is, your confidence is in how you know how to deal with tissue. And this is the whole training process is about tissue handling and approach planning. If you add those two, I remember I had this one of the best people I ever trained was Thomas Manofsky, and then Saman Finke. They were had such a dexterity. If you told them once, they just in their mind they could do this with the hands. So he was in his second year of training, and it was a craniopharyngioma, and you would say no, a second year resident, but he wanted to open the case for me. Okay, that was a subfrontal approach, and he nicely did it. Can I open the dura? Yes, please. You can go open the dura. Expose now the optic nerve, and then the handling, and then you see this. Well, end of the story is after 2.5 hours, he had removed the craniopharyngioma, well, completely, with a small remnant on the floor, where I told him not to go further. And therefore you need to, and you would say, how can you do that? A second year resident operated on a craniopharyngioma, an excellent case. The same with vestibular schwannomas. They open that, and then they start already the debulking. They use the IRM. They use how do you call it? The bipolar instrument that you can try to find the facial nerve, use an endoscope, and step by step they do more. It's about the tissue handling. So I think it is not. I know that at least in my country, I'm the only one allowing residents to operate on such cases, because mainly also the seniors say, I want to do it myself, because they have never had the chance during their residency, wanted to do it then. But of course, with increasing experience, you become actually better in both, in indication, planning, and execution. Of course, that's part. If I now look back to my first cases, I think that nowadays I would do it better. That's inevitable, I think. So I don't think there is a right moment in your career when you wake up in the morning and say, now I'm ready for brainstem cavernomas. That's simply not happening. It is about knowing who you had to operate, when, how you go there, and then tissue handling. If you learn tissue handling well, you're ready for it, in my opinion. And it's always good to have a senior with you, because we cannot teach experience. Experience is what you have to go through. And an experienced neurosurgeon, I always say, is a neurosurgeon that made one more mistake than yourself, because then you are experienced. We learn from our failures, from our where it went wrong, and that's the thing. But it's always good to have somebody as a backup. And I always thoroughly enjoyed seeing how a young neurosurgeon is doing this perfectly well. And I remember one of the young residents at the end of the surgery said, "I really did this. I did that surgery." And he said, "Well," she said, "Well, you more or less talked me through this whole procedure." Yes, it is possible, but still she performed it because she knows how to handle the tissue. That's all. So that's my view into this subject. So I think it is not only for very few. It is also just based on these principles.
Thank you very much, Professor Groton. Thank you very much to Miguel Ayrath, Professor Miguel Ayrath again. Wonderful lecture, wonderful comments. So we will now go to the free papers. So the first one is from Dr. Daniel Kenyatta from Kenya. Dr. Kenyatta, do you want to share your screen? I look forward to your talk. Thank you.
Okay, can you see my screen?
Sure. And he's going to present on chronic subdural hematoma, a cause of persistent post-dural headache in postpartum period. Thanks.
Thank you.
Thank you.
Is my screen visible?
Yes, it is. Yeah.
Okay, so we are presenting on chronic subdural hematoma, a cause of persistent post-dural headache in the postpartum period. And we're doing this because chronic subdural hematomas have not been described in very young ladies who don't have any risk factors. So as we all know, it mostly occurs in elderly patients, Yeah, occasionally in young patients with traumatic brain injury. Yeah, in our hospital, 50% of the cases are between the 7th and 8th decade, and we see that median age in Brazil was 57 years. So it occurs in older patients. Yeah, and we all know the risk factors for chronic subdural from this image. Yeah, so the initial event is usually a bleed. Tearing this bridging veins. But what makes that more possible is can be parenchymal loss that occurs when you're aging, or in patients who've had meningoencephalitis. It's been described also in patients who've had malaria, case reports, individual case reports. Yeah. The other thing is changes in CSF dynamics. So if you have changes in CSF pressure, it makes the brain lax, and that can increase the possibility of bridging veins being torn. The other thing is hypocoagulability. So after the bleed occurs, it can be exacerbated by the host hypocoagulability factors. Some of the vectors that or the forces that cause chronic subdural hematomas, the commonest is the acceleration, deceleration injuries, so and impact injuries in the younger patients. Yeah. So the case report, we had this 24-year-old primate gravid woman who presented with headaches for the past 4 weeks postpartum, and she had delivered using cesarean section after spinal anesthesia. Yeah, she had on examination unremarkable, no focal deficits. However, on CT scan, we saw she had bilateral chronic subdural hematomas. The ones on the left had membranes. So she underwent a left-sided craniotomy and Barros on the right side. And you can see post-operatively, that's the 1 month after surgery. The chronic subdural had resolved. Our second patient was a 29-year-old patient with 2 previous scars. So had indications for cesarean section for her 3rd pregnancy. She had antepartum hemorrhage. So her headaches had started from day 2 post-operatively, and she presented 6 weeks after the cesarean section. She had diplopia. You can see she had a decent nerve palsy. She underwent Barros and with resolution of her symptoms. So the key presentation is prolonged postural headache. So Lineberger had described postural puncture headaches as occurring within 48 hours, but had a median duration of onset being 5 days with a range between 2 and 10 days. So anything longer than 10 days can be prolonged. Yeah, and in these women, they had prolonged headaches for more than a month. And the only identifiable risk factor in these 2 cases was the spinal anesthesia, where the CSF dynamics had been potentially altered. So we propose that this is the cause of the chronic subdural hematomas. So in Kenya, our prevalence for postural puncture headaches is about 20%. We don't know whether there's an association between prolonged postural puncture headaches and a chronic subdural hematomas, because we don't image these women. Yeah, look through case reports. There are less than 100 case reports of chronic subdural hematomas after spinal anesthesia. We have to bear in mind that it's our commonest operation in Kenya. We have 1.5 million births. 10% of those are by cesarean section, and 90% are spinal anesthesia. Yeah, and we do not follow these women up for after surgery. Most women go home and we don't know what happens to them. And bearing in mind, we have one of the highest rates of maternal mortality, 350 per 100,000 live births. So we propose a bigger study where we can follow a cohort of ladies who've been have anesthesia, and we can maybe get a protocol where we can image ladies who have prolonged postural puncture headaches, and probably document whether they have chronic subdural hematomas. Thank you for your attention. This is where I practice in Kenyatta University, Teaching and Referral Hospital in Nairobi. It's one of the new centers, new neurological centers. Prof. Ares, I have to inform you that the center in Mombasa is thriving. I think I was there when Spanish neurosurgeons came in 2008 and 2009 and inspired me to do neurosurgery. So we thank you for that. We had contacted the WFNS for support in getting a set, though COVID seems to have stopped that program. So currently we are looking for a drill. Thank you.
Thank you very much, Dr. Kanjata. I think we do also in UK time to time, not as often. Probably you are having patients who come with the subdural. At least I know of one. So I think it's the obs and gynae doctors or primary physicians aware that this is a complication that they need to look out for. And sometimes, and how do you, if I missed it, in terms of managing it, sometimes most likely whenever there's a CSF leak, here we usually try to put a blood patch. What about in Kenyatta, in Kenya?
Since we don't follow up these ladies, many of them are lost to follow up in the community, and we don't interact much with the obstetricians, and I don't think they know that this can be a complication. So even after presenting these two cases, I can report in the last 3 months I've operated two more ladies who've had the same presentation. So for a rare occurring disease, I think it's probably very common occurrence for one single practitioner to see 4 cases in a year. So
that's great. Thanks. Thank you very much. Any questions for Dr. Kanjata? Dr. Parak has one. Dr. Parak, do you want to?
May I interrupt?
You want to ask the question, Dr. Parak?
Yes, I wish to talk to Dr. Daniel.
Sure.
Yes, I have been doing this subdural hematoma since many years now. Almost 30 years we are operating. And maybe my series may be more than 2,000 cases so far done. But believe me, I haven't got a single case following the postpartum. And I'm really inquisitive to know where these patients are going from our side, because we don't see these things happening with my other colleagues also. They have never even reported to us postpartum because of the lumbar puncture, the subdural might have happened. It is really something needs to be understood and to follow up with the gynecologist. But these are young ladies, so chances of getting subdural hematomas in a tight brain, young brain, is less likely than in older age. The second thing, what Dr. Naren said about the putting a patch, that we do it in the cases when there is a hypotension. There is a condition called intracranial hypotension, where there is a CSF collection comes in the brain, and we don't operate on those cases, and we'll localize the leak in the spinal region and put a blood patch. If you operate, they keep on recurring. This is the second thing. And third thing, I agree with you, in patient who has got a membrane, it's straight away better to do a craniotomy rather than just doing a simple burr holes. But this is something very interesting. Cause of a subdural hematoma which you have brought up is a postpartum young lady. We have not seen in such a large series. Thank you very much.
Thanks. Thank you very much. Dr. Kanjata, for the sake of time, I'm going to move to the next presentation. If you want to comment to Dr. Parak, please, if you could do it on the chat box for me, please.
Thank you, Naren.
Well done, Dr. Kanjata. So now the second presentation is again from Kenya. In fact, from Africa, we had I broke Asia into two regions, South Asia and East Asia, and Africa is the same as a combination of South and East Asia for the abstract. So I think, well done to our colleagues from Africa for joining us at this meeting. And as I said, if we give opportunities, people usually thrive. So welcome to, I would like to invite Dr. Peter Nijuru to present on pleomorphic xanthoastrocytoma, a case report of a 9-year-old boy. Dr. Nijuru, do you want to share your screen? Thanks.
Yes. Hello, is it visible?
I think it's just starting. It's just going to come on. Yep, it's visible now. You just have to put it on the presentation mode. Thanks. If you press F5, then it will also take you to, oh, maybe not. You can see it. Yeah, we can see
you can see it.
Yeah, it's in a presentation mode. It's in a presenter mode, I think. But
all right.
It doesn't matter. We can see it, so you can carry on. Thanks.
Okay. So, hello everybody. My name is Dr. Peter Njeru. I am a neurosurgical resident at the University of Nairobi here in Kenya. And I'll present a case of a 9-year-old boy with a pleomorphic xanthoastrocytoma that we managed here. So there are no disclosures. This is a 9-year-old boy that I'll be presenting. Pleomorphic xanthoastrocytomas, or rather PXA, are rare astrocytic tumor. They account for less than 1% of astrocytic neoplasm. PXAs were first described in 1979, and in 1993 they were formally incorporated into the WHO classification as WHO grade 2. In KNH, where I practice, we see about 2 to 3 cases per year, and I'm going to present one such case of a patient who had surgery twice. The diagnosis was consistent in both cases. So this is a 9-year-old boy who had progressively worsening headaches for more than 1 month. The headaches were associated with vomiting and somnolence. There were no convulsions, no focal neurologic deficits, and no history of trauma. At the age of 6, the child had presented with similar symptoms and had, in addition, generalized tonic-clonic convulsions and an unusual eccentric swelling of the right side of his head. During that time, the child underwent a parietal craniotomy and excision of an intraaxial brain tumor and was then followed up in the pediatric neurosurgical clinic until the current presentation. On examination, the highlight was that this child had, on sensory examination, corticosensory defect characterized by left-sided stereognosis, acrophyesthesia, and loss of tactile extinction. The blood work that was done was normal, and the histology from the first operation had revealed a pleomorphic xanthoastrocytoma. Imaging. I present to you 3 sets of images. In 2017, at the first presentation, the child, I have an MRI and a CT scan. On the MRI, you see a large, solid and cystic lesion, the solid component avidly enhancing, and you can appreciate on the parietal aspect, the head was swollen, meaning there was mass effect on this tumor to the calvaria, and also there was significant mass effect on the rest of the brain with midline shift and effacement of the ventricle on the ipsilateral side. The CT scan did not show any hemorrhage or calcification. Surgery was done at this time, and gross total resection was achieved. 1.5 years down the line, the child presented again, and a repeat MRI showed a recurrence of the tumor, this time with minimal mass effect. At this presentation, the child came with apparent symptoms, and the MRI done showed a large tumor with significant interval growth and ipsilateral effacement of the ventricle and a significant midline shift. Surgery was done in this case, a parieto-craniotomy, gross total resection of the tumor. We found a moderately vascular lesion that was afferent to the dura. We had to remove that part of the dura and repair it with a dural patch. 24 hours postoperatively, we had this CT scan that showed the resection cavity, gross total resection, and some reduction in mass effect. Histology revealed an astrocytic tumor with spindle cells arranged in fascicles with cellular pleomorphism and with large and mononuclear and multinuclear astrocytic cells with significant pleomorphism with intranuclear inclusions in a background of a reticulin network, rich network. Additionally, there were eosinophilic granules and perivascular cuffing around the vessels. The pathologist gave us a diagnosis of a pleomorphic xanthoastrocytoma. Pleomorphic xanthoastrocytomas typically present with headache and seizures because of their typical location in the temporal lobe. Additionally, these symptoms can be grouped into either localizable or non-localizable symptoms, and the main treatment usually, because of infrequency of these cases, is surgery where it is safe and feasible. A gross total resection can be done. They have excellent prognosis with an overall survival rate of 80% at 5 years and progression-free survival at 60% at 5 years. For our child, the way forward is continued follow-up clinically and radiologically, and also to further histopathologically characterize these tumors in view of the fact that with the molecular knowledge that was incorporated in the 2016 WHO CNS tumor classification, we will need to either characterize them as BRAF mutated or BRAF wild type, which may have an implication on recurrence or progression. This is a list of my references. I would like to acknowledge the World Neurosurgery Webinar Conference for giving us the opportunity, and also acknowledge Kenyatta National Hospital and my colleagues as listed. Thank you very much. Asante sana.
Thank you very much, Dr. Nijuru. Great case that you presented. We also seldom come across pleomorphic xanthoastrocytoma. I see Dr. Miroslav Jurasin is here. If he can connect if he can connect his microphone, it will be good to hear what his experience with these tumors. Dr. Miroslav, are you able to connect? Okay, not to worry. So well done, and I think certainly the goalpost of the WHO grading has changed, and how in terms of following up these patients, how do you follow up these patients? MRI scans or CT scans, and how often, and is this funded by the patient or by the hospital?
All right. We usually, upon discharge, for example, in this patient, they are discharged after 4 days. they attend a pediatric neurosurgery clinic, or if we have adults, they attend an adult neurosurgical clinic. We do a postoperative CT scan. At this time, currently, we are able to do, if the patients are subscribers of the National Health Insurance, which is quite affordable for some patients. However, a large number of them may not be able to afford. For those who are not subscribers, they have to pay out of pocket. And that can be a challenge because our catchment area is really an area that most of the people are poor and may not consider doing another scan, especially if the symptoms have gone away, necessary. For those who can do, we are able to do the postoperative scan, then again repeat a yearly MRI scan if they're able to afford, or if there are clinical symptoms, then we can consider to do a repeat CT scan, to reduce the exposure to radiation altogether.
Thank you very much, Dr. Nijuru. Well done. So I'll move to the next presentation. It's from Dr. Oyileye Igan-Jobi from Nigeria. Dr. Igan-Jobi, he's from Nigeria, but currently in Birmingham, in QE Hospital. Dr. Igan-Jobi, you have got 7 minutes. We are now back to being tight on time. So do you want to share your presentation and look forward to your talk? Thanks.
Oh, yes. Thank you very much for this wonderful platform. I really do much appreciate this. So I'll be quick on time. It's such a wonderful privilege, really, having to come up with one of the rarest clinical constellation of signs and symptoms called the Alaman-Strieff syndrome. This was particularly one of the cases I happened to, or privileged to see when I was an intern. It was, the details will be very much revealed along the course of presentation. So very briefly, this is one of the underreported syndromes, especially when it comes to cranial synostosis. It's rarely talked about, even in the spectrum, whenever conversations are being held around the Cruzon syndrome, the Apert syndrome, Pfeiffer syndrome, Moenke syndrome, and all of that. But Alaman-Strieff syndrome apparently is one of those cranial synostosic syndromic presentations, and basically comes with dysmorphic features that include abnormal development of the skull, the face. There are hair problems, skin, teeth, bones, and the eyes. And historically, we can relate it to back in 1893, where something looking like Alaman-Strieff syndrome was described. However, it was Alaman in 1948 and Strieff in 1950 who came about talking about the key features seen in these syndromes. And basically, it included features as described in the introductory aspect. For this index case, really, it actually happened in a case where the mother was she had quite a number of poor obstetric history, hepatitis B positive. She had preeclampsia, a polyhydramnios identified on abdominal ultrasound. She didn't attend antenatal care. At 34 weeks of age, at 34 weeks gestational age, she presented with gestational symptoms, and clinical examination revealed certain findings that were in keeping with this syndrome in particular. And one of the things that actually struck my attention was the fact that anytime I happen to see a fresh bone with natal teeth, it's one of those things that switch my observational IQ to say, hey, something might be strange in this. And publications have actually revealed that, okay, in cases where there are Soto syndrome, Alaman-Strieff syndrome, these are just one of those rare syndromes or congenital malformations.
Dr. Lay, you have got 3 minutes. Thanks.
Where we have this kind of situations, and this particular case revealed frontal bossing of the skull brachycephaly, big-shaped nose, micrognatha, hypoplastic mandible, and of course the natal teeth, with short web neck and some asymmetric nipple sides. Just 1 minute to have a quick rundown on this, and the exact cause is really unknown if we look into this syndrome, and of course it should be categorically discussed as one of the differential diagnoses of craniofacial synostosis or dysmorphism. There have been reports of difficult airway management as well in the past. Also, there are certain structural congenital intracranial abnormalities also usually, since there have been cases reported of absence of corpus callosum. And one key thing is that folic acid is definitely key in prevention of these teratogenetic manifestations, especially during the first 8 weeks, which is called the organogenetic period. And just to conclude in 30 seconds, it is really the first of its kind in the locality which was reported, and basically with adequate health, information, health promotion, these pan-systemic or cerebrofacial complications can really be prevented if, adequate health education, promotion, folic acid supplementation. Like I remember Professor Nwagumbi was presenting about spina bifida yesterday, 2 days ago. So this is really key. And I conclude by saying these are my references. Thank you very much.
Thank you very much, Dr. Lay, for to enlightening us on this very rare condition. And as you said, prevention is better than cure. And I hope things will change. Thank you very much.
Yeah,
well done.
Thank you very much.
So we now move to the next talk. It's from Dr. Laura Beatriz Martins from Brazil on vasopressin performance in chronic pain studied through systemic review. I will just set her up. Oh, she's all good. Dr. Martins, do you want to? I'll just get the share options for you. Just a second. Okay.
Yeah, let me share my screen.
Yep, please. Thank you.
Are you seeing my screen?
Yep. Yeah. Yes. Well done.
Okay, thank you. So my work's about vasopressin performance in chronic pain. I studied through a systematic review. It's well known that chronic pain is the main cause of disability worldwide, with lower back pain and cervical pain as its main factors. I will call chronic pain as CP. CP is the result of an injury or disease, and it's not classified only as a symptom, but it presents a complex pathophysiology with a profound impact on the patient's life and society. CP has a multifactorial etiology to the causal injury itself, as psychological, biological, clinical, and socio-demographic risk factors that affect the entire course and intensity of the disease. The nonapeptide arginine vasopressin, also known as antidiuretic hormone, AGH, can be synthesized by magnocellular cells, mainly in the supraoptic nucleus and secondarily in the paraventricular nucleus of the hypothalamus. The release of AVP in the blood is stimulated by the activation of rosmin receptors that detect small increases in plasma osmolarity. These receptors are irrigated by vessels with no blood-brain barrier, and therefore they could have contact with plasma. The variation in electrical activity induced by changes in blood osmolarity stimulated these osmoreceptors through mechanosensitive electrical channels. Vasopressin acts as a neurotransmitter in some limbic structures, in addition to its hormonal action. AVP acts on the brain at two centrally expressed receptor subtypes, V1A and V1B. Of these two receptors, V1A has a more prominent role in the vasopressinergic modulation of the social behavior, and therefore the studies has a greater focus on examining the role of vasopressin in the regulation of social behavior and limbic system. The thermal analgesia through V1A receptor modulates the contents of neurons in the dorsal root ganglia, resulting in analgesic effects. These effects produced by the activation of the V1A receptor results in an activity reduction of the transient type 1 vanilloid receptor, present in the pathophysiology of CP, This leads to a sensibilization of neurons in the dorsal root ganglia, inducing a thermal analgesia. In addition, the lower level of vasopressin is associated in some studies with a greater sensation of pain, suggesting that vasopressin is only one of several neuropeptides involved in the modulation of the central pain. So, in view of these pathways between vasopressin and changes found in DCP, our aim is to describe the correlation and changes in the pathophysiology of chronic pain by developing a systematic review analyzing the relationship between the role of vasopressin in chronic pain. Our systematic review was performed according to the guidelines from PRISMA. The short terms used were these showing on the screen. They were using PubMed, Medline, Cielo, Crocaine, Lilacs, and TRIP database on October 14 of this year. We identified 231 articles, 60 on PubMed, 29 on Cielo, 4 on Crocaine, 60 on Lilacs, and 8 on TRIP database. After removing the duplicated studies, 195 papers were selected. The inclusions criteria were studies in human or animals, with chronic pain diagnosis by any criteria in any age group, original published in any language. Studies published only as a summary papers that prevent their full access prior to 1990 protocols, as well as systematic or non-systematic review were excluded. 3 reviewers conducted the screening and removed studies that were out of scope, making a total of 12 studies in the eligibles. 1 study was excluded because it was not possible to have full access of it after 4 reviewers with the full papers, and we reached the consensus of 4 included studies, as we can see here in our diagram. The frequencies of single nucleotide polymorphisms, SNPs, of the V1a receptor gene, as well as this SNP here, RS, is associated with pain. CP is not directly associated with this specifically SNP. However, this gene polymorphism was associated with an acute phase of pain. The difference for this association may be due to the difference between sample and their heterogeneity found in this study. The pain, catastrophizing, and depressive symptoms are associated with RS polymorphisms, suggesting a possible relationship between AVP and chronic pain through the limbic system. The angiotensin converting enzyme and AVP levels were measured in cerebrospinal fluid and serum in 1 study. An osmolarity increase was found in patients with CP, suggesting changes in their homeostasis and in AVP secretion. Elevated AVP level can be chronic due to the presence of pain over several years, leading to a negative regulation of the renal tissue, resulting in a chronic state of hyperosmolarity. This higher AVP plasma concentration in CP can cause chronic stress because of pain. So the homeostasis and AVP secretion are dysregulated in CP, reflecting a condition of chronic stress. Nishimura et al. Published in this year was the first study to find a relationship between CP and the AVP system activation in animal models with chronic peripheral joint pain. The AVP serum concentration was increased, suggesting a link of CP modulation with the hypothalamic pituitary adrenal axis, HPA axis. Possibly in response to nociception, AVP is synthesized by the AVP magnocellular neuron, activating central and peripheral areas, such as V1a and B receptor. This found suggests that CP activates predominantly AVP-producing neurons and not CRH, corticotrophin-releasing hormone. Thus, the HPA axis activation allows the AVP parvocellular neurons to suppress inflammation through this activation. The hypersensitivity to vasoconstrictors is present in CP. A study carried out the application of intradermal doses of adrenergic agonists in rats with post-ischemia CP, verifying that the models presented pain when submitted to these vasoconstrictors for several seconds. This is due to the abnormal and hypersensitized response to these substances. Nociceptive behaviors increased with the use of non-adrenergic vasoconstrictors as AVP, suggesting that hypersensitivity to sympathetic vasoconstrictors and ischemia are important mechanisms in pain and can be used for the development of future treatments. So in the conclusion, the correlations between AVP and CP is not well understood by the studies. As limitations, we found difficulties in finding studies that the database that evaluate this hormone in patients diagnosed with CP. However, it was possible to observe that there is a change in the AVP serum concentration in the presence of CP that cause justifiable symptoms to these abnormal levels. But it has not been clarified yet either it is a consequence or causal of CP. The AVP changes should be better studied to clarify the pathophysiology pathways that may be related to CP, enabling studies to improve existing treatment for the disease. This is our references, and I wanna thank you all so much for this opportunity to present our work.
Thank you very much, Dr. Martins, for bringing our attention to this vasopressin and chronic pain. How do you want to take it further yourself? Do you have I used to do pain neurosurgery. I worked with the pain physicians, and when they put the spinal cord stimulators, obviously it's intradural. Sorry, no, it's extradural. Sorry. And how do you plan to study this further? Do you have any plans yourselves, or
We work with chronic pain by intervening in our patients with DBS and these things, but we are thinking about the correlations between hormone and all the system with the pain, because the pain we don't have a really strict pathway for the pain. We have limbic system acting on it. We have a hormone system acting on it. We don't have a really clarified pathways for the pathophysiology of pain. So we are investigating this because our professor works with this part of longevity of life. So we are thinking about improve these vasopressin studies to make better studies for the treatment of chronic pain.
Thank you. I think well done. I'm sure you'll find ways to study this further. Probably trigeminal neuralgia is not the chronic pain that you might think of, but you might get some CSF from there and look at vasopressin levels. So well done. I look forward to hearing more from you on this in hopefully the future meetings. Thank you very much.
Thank you very much for your attention.
Thank you very much. So in the next presentation is, let me just, I just jumped. Beg your pardon. So the next presentation is from Dr. Dr. Noor Ul Huda Maria on the effects of COVID-19 on hypothalamus. So not far from the other Dr. Martin's talk. Is it another phase of SARS COVID-2 that may potentially control the level of COVID-19 severity? Interesting. I'm looking forward to your talk, Dr. Noor. Well done with all the other talks. Look forward to great things. Keep it up. So I will make sure that you can share. Let's see. Yeah, okay. Okay, share. You can now share. Thanks.
Thank you. So can you see my slides?
I think it's just going to come through. Yep, we can see your slides. Yep.
Thanks a lot, sir. So thank you so much again. It's a big privilege for me to share this work. This is the effect of COVID-19 on the hypothalamus. Is it another phase of SARS-CoV-2 that may potentially control the levels of COVID-19 severity? Actually, the basic thing I want to share here is that why it concerns us being neurological surgeons. It is basically the thing that may actually, there are 4 different studies I have got which are relevant to this. One of this is with Dr. Luis Rafael from Colombia. He and I worked on our project where we were suspecting that SARS-CoV-2 might be transmitted from the CSF. So it was one thing that we wanted to know. The other thing was that many of my colleagues reported that they're awaiting surgery, especially of low-grade gliomas and other gliomas, or low and high-grade both gliomas. They showed that those patients who were waiting for surgery and they suffered from COVID-19, they suffered from worsening of the symptoms. There were third thing is we have noticed that many of our patients have suffered from peripheral nervous signs and symptoms who have suffered from COVID-19, which did not have anything else, like they were normal patients. Many of our doctors who fell ill to COVID-19 suffered from peripheral nervous system signs and symptoms. They eventually recovered, but they suffer from this. One report supporting this was from China. They showed that demyelination they have noticed in COVID-19. So what we actually wanted to see was what could be the effect of SARS-CoV-2 and COVID-19 infection on the CNL. Later, like it's a new virus for us, but after a few years we might see that there may be any oncological potential of this infection as well as some vascular pathology that may it may lead to. There is a potential. I have another study of there is a potential. I have another study of salmonella typhi, which actually links salmonella typhi with the incidence of low-grade gliomas in patients, because there was a temporal relationship of a certain age group of people with only low-grade gliomas, and it was not seen in any other pathology. So as we all come back to here's my paper start, as we all are combating the COVID-19 pandemic, that is a war being imposed by an invisible enemy. Each day we need to spy the new moves by our enemy in order to design our own strategy. It has pushed us back in teaching ourselves the basic science based on observation, the new words from the alphabet as we find, and playing Columbus to discover the new faces through which SARS-CoV-2 may manifest itself while looking for the hallmark sets of signs and symptoms, the tendency of masquerading itself of the SARS-CoV-2, a virus that ruined the famous Venetian Carnival. It is in well itself has put all the researchers into a mayhem. This metamorphic menace has ways to amaze us and to bluff us by presenting it in unexpected ways. Since we have never suffered from this novel virus before, there is no data to correlate and guide us regarding the possible ways of presentation of this virus. So actually, it is very interesting that many of the subjects of this study are doctors themselves. Many of my colleagues who suffered from COVID-19 infection reported that they are facing some novel signs and symptoms which they were not expecting. Even before they were febrile, they were suffering from polyphagia, polydipsia, and tingling and burning sensation in their distal limbs, especially lower limbs. So all of them were doctors, and they were very amazed that why have they suffered from the same symptomatology before they became febrile and before they turned positive for COVID-19. And the mean time period from the symptomatology to their COVID positivity was about 48 hours to 72 hours. So it came into observation that many patients with COVID-19 infection have presented to us with polyuria and polydipsia with and without polyphagia. In a short study, we detected at least 27 patients who suffer from unquenchable thirst and ravenous appetite. 7 of them were diabetics, including 2 who were insulin dependent. Most of them did not develop severe COVID-19, and it is very amazing because most of them were recovered, it took them about 7 to 10 days, and they were all doing fine, and they were just self-isolating. They never needed vent. They did not suffer from severe respiratory symptoms as well. Polydipsia and polyphagia raise suspicion of hypothalamic infliction, since hypothalamus has centers for thirst, hunger, and satiety. The interplay between stimulation and inhibition leads to the normal hunger and thirst sensation. We further noted that 20 of them had other signs and symptoms that were related with peripheral nerves. They all suffered from anosmia and dysgeusia as well. That was very serious. So we suspected that if we put all these symptoms together and correlate it with the viral entry through the nose, it is quite simple to explain the SARS-CoV-2 affects the olfactory nerve, and from there it may find the way to the hypothalamus. Our patient did complain of unquenchable thirst and ravenous hunger, which are both related with the hypothalamic function. Basically, it is an imbalance of thickness from the lateral hypothalamus, that is the hunger center, and the ventromedial hypothalamus, that is the satiety center, with an increasing experimental and clinical pieces of evidence showing hypothalamic dysregulation as one of the underlying mechanisms of abnormal glucose metabolism. It can be postulated that hypothalamic infection is likely in SARS-CoV-2 that leads to polyphagia in both diabetic and non-diabetic patients, as well as poor diabetic control in the diabetic patients. Connie, this is a Koshiyama et al. Study that postulated an increased hypothalamic pituitary adrenal axis activity caused by extreme stress that may lead to manifestation, including polyphagia. So, a deranged hypothalamic function causes diabetic tendencies, and polyphagia can be one cause. In the non-diabetic patients, proper blood sugar level testing was not performed. However, in the diabetic patient with COVID-19, it was evident that glucose control was quite poor. The other that they were not able to control their insulin levels, their blood glucose levels through insulin. The other important point regarding the causation of polyphagia is the direct effect on hypothalamic centers for satiety. It's evident that mutation in several genes related with hypothalamic satiety centers signal lead to polyphagia and the so-called hypothalamic obesity. This might point towards the possibility of SARS-CoV-2 affecting the hypothalamus not only directly but also via genetic expression. And this is very, very important in a way that if it is working on the central nervous system at the level of the genes, it may ultimately lead to some oncological process that may become evident, God forbid, years from today, all those patients who have been afflicted may later on, if it is impregnated in the genetic makeup of your CNS, then it may not be. We cannot say, especially if it is going into the CNS. It is causing inflammation. It's causing infection. Many of the genes will change their expression. Some of them will be methylated. Some of them will try to express themselves. There will be wear and tear, and there will be repair as well. You know, whenever there's a repair, there's always a possibility of some oncological potential. So if it is working on the genetic level, it can be something that is very, very important and may lead to some oncological potential on its own self. It's also working on the level of the blood vessels, because we have seen that there's a lot of there's an increased incidence of strokes in COVID-19 patients. So it is something that is really important in the long term, not today, but from a couple of years from now. We have to be very vigilant in those patients who have recovered from COVID-19 infection. Today, Monse and I will be sharing their views on CNS infection and other long-term effects of COVID-19 that they have actually noticed. Since SARS-CoV-2 also acts on the ACE2 receptors, somehow at any level, whether central or peripheral, it's able to cause both dyspepsia. Hypothalamus has osmoreceptor that regulate thirst mechanism, and hypothalamus plays a central role in thirst mechanism, as we all know. Due to limited resources and an overwhelmed system, we were not able to follow any specific lab investigatory protocol. However, correlating with the serum electrolytes, urine output records, none of them had either diabetes insipidus or dehydration. The only notable point was a poor diabetic control during illness, but this can be from various different reasons. Again, hypothalamus play a role inside of this mechanism, including blood sugar control. So further pieces of evidence that we found is the study by Gu et al. Neuronal histopathological changes that were found in the hypothalamus in the autopsies of 8 victims of SARS. That was not the COVID-2, the one that was before. And then Nemputheri et al. Suggested that SARS-CoV-2 invasion is very evident. That is scientifically, they proved it scientifically in the hypothalamus. The hypothalamus plays a key role in hypertension, diabetes, obesity, and other risk factors for developing severe COVID-19 infection as well. So it can be a double-edged sword. So it can not only directly and also indirectly, and there is a lot of multifactorial things that can lead to a lot of severity. They also suggested a non-respiratory system, a region for respiratory failure. Hypothalamus being connected to the brainstem cardiorespiratory centers can cause respiratory arrest. This was applicable in the large number of patients who presented with sudden deaths and were not resuscitable as well. Human brain gene expression analysis revealed that hypothalamus within the associated region express angiotensin converting enzyme 2 and transmembrane protease serine 2, which allow the SARS-CoV-2 entry into the cell. So it may be possible that SARS-CoV-2 alters the gene expression at this level. Results from immunolabeling in human brain show that hypothalamus allows the entry of SARS-CoV-2 through multiple routes, which influence brain susceptibility to the infection as well as the severity of COVID-19 manifestation. So let us all join this piece of information together and suspect that polyphagia, polyphagia, and peripheral manifestation to suspect the SARS-CoV-2 interacts with the nervous pathway and also interacts with the ACE2 inhibitors receptors. It is likely that SARS-CoV-2 finds a way to the hypothalamus, leading to the manifestation related with hypothalamic structures. So in our in our sample of 27 patients, all of them suffer from polydipsia, polyphagia, and there were 7 patients, that is 26%, who were diabetic, and 2 of them were insulin dependent. They all suffered from dysgeusia and anosmia, and the peripheral nervous system involvement was seen in 20 patients, 20 out of 27 patients. Based on these findings, strong suspect the infection of hypothalamus by the virus, the severity of the may even be controlled by the degree of hypothalamic dysfunction. We suggest further studies on this subject, which is very prudent. From the neurosurgical point of view, Mount Sinai Hospital has just raised the issue of delayed complication in patients who have recovered from COVID-19. They will be doing a press conference tonight for us. It is tonight, for them it is 5 p.m. EST. If we can prove that a virus affects the CNS, we could be vigilant and ideally should start a prospective study to evaluate the long-term vascular and oncological effects of the CNS. In another paper of mine, I have raised suspicion of peripheral nervous system infection by the SARS-CoV-2. I also suggested latency of the virus through various different mechanisms. It's just like the herpes virus is staying there, a varicella zoster virus, we all know that is in the dorsal root ganglion. But whatever it is, we have to be very vigilant. This is another paper from Wuhan, which is the epicenter of this pandemic, where they showed the neurological manifestation of hospitalized patients with coronavirus during 2019.
Dr. Noor, you have got 1 minute.
Okay, that's done. Thank you so much. And this is the press conference that will be released today by the Mount Sinai. Thank you so much for your vision, for listening to me. Thanks a lot again. It's done.
Fantastic. Thank you very much, Dr. Noor ul Huda Maria. I think you certainly raise an interesting speculation and hypothesis and some evidence. I hope you will follow this one up. And sometimes, sometimes you can get biases. When someone has it's like a, like a suggestion. Sometimes when you have something and when you ask, then suddenly you feel, yes, I had the headache there, I had polydipsia there, I had, so sometimes these are biases that come into it as well. So it will be hard to just clinically teasing it out, but I think it will be a combination of clinical suspicion, MRI, then autopsy. But I think you are not, I think you have a plausible hypothesis, but we probably have to you have to have some work to systematically look into it. But well done, and look forward to hearing further. Thank you very much. Is it okay? So we'll now move to the last talk of this session, and then we'll directly go to the next session. So this one is this presentation is from Dr. Dimitrios Kefeles. He's a neurophysiologist, secretary of the UK Neurophysiology Society. He's going to give us 15 minutes talk on neurophysiology of brain surgery. Just a second.
Hello, can you hear me?
Yes, Dr. Dimitrios Kefeles. Yes, you should be able to now share your presentation. Thank you.
Can you see my slides?
Yes, we can. Thank you.
Okay, great. First of all, I would like to thank the organizer of this wonderful neurosurgical conference, and to thank the committee for giving us the opportunity to present our work. I would also like to thank my colleague Gema Perez Fajardo from Spain, consultant clinical neurophysiologist. I'm going to talk about neurophysiology for brain surgery. Probably you are familiar with the most commonly used modalities, for example, motor evoked potentials and somatosensory evoked potentials. However, there are much more modalities and techniques that are available for neurosurgical monitoring, and I'm going to talk about the ones that are applicable for brain surgeries. I'm going to start with the monitoring techniques. EEG is used to monitor cerebral oxygenation, and it can also detect intraoperative seizures. The free-run EMG is more useful when we monitor cranial or peripheral nerves. However, it can be used to detect generalized seizures. When we monitor the evoked potentials, it's very important to set a baseline before the surgery. Anesthesia should be total intravenous in order to help us to record good signals. The anesthesia should be stable during the surgery and without relaxants. Moreover, the neuromonitorist should be aware of the underlying mechanisms and should set the alarm criteria before the surgery according to what the surgery is. From now on, when you see this blue star, it means that the recordings are from my own cases or from Dr. Perez Fajardo. Somatosensory evoked potentials can be elicited stimulating a peripheral nerve, most commonly the median or posterior tibial nerve, and they can be recorded with scalp electrodes or even better with intracranial recordings over the somatosensory area, which can give a better recording and more reliable monitoring of SSEPs. The exact position and direction of the dipole generator of the SSEP may differ from patient to patient, so it is recommended to perform multi-derivation SSEPs. As you see here, there are more than one derivations for each SSEP, which is going to improve the reliability of our monitoring. Motor evoked potentials can be elicited either with transcranial stimulation or direct cortical stimulation. And for brain surgeries, we record the responses from the muscles. Especially in supratentorial cases, we should be aware of a phenomenon that may affect our monitoring. It's the spread of the current, which mainly happens when we use non-focal stimulation montage with high intensities. The current may spread deeply in the white matter, and it may activate the corticospinal tract caudally to the potential injury. So it may bypass the damage, and we may have false negative MEPs. That's why it is recommended to perform focal stimulation with low intensity in order to avoid the spread of the current. C1, C2 can be used for lower limbs, and hemispheric stimulation with C3, CZ, or C4, CZ can be used for face and hand areas monitoring. When the primary motor cortex is exposed or accessible, then we can use a strip electrode to activate more focally the cortex without spread of the current subcortically. And we can monitor the MEPs with minimal movements without even interrupting the surgery, as we do with motor evoked potentials with transcranial stimulation. If we need to monitor the face area with transcranial stimulation, we have to apply a special technique, which is called corticobulbar MEPs. This technique consists of a single pulse stimulation and then multi-pulse stimulation transcranially, which can help us to differentiate between peripheral activation of the cranial nerve or cortical activation of the corticobulbar tract. So applying this technique, we can minimize the false negative corticobulbar MEPs. Visual evoked potentials can be elicited delivering flash light stimuli to the eye, even with closed eyelids, and the responses can be recorded over the occipital area with scalp electrodes. Even better, the recordings can be obtained directly from the visual cortex with strip electrodes. And I am aware that some neurosurgeons have doubts regarding the recordability and reliability of the visual evoked potentials. That's why I would recommend you this this review, which explains the development and improvement of the visual evoked potentials monitoring throughout the last decades. This is an example of a case I monitored a few years ago. You will see something like VP drop and then loss and then recovery of the potentials. But actually, this was not a real drop. It was a technical problem. And the way to realize that it was a technical problem is to record the ERG, the electroretinogram, at the same time with the VEPs. And here you see the correlation between the VEP drop and the loss of the ERG. In that case, the problem was a dislocation of the stimulator, and the light was not able to reach the eye and the retina to activate it. Now I'm going to the mapping techniques. Mapping of the central sulcus can be easily done stimulating the contralateral median nerve and recording the responses over the cortex, and we can localize the central sulcus when we see this phase reversal pattern on our recordings. In that case, between the contact 3 and 4, we see the phase reversal, so we can localize the central sulcus. Motor mapping of the primary motor area and subcortical mapping of the cortical spinal tract can be performed with anodal and cathodal stimulation using a monopolar probe and delivering a train of 5 electrical stimuli. It's a reliable method. Nowadays, we also have a monopolar suction simulator with which we can perform continuous and dynamic mapping of the corticospinal tract during the resection. So we are able to estimate the distance between the stimulating point and the corticospinal tract at any moment of the surgery. Electrocorticography is used to delineate the borders between the borders of the epileptic zone. However, it is affected by anesthesia, so the use of intraoperative electrocorticography has been controversially discussed on the literature. During awake craniotomies, we can perform speech mapping. The most commonly used technique is the bipolar 50 or 60 Hz simulation, the Penfield technique. However, the last years, the repetitive train of 5 stimulation is becoming more popular. This technique was introduced by Dr. Axelsson and became more popular from Professor Bello. However, we should have in our mind that, especially with Penfield technique, seizures may be induced, and in order to minimize the rate of induced seizures, we should load the patient with anti-epileptic drugs before the surgery, and we should always have available cold irrigation during the surgery. Neuromonitoring related risks are the bad injury because of the transcranial simulation for motor evoked potentials, and the movements for when we perform MEPs, which can be catastrophic, especially in neurovascular surgeries, for example, an aneurysm clipping surgery. Moreover, the seizures is a small risk that I described before. I would like to mention the importance of doing monitoring appropriately during a brain surgery, because if we apply the same methods or as in spinal surgeries, we may have failures. And this is an example. This is a paper published relatively recently. They compared the long-term outcome of patients underwent aneurysm clipping surgery before and after the introduction of monitoring, and they did not find a significant difference on the outcome of the patients. However, as you can see on this letter to the editor, this is most likely because they did not do the monitoring well. For example, for motor evoked potentials, they only did transcranial stimulation. They did not utilize cortical stimulation for monitoring of the MEPs. Sometimes they also did non-focal stimulation with high intensity, so they bypassed the ischemia of the cortex. They activated the corticospinal tract deeper than the cortex, so they had false negative results that affected the outcome of their patients. As take-home messages, neuromonitoring can prevent neurological deficits and improve the neurological outcome, but it has to be performed well. You should have a complete monitoring, and it's important to detect the evoked potential changes at a reversible stage. Otherwise, it's going to be just detection, not prevention of the neurological deficits. There should be an appropriate methodology for the brain monitoring because it may make a significant difference, as we saw on the previous slide. And moreover, multimodal neurophysiology is recommended, combining monitoring and mapping when this is applicable. Last slide, I would like to remind you and invite you to the next European Congress of Clinical Neurophysiology. And this time the Congress will have a course in intraoperative neurophysiological monitoring. I will be the organizer of this course, and Dr. Pérez Fajardo is going to be there to teach the participants as well. Thank you very much for your attention. Please let me know if you have any question, or feel free to email us if you need anything regarding neuromonitoring.
Thank you very much, Dr. Kefalas, for once again another excellent talk. I think more and more in neurosurgery, certainly in pediatrics, neurophysiology becomes exceptionally important. And if you go to state neurophysiology, even for IVF, and so I think there's a question for you in the chat box. If I could ask you to answer it on the chat box for me, I would appreciate it. Just get Professor Groton there on the importance of neurophysiology for neurosurgery.
Yeah.
Historically, I don't know. I think Dr. Albino Briccolo was a neurophysiologist before he became a neurosurgeon. I think Professor Grotonius might be able to tell me, but certainly in pediatric neurosurgery, the people who spend time with Fred Epstein, who now are leaders in the world in pediatric neurosurgery, are all pretty much neurophysiologists. So
it is very difficult to understand. There is a terrible echo.
Okay, Professor Grotonius, I was just saying that if you can just comment on the importance of neurophysiology for modern neurosurgery and the role of Briccolo in neurophysiology and the Epstein
yeah, I
group.
think you already mentioned two important names. But the Briccolo, I don't know if he was neurophysiologist before.
Okay.
He was a neurosurgeon from Verona, and still there in Verona, neurophysiology, intraoperative neuromonitoring is very strong. The proponent now is the current chairman, Francesco Sala, who has extensively published on the importance of intraoperative neuromonitoring. And Fred Epstein was even ahead of his time in New York. And I think everyone who spent some time with him, mainly on intermedullary tumors in children, and the importance of IONM there, they have continued to do that, like Shlomi Konstantini and also Karl Kohlbauer, who unfortunately just died a few weeks ago very suddenly. So this is, I think the IONM have divided a little bit the field of neurosurgery. Some people claim and say, well, IONM is only capable of telling you the moment the damage was done, and that's all. So why should I use it? The thing is that if I discuss with people who intensively and actually know how to use it, they say it's better not having IONM at all than having bad IONM. And that's the thing. We should not, as neurosurgeons, rely only on our neurophysiologists. We need good ones, of course, but you should also understand the principles yourself. So what does it mean when a signal diminishes? What means that in, let's say, even on a kind of cellular level? So all my residents actually follow a 3-month course in neurophysiology to learn that, to understand this part of it, so that nobody just can say, oh, I see the P3 is going down a little bit, or the D wave has diminished to 50%. If you don't, as a surgeon, understand what is going on, it's not helpful at all in surgery. I think that, and then if you do, and you have a good interaction, it becomes really a worthwhile method in exactly walking this small rim between effective and good removal of a lesion and causing a deficit. So it for me, it is not just a number or a figure or just a signal. It is something that needs interaction, and also a surgeon who understands this. If that is the start, then IONM is an extremely valuable tool in neurosurgical procedures. Because I have also seen medical legal cases where somebody had, he did an MVD for tinnitus, and then the auditory signals were starting to diminish. And he said, okay, well, I go on nevertheless. I don't, probably it is a technical problem, and then, but the patient ended up deaf. So I would say, why are you using IONM if you are not taking what is happening seriously? So therefore there was, and I learned this from Francesco Salo, who said, if you don't understand what it all means, you better don't use it at all, because then you will then you just go on having neurosurgery without knowing what is going on with physiology. And you have this first monitoring, and then of course we have the mapping. It was a beautiful lecture, and this mapping is even more difficult to really interpret. And again, we cannot simply do this. Also, let's say, interpreting an MRI scan well, and you have to study this. So this is not something you just enter the OR and you can handle this. It needs proper training in doing it and interpreting it. But both, if you do it well, and that is my message to the younger neurosurgeons, put some effort and time into it, and this is valuable. Then you will never want to have surgery without it anymore. So this is my comment to it. Thank you, Nera.
Thank you very much, Professor Grotten-Hughes. Dr. Jallo is here as well. Dr. Jallo, I know you're from Dr. Epstein's school, and you use neurophysiology extensively. Do you want to add to the comments of Professor Grotten-Hughes, and any advice for young neurosurgeons?
No, I think I think the comments were all excellent, and the presentation, as I put in the chat box. I mean, I think the question is, we as neurosurgeons have to know what the technology is and understand it, and when we're operating, to realize that when someone tells you, oh, something's changing, you have to know the physiology to be able to make the intraoperative decisions that are necessary. If you, I wholeheartedly agree that we as all neurosurgeons should be trained in neurophysiology, or at least take a several-week course to understand neurophysiology. We're the ones that are operating on these patients. We should not just rely on the neurophysiologist, neurologist, or the technician that's doing the monitoring. We have to understand what they're monitoring, what the D wave means, what the stimulation means, or what the bears mean, to be able to make the best intraoperative decisions.
Thanks. Thank you very much, Dr. Jallo. Thank you very much again.
May I say a few comments if we have 1 minute?
Just 1 minute. We are running well late. Thanks. Thank you.
Thank you very much. Just to comment that to my understanding, it's the neuromonitorist's job to realize if it's a technical problem or not. For example, as you saw on the VP slide, it was easy to differentiate between a real drop and technical problem using the ERG. So there are ways to differentiate between real changes and technical problems. I am aware that several surgeons don't trust monitoring much because they have a lot of false positives. And that's why it's important to have a good team and multidisciplinary meetings before each surgery. So the surgeons, yes, should have a basic understanding of monitoring. We should have a basic understanding of what you do and what the risks may be in order to improve our work and the outcome of the patient.
Thank you. Thank you very much, Dr. Kefeles. You made an excellent point. Thank you very much again for the talk today and as well as yesterday. Great. So now we go to the afternoon session. It really, I mean, I first heard Dr. Mariano Sokolovsky give his lecture at the WFNS Rome meeting. I tell you, you are in for a treat. And he's a great surgeon, highly regarded. He's the chairman of the peripheral nerve surgery section of the WFNS. He's ahead of his time. I think 4 or 5 years ago, even 6 years ago, because when I joined London, he was already doing it. He started a course, online course for peripheral nerve surgery. I mean, that was, well ahead of anyone, even me, to be honest, in that matter. Congratulations to that, and very active peripheral nerve surgery practice. And I had the pleasure of training one of his former residents. She was fantastically good as well. And so, he's going to talk to us about why neurosurgeons should do peripheral neurosurgery. And I do like doing peripheral neurosurgery. I do love it. But I tell you, you are all going to be converted today, so be ready. Professor Sokolovsky, would you want to share your presentation? Thank you.
Yes. Hello, Naren. Do you hear me?
Yes, I can hear you.
See me appropriately? Okay. I will share the screen then. Just give me a minute. Well, first of all, thanks for inviting me to give this this talk. I will. Do you see the screen?
Yes.
Or no?
We can see the screen, but to maximize it.
Yeah, of course.
Thanks.
Is it okay?
Yes. Well, fantastic. Thank you.
Okay, just a second. Okay, first of all, thanks for the invitation, and also thank you, Naren, for organizing this wonderful World webinar meeting. I've seen the program and I've heard some of the talks, and I really congratulate you to put all these things together, which is not easy. So I will copy the title that my good friend Stefano Ferraresi from Italy asked me to speak about, which is this one: the syndrome of the orpheline. How did I overcome not to be a renowned vascular or skull-based surgeon? This is the title of the talk he asked me to give a couple of months ago in a European meeting. So the answer actually of this question is very easy. I would never have been able to be a renowned vascular or skull-based surgeon. But let me put this question in another way. Peripheral nerve surgery, is it as important as, for example, clipping an aneurysm or resecting a brain tumor? That is the question. So I remember many years ago, I was clipping an aneurysm in a young lady. She had an ACOM aneurysm, and when I was clipping it, I was wondering myself, do I want to do this for the rest of my life? Because is this what I really like? I don't know. I want to thank my chief of resident at my hospital in Argentina, who gave me this video. But anyway, let's speak just a few minutes about ego and neurosurgeons. Because ego, as you know, we all have a big ego as neurosurgeon, and it might be helpful, of course, to develop, to progress ourselves, and to become better. When we decide to be neurosurgeons, we all want to be like Yasagi. We all want to be the best one. And we all want to take out very difficult tumors or clip very difficult aneurysm or do very difficult tasks. That's why probably many of us decide to go into this specialty. But in some cases, ego can be a very heavy weight that make us move slower. So my humble advice would be to get rid of the ego and do what you really maybe want, like. So let me state this very, very clearly, because this is the most important message of my talk. Neurosurgery improves very importantly the quality of life of our patients. So the message is, do neurosurgery. As neurosurgeons, we shouldn't forget about doing neurosurgery. It is a very important part, in my view, of course, of neurosurgery. So my objective during this talk will be trying to convince you that neurosurgery is worth enough to be done by neurosurgeons. But why is that? Because you earn a lot of money? Because no one does it? Because no. The reason is because the results of neurosurgery are quite good. In fact, you can recreate neurological function where it was really lost. I mean, maybe a tumor compresses in the brain some structures, and you, after taking out the tumor, the function recovers. But in nerve surgery, you really create new function. Why? Why is that? Because we as peripheral nerve surgeons, we work with axons. We don't work with neurons. And that's just as simple as that. So I'm going to give you some examples about what I'm talking or trying to convince you. For example, let's see a brachial plexus lesion. This is a typical C5, C6 upper type lesion where you will have your patient without movement on the shoulder, on the left side in the shoulder, and also he will have no elbow flexion. I'm going to take out the sound, and you will see here, this is pre-op, and after the surgery, he moves quite normally, not perfect, but quite near to normal, the arm. So this is a typical result of a brachial plexus surgery upper type. I won't be very technical, that's the surgery, and there's another part of the incision in the supraclavicular space. I won't get very technical. This is not the point of my talk. The point is to try to convince you to do this type of surgery. And what about complete brachial plexus surgery, where you have all the flail limb and you have no function at all? This is the typical situation, typical complete palsy and complete anesthesia in the right limb. As you can see, there's no movement at all. So this is a complete tragedy for a patient. Okay, in complete brachial plexus injuries, it is very difficult to reinnervate the hand. And this is not let's say, a surgical problem, because the axon speed of growing is 1 millimeter per day. So if you have an injury here, you have to wait all up to here, well, the axons get, and they get there to the hand maybe 1 or 2 years after the surgery. So when they get there, the muscles are atrophied. So you can expect good results proximally in shoulder and in elbow. So I'm going to show you a lot of pictures and a lot of videos showing the patients waving their limbs. And you can say, oh, wonderful, this is a very good result. I really like it. This is good. Okay. But this is not the point, because I don't want to show some people waving their limbs. The thing is function. How can you impact this surgery in the function of the patient? The most important thing is that they get bimanual. They get bilateral handed. You see? Which was the paralyzed limb? It was the left. But anyway, he can hold something with both hands. This is using brachial plexus surgery. You can see in this patient, again, moving the limb, but here he can hold something with two hands. So you can add here many other orthopedic surgeons like wrist flexion or shoulder or shoulder arthrodesis. But anyway, look at this patient especially. We did a very simple surgery, which is intercostal to musculocutaneous for elbow flexion. You see, elbow flexion is starting. He's at our gym, making some exercises. His name is Lionel, like Lionel Messi. He's a champion of the life. So we did just, as I said, just a very simple surgery, intercostal to musculocutaneous. And then we did a shoulder arthrodesis and a wrist arthrodesis. And look at him many years after the surgery. That's 5 or 6 years after. And this is very actual. Look, we had in the COVID pandemic, we are all like in the third world. We don't understand what's going on. But anyway, look at this. He can use his previous paralyzed limb for doing many, many things. For example, he can hold his wallet, so he can use his limb as an assistant limb, and this is quite important. Again, I was talking about the pandemic. Look, a simple act like washing your hands or putting alcohol on them, it's helped by this surgery. So be aware that you can really impact and you can really change the life of your patients. Look at here, using or putting face masks and some other things. So some other things in the domestic life that he can do now, even not being normal. Brachial plexus surgery is important. You have to be trained, especially for this surgery. It is not that you can start from zero. You have to go to a center, start training, see people, go to congresses. It takes some time to be correctly trained in this surgery. But anyway, it is not absolutely not impossible. It's perfectly possible. You have to have some anatomical knowledge and some other type of knowledge, but absolutely perfect. So the solution for the hand is still in progress. And my friend Oscar Assmann, he's a plastic surgeon from Austria. He's doing a special work on this. He's doing a reinnervation of the forearm muscles, and then he makes a special orthesis, for this function. He trains the people, and then he uses this bionic orthesis. So there's still a lot of things to do. Let's speak about now facial palsy, which is, as you know, a common sequel of brain stem or vestibular schwannoma surgery or many other things. So what we do is hypoglossal to facial nerve anastomosis. You can use the masseter, you have many possibilities, but we usually do this surgery that gives us more than 90% of good results. So we drill the mastoid bone and we take the facial nerve and we go to the hypoglossal. We just take half or 1/3 of the hypoglossal, and then we get good results like this. This is pre-op and this is post-op. So the patients get a very good result. And this is in more than 90% of our cases. More cases, pre-op on the left, as always, post-op on the right. Same thing. Pre-op with a facial palsy in the left side, and this is post-op. But the facial nerve is not the only cranial nerve that can be reinnervated. For example, you can reinnervate even the trigeminal nerve. For example, if you have a corneal anesthesia, you can use the other trigeminal nerve to reinnervate the cornea. This is a sensitive reinnervation. So if you have a denervation of the cornea, for example, after taking out a tumor, you can solve this with a corneal neurotization, which was described 10 years ago and was developed lately by Gregory Borchel, also a good friend from the Sick Children Hospital in Toronto. So as you can see, what we do is using the normal nerve, which is A, to put a graft and take that nerve into the denervated cornea. B would be the graft, and the denervated cornea would be in the right side of your screen. That means the left side, the left eye of the patient. So you see here the surgery, you make double incisions in the eye, in the eyelid, and then let me show you. This is, we are cutting now the donor nerve, and this is the sural nerve, which has as a graft, and we then use some gel foam and some sutures to make the nerve suture. And once you make the nerve suture on the donor side, in this case is the right side, then we go to the eye. In this part, we spread the donor nerve, the sural nerve, in 4 parts. And now our colleagues from ophthalmology start to work on this part. What we do is go to the sclerocorneal limb and put the graft right near the cornea, very, very near the cornea. So as usual, the most difficult part is done by the arm body of the patient. They need to make the graft grow into the cornea and reinnervate it. So the results are really good of this technique also. And you can expect, now they are closing. This is the ophthalmological part of the surgery. And you can see this patient, she had also a facial palsy, which was reinnervated. But look at his left eye. You see something inside? Those are the grafts. You see directly the graft. So the donor side on the right, receptor side, and denervated side left. So there are clear signs of corneal reinnervation, tactile perception, and positive corneal reflex. Can we call that corneal reflex? I don't know, probably not. But anyway, you can make this objective using this in vivo corneal confocal microscopy. So this is the way to make objective this corneal reinnervation. Let's go to another procedure that is very useful. If you have a vocal cord palsy, for example, after extracting a tumor and you have some lower cranial nerve palsy, you can reinnervate the larynx. And for example, if you have an inferior laryngeal recurrent nerve, you can reinnervate using the hypoglossal nerve. In fact, the ansa cervicalis, which is exactly not the hypoglossal, but let's avoid this anatomical discussion. So you see here a paralyzed on the left cord, a paralyzed cord, which of course can occur after neck and head surgeries, after thoracic surgeries, after resection of a skull-based tumor, whatever. And you will experience phonation and swallowing affection. So the classical solution is thyroplasty. So you put some Teflon in the cord, you make it gross, the vocal cord, and then, well, it's done. But anyway, there are some not so new techniques like this one designed by Roger Cromley, which is an ENT surgeon from USA, and also popularized by Jean-Paul Marie from France. Anyway, the thing is to use the ansa hypoglossy to reinnervate the recurrent nerve, which is denervated. So let me put the volume. Okay. And this is the typical voice after recurrent nerve palsy.
Mi nombre es Paula Trejo, tengo 43 años.
You see?
Me operaron en julio del 2018.
She has dysphonia. So I'm going to take out the sound. You can see here in a laryngoscopy the vocal cord palsy, which is very clear on the right side. Okay, so we go to the surgery. This is the patient, and using a cervical incision, we can expose the ansa cervicalis and also the recurrent nerve. They are very near. The thyroid gland is right here in the upper part. That's the thyroid gland, that's the parathyroid, and that's the receptor, the recurrent, and that's the donor, which is the ansa hypoglossy. So all you have to do is make a nerve suture between those two nerves, which is actually under microsurgery, very easy. You see here the nerve suture, and let me put the sound again. This is.
¿Cómo es tu nombre? Mi nombre es Paula Verónica Trejo, tengo 44 años.
Sí, decir los meses, a ver.
Enero, febrero, marzo, abril, mayo, junio, julio.
¿Qué pasaba cuando tragabas comida antes de la cirugía y después?
Antes de la cirugía no podía porque tosía mucho, me ahogaba. Me ahogaba con los líquidos y con mi misma saliva en la noche mientras dormía.
So what she's doing is explaining that before the surgery, she had swallowing problems, and she recovered all that after the surgery. Of course, that was in Spanish for those who didn't understand the language. The cord is not perfect. You can see it is still paralyzed, but it's medialized. So under this medialization, you can expect to see this amelioration of the symptoms. So if we want to compare pre-op and post-op again.
Mi nombre es Paula Trejo.
This is the
Tengo
voice
43 años.
before the surgery.
Me operaron.
And this is after the surgery.
¿Cómo es tu nombre? Mi nombre es Paula Verónica Trejo. Tengo 44 años.
It's a very important improvement
Enero, febrero.
of the voice. So let me remind you about this. Muscle atrophy is the worst enemy of a successful reinnervation. So if we wait more than 1 year, muscle atrophy could be irreversible. So if you're planning to do a nerve surgery, whatever it be, a nerve repair of the median nerve, ulnar nerve, facial palsy, brachial plexus, whatever, you have to decide, and you got to go forward as soon as possible, before 6 months, if possible. This is the correct timing of this surgery. Timing is an important factor. And sorry, I'm going to take out the sound. Trauma is only 1/3 of the nerve pathology. Do not forget tumors and compressions, which in fact are also very, very frequent. You can see this neurofibromatosis patient who had a ulnar nerve palsy. A median nerve tumor. You see here, and again, under the well-trained neurosurgical hands, this is a very easy procedure where you can save all the nerve and extract completely the tumor. So the patient, if this is a benign tumor, the patient will be cured. So you can have also a good result. You can help the patient, you see. You preserve the nerve. This is a typical neurosurgical. This is the fascicle of origin of the nerve. This is a typical resection of a tumor. You see how it spreads the nerve by the tumor. So you have to preserve the nerve fascicles. And dissecting them as gentle as possible, you can obtain a good resection with no neurological deficit, even being such a big tumor like this one. You see here the tumor after the extraction and the nerve. And this is the patient. No sensitive deficit, no opposition deficit, mediated by median nerve. You see here, good opposition. So no added neurological deficit. That's the incision. So do not forget, it doesn't stop in trauma. Also, you have peripheral nerve tumors and nerve compressions, which are also very, very, very frequent. Of course, and I'm finishing my talk, I'm not specially skilled because talent is many times overrated. All the results that you saw are fully reproducible in any experienced peripheral nerve center by any well-trained peripheral nerve surgeon. This is important to say. It is not that I'm showing extremely good results of a wonderful, no. If you train, you can obtain these results. And that's another message I wanna give to you. So neurosurgeons should do neurosurgery. As I said, because you help the people, And we have some advantages because neurosurgery is performed by, very well done, by plastic surgeons, by orthopedic surgeons, by hand surgeons. So they are, of course, they are well trained and they get also good results. But as neurosurgeons, we have some advantages over them. We know how to handle very perfectly nerve tissue. We're born with a microscope in our hands, so we know how to make microsurgery. From the beginning, they have to train, especially for microsurgery. We perfectly know how to make neurological physical examination, are some of the advantages. But on the other side, we lack orthopedic and plastic knowledge. So if you are going to be trained, you have to get some new knowledge in orthopedic, in functional, in plastic knowledge that is important. Also, it's important to work in a team. This is our team. It's there is an orthopedic surgeon, Gustavo Niso, a physiotherapist, Danilo Battaglia, and two other colleagues, neurosurgeons. They are at the University of Buenos Aires School of Medicine, Gilda Di Masia and Gonzalo Bonilla. And this is a normal situation in our office with many people, even the ultrasonographist over there at the end, seeing what we are doing and studying the patient. So in conclusion, in order to finish, neurosurgery improves very importantly the quality of life of our patients. Please, please do neurosurgery. It is important. I want to thank my family, which is here, and from Buenos Aires, Argentina, which is my beloved city. I want to thank you all for your attention.
Thank you very much, Marino. That's absolutely fantastic lecture. As I mentioned, I'm sure that you know, if not all, most of them in the audience now have got the bug for peripheral nerve surgery. There are a couple of questions, but before I come to the questions, can I just get Professor Grottenhuis to give a comment while I read through the questions? Thanks, Prof. Grottenhuis.
Yeah, thank you. Well, I listened with great pleasure and to this lecture. I always considered peripheral nerve surgery being part of neurosurgery. And that's not only carpal tunnel syndrome, ulnar nerve compression, or other compression syndromes, especially this. And unfortunately, we realized that many neurosurgeons only think about either brain surgery or spine surgery, but this is the third leg. This is peripheral nerve is very gratifying. It's not always that way. I mean, there have been some studies that objectively the results were good, but subjectively the patients were not so satisfied. But that was mainly due to, I would say, bringing the right expectations to the patient. Because if you look, of course, after a complete plexus palsy, you have a useless arm. And there have been even periods in times when the arm was just amputated because otherwise it was a burden to the patient to have this floppy arm hanging on the body. And now, with this kind of surgery, we can bring back bimanual use of your arms. I mean, that's incredible. I even consider this more spectacular than removing a vestibular schwannoma or a brainstem carcinoma. This is for the life of the patient. That is invaluable. I know these patients and I've seen those patients, and it is a long way. You have to, and that's also the nice part of this. You become a companion of your patients. You don't see them only once or twice. You see them for 1 to 2 years and many long time after that. Because you have, I always tell them, we have now to travel the road together. If we start to doing this, it will not be an easy road because it takes a long time before this will really go. And therefore, sadly, we as neurosurgeons, often see patients 2, 3, 4 years after a trauma or after a lesion, facial nerve palsy, and so on. I think we should educate our younger generation and also neurologists to please send them as early as you can. And sometimes they complain. They said, I sent them to you a week after the trauma, and after 6 weeks, you still not have operated on them. No, but they are now with us, and we can make the right decision for the right timing and the right kind of surgery. And I have to tell them often, sometimes it's not only one surgery. So it is a road traveling together with your patient. And I think as a medical doctor, not only as a neurosurgeon, as a medical doctor, that is one of the best things there is. I even think that restoring function is part of the essence of doctoring. So thank you very much.
Thank you, Mariano. Can I give you give you a response to Professor Grotton-Hughes? Thanks.
Yes, dear Professor Andre, thank you very much for your kind words. And I completely agree with this wonderful comment that you made. The expectation should be in the right place. So if you say to a complete brachial plexus patient, well, don't worry, you will be great in 1 year. No, then you are raising the expectation so high that he will never get to those expectations that you put.
Ollie's nails
On the other side, if you if you
there is a mix-up of tones.
Sorry. Yep. That's okay.
It's okay. So if you put the expectation in the right place, then the patient will be satisfied. And the last thing, when we start the treatment, which is long, as you said, it takes many years, you have to say to the patient, okay, the treatment does not end with the surgery. It starts with the surgery. We need a lot of rehabilitation. We need a lot of work. We need to see each other for the next 2, 3 years or whatever it will take to recover. So this is important. And what you said was absolutely correct. And I do absolutely agree.
And also not only sending them to rehabilitation and then forget about them. You have, as a surgeon, see them also, because they put the faith into you as the surgeon. And you therefore have to follow. You send them to physiotherapy, to rehab, to many others, and they are involved, absolutely, let's say, with this neurotization of a corneal anesthesia. I never heard of it, and that's incredible. I mean, because this is a very big burden. People get blind from that, from corneal also. So it's just incredible to see that. And I really very much appreciated that. And also this lady with improvement of the voice, and also her breathing was clearly improved, because that is also, these people are short of breath. So we consider that as a minor complication. No, it is not minor at all in the eyes of those that have this. So no, really, I think this is really close to the essence of our specialty. So thank you so much. And I think Naren was right. You have convinced people to do peripheral neurosurgery. And I always have fought for it. And here in Europe, we have Lukas Razovic from Serbia, from Belgrade, who is very much promoting also peripheral nerve surgery being essential part of neurosurgery. We should keep this field and never leave it only to others.
Thank you very much, again, Professor. Thank you, Professor Grotton-Hughes. Thank you, Professor Sokolovsky. Just before I move on, there are a few questions for you. If you could please answer it on the chat box for the reason of time. I think your resident who came to neurosurgery in Royal London, she wanted to do peripheral nerve surgery, so you certainly have converted there. And just to remind you that Majid Sami was a peripheral nerve surgeon in Mainz before he moved to Nordstedt and became a skull-based surgeon. So techniques are not that different. Thank you very much. So we'll move to the free paper. Thank you very much. Much obliged. So we'll now move to the free paper. So I'm now going to invite Dr. Munoz Garcia Araceli. She's going to talk to us about epidermoid cyst of the anterior lateral cisterns of the brainstem treated with a minimally invasive subasterional approach. Dr. Munoz, do you want to share your presentation? Thanks. And she's coming from Mexico. Thank you. We can't hear you, Dr. Munoz. Dr. Munoz, we can't hear you.
And can you hear me now?
Yes, we can hear you, yeah.
And can you see my screen?
Yeah, we can. Yep.
Okay, let me start. Good morning, my name is Araceli Munoz Garcia, and today I'm going to talk to you about epidermoid cyst of the anterolateral cistern of the brainstem with a subasterional approach block type. I'm from the research unit of Neurologia Segura from Angeles Hospital in Morelia, Mexico, and we do not declare any conflict of interest. The tumors of the cerebropontine angle are a group of tumors located between the tentorium of the cerebellum, the pons, and the tip of the petrous bone. They represent about 1% of the intracranial tumors, with the epidermoid cysts being half of them in our series. These slow-growing tumors have an embryonic origin and manifest symptoms in about decades of life. About 1.5% of our patients with clinical symptoms of trigeminal neuralgia are associated with the presence of an epidermoid cyst. Trigeminal pain is a triggering symptom while patients come to us to seek for help, and the study of choice is magnetic resonance. And the treatment for this specific entity represents a true challenge for the neurosurgeon because there is no consensus about the best treatment options. Here in this image, we have a simple magnetic resonance with axial slide at the level of the bridge in a 3D Fiesta sequence. And here we can see an extraaxial nucleation in the left cisternal space with displacement of the trigeminal nerve. Well, our objective is to present a case of series of patients operated to remove the epidermoid cyst located in the anterolateral cistern of the brainstem, and also to describe our operative technique. Well, on patient and methods, we have a descriptive retrospective observational study, and it was from January 2011 to October 2020. We studied the medical records of 1,996 patients treated at our institute, and all patients present a clinical and imaging diagnosis of neurovascular compression of the cranial nerve, it manifesting as a trigeminal neuralgia. In any of the two clinical presentations, we know we have paroxysmal pain or typical trigeminal neuralgia or paroxysmal with continuous persistent pain, and other manifestations including fasciopharyngeal, glotopharyngeal neuralgia, occipital neuralgia, dysfunctional hyperactive syndrome, or vertigo with tinnitus. And all cases were classified by their three etiologies as classic, idiopathic, or secondary. And we have the distribution by age, gender, pre- and post-operative image studies, post-operative evolution, and the follow-up was 6 months, 12 months, and annually. Well, talking a little bit about our surgical technique. First, we position and bird the patient, marking the craniometric point and position of the patient in the operating room. We mark the retromastoid surgical site. We position the patient with a 0.1 angle with limitation of the neck rotation 2 for 49 angle. In step 2, we made a skin incision. It was about 3 centimeters in the retromastoid region. Then we have a soft tissue dissection, dissecting until we reach the cervix of the skull. In step 4, we disinsertion of the muscular upper nautical plane. And later we do subasternal craniectomy and also a dural. We do the depletion of the posterior fossa and cerebellum. Also, we made the tumor resection. Then we treat in the implant area, and finally we do the duroplasty. In this image, we can see the right subasternal approach under a microscopic vision. In this picture, we saw a subasternal craniotomy, durotomy, and the exposure of the tumor surface with a pearly appearance in the cerebellopontine angle. And in this one, we see the incision of the pseudocapsule and the bulking of the tumor. And then we deplete of the cerebellum without use of retractors. We see the appearance of the superior venous complex and the cranial nerves priori. And we do the appearance of the tumor bed with exposure of the facial nerve. Well, talking a little bit about our surgical research, we have that of all the 1,996 patients. A secondary etiology was established in 308, of which 29 were epidermoid cysts. We exclude 3 patients who present as epidermal cysts extending to other chiasmatic and supratentorial cistern due to surgical method and risk of operating on them are totally different to the cerebellopontine angle approach. So we left with 26 patients. In this patient, the intratentorial location was determined, and either in the posterior fossa or anterior cistern were located. And only 6 patients underwent surgery in another institution and currently present with residual tumor pain and are going under pharmacologic treatment. Almost immediately after tumor diagnosis, 18 patients were operated at our institution using a minimal invasive technique. The cyst was removed completely or as completely as possible, leaving the implant attached to the brainstem or vascular structure due to the high risk of complication or death. The remaining 2 patients were not operated on as their pain continued to be adequately controlled with medication. The total removal of the tumor was achieved in 11 patients with excellent surgical results. A total resection was considered as the removal of the squamous content, the pseudocapsule around the tumor, and its integrated implant. The subtotal resection occurred when the friable content was excised, with visible remains of the pseudocapsule or implant. In the remaining 7 patients, it was decided to remove the implant strongly adherent to the neurovascular structure due to the high risk of causing a neurological lesion. Only 2 patients presented a surgical complication due to cerebrospinal fluid leak that required reopening and duroplasty in other institutions. In 2 patients, an MRI showed residual tumor growth at 1 year as follow-up with a size of 2 cubic centimeters without any clinical manifestation. In the immediate postoperative, we we evaluate our patient. This is a maneuver during the clinical examination of 48 hours after her minimal invasive surgery. And here we can see that the lumbar manner was without any alteration. There are facial and extremity motor integrity. The eye movements are without limitation or of the angles in the conjugated picture. And well, we can see that it's a very entity, but up to 1 to 3% can be a secondary cause of trigeminal neuralgia. In the past, it was said that because it is an entity derived from embryological tissue, it can be present on early stage of life. But now we can see that it can be present on elderly patients too, as we showed you before. And also we can say that it has an excellent and very good immediate postoperative clinical result. With respect to tumoral removal. And this MRI is the one I showed you before. In the slide below, this is a postoperative MRI where we can see that the tumor was removed and the system is entirely free. Well, in conclusion, in our expert opinion, we consider that the minimal invasive subbacterial keyhole approach is an alternative microsurgical approach that should be considered as their first option in a case of 0.9 angle tumor of the Epidermoid cyst type. And due to the rarity of this entity, we recommend that the neurosurgeon interested in treating this subject should be trained in a laboratory with a cadaver software for 3D virtual surgery, and it should go under the mentorship of an expert neurosurgeon to resolve the contingencies of the learning curve. And well, that's all. Thank you for your time.
Thank you very much, Dr. Munoz. That's an excellent presentation, a fantastic, huge series and large number of CPA angle epidermoid. I've got one question, then I'll ask Professor Iaconangeli, as well as I see Professor Benedetto Colli, the doyen of Brazilian skull-based surgery there. If we can connect, that would be great. How about how much chemical meningitis did you get after, or hydrocephalus eye did you get after removal of these epidermoids? Thanks.
CSF leaks is still a problem in every approach, endoscopic, retrosigmoid.
Dr. Segura, in terms of actual spillage of epidermoid, did you get any chemical meningitis or hydrocephalus in any of the patients? Sorry, your mic, thanks.
Yeah, thank you, Nari. Good morning from Mexico, good evening from London. Not really. From this large series, we have not experienced this chemical meningitis. I know it's a very rare case reported, and in every single case, we, at the beginning, open the pseudocapsule, and never we experienced this chemical meningitis.
That's great. Thanks. Thank you. Maurizio, Iaconangeli, do you have any comments about the approach on?
It's good. It's in some cases you can use, and these are quite rare cases. So, good job.
Well done. Thank you very much, Dr. Munoz. Thank you very much, Professor Segura. And if you have any questions, please put it on the chat box. We will now move to the next presentation. It's from Italy, from selective vestibular neurotomy for intractable Meniere's disease in the era of endoscopy and intraoperative advanced neuromonitoring. Recent experience and technical notes from Dr. Fabrizio Salvinelli. Is Dr. Salvinelli there? Because I'm trying to find.
Oh, I will present the. Okay.
Thank you, Dr. Gregor.
The presentation. Thank you.
I shall put you to be able to share your presentation. You can now share your presentation. Thank you.
Okay. Do you see me? Do you see the first slide?
We see you, but not the slide yet.
Okay, just a moment. No, eh? Do you see the slide?
Not yet. Are you able to click on that green button to share on the bottom of the screen?
Hai premuto su, Fabio, su share,
share screen.
E condividi lo schermo o la presentazione.
Ok, sto facendo share.
Good, excellent. Well done.
Si vede?
Yeah, absolutely.
Metti la presentazione globale, modo presentazione. Ok.
Thank you very much.
You see?
Yeah, absolutely.
Okay. Nice to see you all in this virtual presentation. This is our experience from Department of Neurosurgery of Università Politecnica delle Marche, directed by Professor Jacopo Angeli, and Department of ENT Surgery, directed by Fabrizio Salvinelli. Together, we constitute a division of otoneurosurgery and skull-based surgery at Campus Biomedico University of Rome. The selective, I will speak about the selective vestibular neurotomy for intractable Meniere's disease. Meniere's disease has a lot of treatment. First of all, diet and medical therapy, where no social hearing residual is present and no control of vertigo with medical therapy is archived. We can go with intratympanic gentamicin injection. If residual social hearing is present or no control of vertigo with injection of gentamicin, we can perform a decompression of endolymphatic and duct and sac decompression. If still no control of vertigo is archived, we go for selective vestibular neurotomy. Then the first verified the real effectiveness of selective vestibular neurotomy in refractory Meniere's disease. But that was had a lot of morbidity and factor in complication at the time. The aim of vestibular neurotomy is only to control vertigo while preserving hearing function and facial nerve function. Nowadays, endoscopic magnification and advanced intraoperative monitoring may contribute to maximize the complete section of vestibular nerves. In this slide, we can see the figure of vestibular nerve, facial nerve, and fifth nerve, and neuromonitoring of the facial nerve. The aim of surgery are a complete section of vestibular nerve, sparing the cochlear and facial nerve, and be careful, an incomplete vestibular differentiation results in a failure to control vertigo after surgery. continuous and stimulated EMG of facial nerve intraoperative hearing monitoring are useful in facial and hearing preservation. Our series is of 28 patients who underwent a combined microendoscopic selective vestibular neurotomy. All of them was previously treated by DSD, so duct and sac decompression. Vertigo disappeared in 24 of 28 patients. 3 patients showed a feeling of dizziness and occasional tinnitus, and 1 patient remained unchanged, maybe for incomplete vestibular nerve section. A mild worsening of auditory function occurred in 1 patient, and we had 1 complication in CSF leakage resolved by surgical revision. We performed this surgery via a presigmoid retrolabyrinthine approach. This has some advantages. First of all, a direct access to the cerebellopontine angle with a minimal cerebellar retraction. A possible, moreover, a possible better working angle for vestibular nerve section toward the 5th nerve, and early and better identification of the facial nerve, and since all of our patients previously were submitted to DSD, part of this approach was already done. In this slide, we can simulate a retrosigmoid view, the angle view of a retrosigmoid approach and the angle view of a presigmoid approach. The presigmoid retrolabyrinthine approach may offer a direct view on the target vestibular nerve section area facing the 5th nerve without any cerebellar retraction, along with a potential better initial identification of the key anatomic landmarks. The success of the surgical procedure depends on identification of the cleavage plane between the cochlear and vestibular nerve of the 8th nerve. And this is this cleavage plane is signed by a fine arteriole and by a different coloration of the 2 nervous components, grayish white for the vestibular nerve and pure white for the cochlear. In this procedure, grit help come from endoscopy. A third key point is that the vestibular nerve section should be performed as close as possible to the brainstem toward the 5th nerve, where these nerves are still in a clear anatomical position. In this video, we can see the microscope field of view, a very limited field of view, and this is the vestibular nerve, the 5th nerve, and part, and this is a look around the corner of the vestibular nerve. Here we can see the intermediate nerve, the facial nerve, the apical loop, the abducent nerve, and then this vein. Subsequently, we see the arteriola we speak about. Hydrodissection can be useful in separating fibers, the 8 nerve fibers, and here we can see the vestibular neurotomy performed. In conclusion, the selective vestibular neurotomy, in our experience, conducted via pre-sigmoid retrolabyrinthine approach, could represent an inadequate and safe procedure for intractable Meniere disease with a serviceable urine function. This procedure is characterized by a low rate of complication at about 86% of complete vertigo control after surgery. Mild symptoms were present in 10% of cases. The use of endoscope technique and intraoperative monitoring may guarantee a complete selective vestibular neurotomy, saving facial nerve and cochlear fibers with complete hearing preservation. And the success rate is most important of the procedure is due to the complete differentiation of all vestibular nerve fibers. Thank you all.
Thank you very much, Dr. Greco. That's beautiful work. I've got some skull-based surgeons here, so I'll try to see whether they can comment. But before that, I've got a question for you from, I thought I had a question, yes, from Dr. Parekh. Dr. Parekh, do you want to ask it yourself? Thanks.
Yes, thank you. It was a nice presentation. As I see, you've done a vestibular neurectomy, selective vestibular neurectomy. Peter Jaretta described this by showing the vascular compression around the vestibular nerve. And he has described the separation of this vascular loop and putting a graph between the nerve and the vessel. So displace the vessel. And he has shown a very, very good results. I'm not too very much experienced about intractable vertigo. Of course, we do a lot of hemifacial spasms and MVDs in the same principle of decompression of the nerves. Can we not apply the same here? It has already been described, rather than just doing a neurectomy. And my experience is not too good in that, but just a question mark in my mind. So I asked you. Thank you.
Maurizio,
can I answer, Dr. Parekh? Because in our experience, we almost never see, it's true that even in intrageminal neuralgia, you cannot find a real neurovascular compression, neurovascular conflict. But sometimes you see a loop of ICA, a group of vein. In this case, we almost never see vessel abnormalities. So I really I would not say what to do if you don't see any anomaly in vessel. But doing these are of course extreme cases. So we really intractable Meniere disease. It is not the first option. But looking at intraoperative anatomy, I have no one, almost only maybe one case, two cases in which there was some vessel loop. In no cases we had vascular anomaly. So it's impossible to put something that you don't see. That's simple.
Thanks. Thank you very much.
Right.
Thank you, Dr. Parekh. Thank you, Professor Aikananjali. Any comments from Dr. Gentili? Welcome, Dr. Gentili. You have to unmute, Dr. Gentili.
So thank you very much, Naren. No, I must say, don't have any comments. It's not a procedure I do.
Good, thanks. Thank you very much. Thank you for again, Dr. Greco and Professor Aikananjali. I think the next presentation is also from Dr. Greco. It's minimally invasive surgical options for treatment of medium to large vestibular schwannomas, technical nuances. Thank you.
Dottor Narentian, Professor Iacoangeli.
I will present.
Thanks. Thank you. I'll just. Dr.
Thank you.
Thank you. Dr. Greco, you will have to take unshare so that Professor Iacoangeli can.
Fabio, togli lo schermo.
Sì, sto cercando.
We can see your talk.
Chiudi la presentazione, va via da solo. Ok.
Ho bloccato tutto? Si vede ancora lo schermo?
Sì.
It was there, but it disappeared.
Just a moment.
Thanks. Is it on my side? Is it Dr. Greco's computer that's going to output the PowerPoint? Hello, Professor Iacoangeli.
Okay, Naren, I'm here.
Great. Great, thanks.
I try to share my screen.
Brilliant. Yep, I'll. Yep, you should be able to share it now.
Okay. Can you see the presentation?
Yep.
Okay. Thank you, Naren. Thank you to all my friends. And this is very nice initiative by Naren. As usual, is very educative in this very sad period. I will present our experience on medium to large acoustic neuroma, actually vestibular schwannoma, experience done with my colleague in the university campus university in Rome. So there is some connection between Rome and Ancona. As usual, in our clinical practice, we have a lot of different choice in selecting the approach, as you can see here for the cerebral pontine angle. And we have to try to select, as we discussed before, the right approach. Of course, during these years, the philosophy changed. Of course, in the dandy period, the caching period, if you saved the life of the patient, it was a big success. Now, if the patient has some decibel of hearing loss, had some complaints. So our clinical practice is changing. We try to maximize, of course, the removal of the tumor, but even pay attention to the details, aesthetic details. Sebastian Fröhlich talked about aesthetic craniotomy. This is true. We learn this technique by Akuba in doing the preventing the drilling of the external bone that can be replaced at the end of the procedure. And as you can see, the final reconstruction is quite aesthetic. So this is important to take into consideration. The presigmoid retrolabyrinthine approach to the cerebellopontine angle is an option. Of course, most of the time we already perform the retrosigmoid approach, but in doing for example, the selective neurectomy, we found that this approach allowed a direct vision of the CPA, and without or with very minimal cerebral retraction. That's the problem. And with an easy identification of the structure, especially the most anterior one, anatomical structure. And of course, if it's necessary, it can be combined with the retrosigmoid and translabyrinthine approach. The main drawback is the poor exposure, of course, of the internal acoustic canal because of the labyrinthine, the semicircular canal. In this way, we started to use the endoscope. This is the same slide already Dr. Greco presented. We simulated, this is a presigmoid approach. We simulated the vision of the presigmoid approach and in the upper part, the retrosigmoid approach. As you can see, with the presigmoid approach, you almost see the internal acoustic meatus. That is quite hidden by the nerves and the artery from behind. And here you can see even the intermediate nerve and the sixth nerve. This is a vision much more direct and much better than the retrosigmoid. This is one of the small advantages, but it can take into consideration. The second advantages using the endoscope is that we can reduce the drilling and opening of an internal acoustic canal in order to reduce the risk of CSF leaks and loss of hearing because of damage of the semicircular canal and the lymphatic sac. The risk, it can be that the endoscope can be introduced by the use of the microscope that can offer much more confidence. This is actually not really an endoscopic technique. It is most of the time microsurgical technique, but the endoscope in some phases of the operation can really be of great help. Of course, the first step is the exposure of the Trautmann triangle, sparing the semicircular canal. But the secret, and this is a quite small opening, as you can see, is less than 4 centimeters. But the real secret in this approach is the complete skeletization, the complete exposure of the sigmoid sinus from the jugular bulb to the middle fossa, because that's essential and skeletonize the labyrinthine in order to gain even a few millimeters, because as you can see, this is a really narrow approach. It's like a fissure. And we need to displace the sigmoid sinus in order to get a better vision. That's important. That's the two main points. And the second surgical step, of course, is the endoscopic exploration of the internal acoustic meatus, as you can see, and try to reduce or limit the drilling of the internal acoustic canal. As you can see in this video, because there is a safety zone with two main structures that you have to preserve, the jugular bulb and the endolymphatic sac and semicircular canal. But we have some anatomical measurements, some landmarks, but there is big variation, and sometimes it's not so easy to identify all the structure that can be preserved in drilling the posterior wall of the meatus. And with the help of the endoscope, as you can see in this short video, we can limit the opening of the canal just as necessary as we can see the tumor with the microsurgical view and with the endoscopic view. The last part of the tumor viewing by the endoscope can preserve a bigger opening of the bone in order to save the structure. This is another potential use of the endoscope. This is the results of the illustrative case. As you can see in the immediate postoperative CT scan, this is the way with almost no damage of the cerebellum, and the possibility to reach, this is there, the internal acoustic meatus with a good angle of vision. So in conclusion, the endoscopy-assisted pre-sigmoidal retrolabyrinthine approach is an option. It can provide two main advantages. One, a direct vision, direct access to the CPA, and with minimal or very limited cerebellar retraction. Of course, the limit is the vision inside the internal acoustic canal, but this can overcome by the endoscope. And this can be an option, and is also possible even in case with such a big tumor to preserve the facial nerve, and in some case preserve the hearing. Thank you for your attention.
Thank you very much, Professor Aikananjali. It's very elegant. It's very impressive. I would like to invite the skull-based surgeons to give their commentary. Professor Fred Gentili, could I ask you to give your thoughts? Thank you.
Thank you, Naren. And it's very interesting, as we see in terms of skull-based surgery. I've never done a retro, at least translabyrinthine approach. And I know I have colleagues. It's an excellent approach. The various options to that has significant advantages. And you know, I just, as I say, personally, have always done a retrosigmoid. And it has its disadvantages, as noted there, in terms of the degree of cerebellar retraction. So I always say that you must do what is best for you, what your results show to be, you know, adequate results for you and the patient. So there's no such thing as you must never do this this way, or you must never do it that way. And so I have colleagues who do retrosigmoid all the time. This is a nice variation, and I think is a valid option.
Thank you. Thank you very much. Professor Arath, can I just get you to, have you tried this approach? Did Dr. Sherker come up with this approach? Thank you.
Thank you very much. First of all, let me say that it's a very nice and elegant and anatomical presentation. I have the same opinion as Dr. Gentili, because I've never done only in cases, in certain cases, usually not acoustic neuroma. I have been using some endoscopic procedure as a gentle tool, but I do classical microsurgical retrosigmoid approach with microsurgery, and we do not use a translabyrinthine approach for acoustic neuroma. So I don't have much experience about that.
I have the experience because the good collaboration with the ENT colleagues. Otherwise, I never had such experience. So you need, of course, to share the experience with the ENT. But of course, most of the time I perform the retrosigmoid approach. This is something that can use because of this friendship.
That's great. Very nice, elegant. Thank you. Professor Colley is here, but I don't know whether he's able to connect. Professor Benedicto Colley. I hope I can bring Professor Colley for the next, to comment on the next talk. The next talk is from Dr. Mauro Segura from Mexico on minimally invasive microsurgical decompression of trigeminal nerve with plus 180 stroke minus 180 exploration. Professor Segura. Thank you. Could you share your presentation, please?
Hi, everybody.
Hello.
Good morning from Mexico. This is, we are very happy for this time. Thank you, Naren, for this effort to this training conference, international conference. I want to share my screen. Can you watch it?
Yes, we can see it. Thanks. You have to put it on presentation. Thanks. Thank you very much. Password.
Okay. I'm going to spend the next 10 minutes to resume our experience from the last almost 20 years working on trigeminal neuralgia, skull base, especially in the pontocerebellopontine angle. We want to present the experience. Let me show. The aim of this study is to present our philosophy about surgical management for minimal invasive microsurgical decompression to the trigeminal nerve, based on 3 principles. The first principle is to preserve the patient life. This is not rare. This is very important. And from the last 18 years, we are very proud that the zero mortality is the goal of the work. The second purpose is not to damage the nerves, neither the vascular structure surrounding the surgical bed, to avoid neurosurgical sequela or complication inherent to the surgery. This is another important point. And finally, the third purpose is to eliminate the cause of the symptom. Talking about the trigeminal neuralgia, it's very severe facial pain. In the next slide, I'm going to present step by step our microsurgical technique. And from today, we are collecting more than 1,145 patients with trigeminal neuralgia. Of course, about 30-35% of them go to the surgery. Most of them we kept with pharmacological treatment. I want to point this 5 level of training. I'm very happy to meet many of my professors. I remember Candras 10 years ago, Dr. Goel. He was a very experienced young neurosurgeon. 20 years later, we met again. This is important. The general neurosurgery, it's just the beginning of this life, the brain surgeon. The level 2, we have to do a great effort to cadaver handwork, to train it, and at the same time have a training under a mentorship. In my case, I have to say thank you to Kawase and Yasui professor. I spent 3 years with them. And the level 3 and the level 4, it's start with simple cases and advance it little by little. Finally, the complex cases should be combined and discussed with expert team. This is our philosophy. I'm going to skip. And I know more of the people prefer the sitting position. We never use this. It's very easy. However, with our position, the supine position, it takes less than 8-9 minutes to prepare the surgery field and start the surgery. We have a kind of record for this. So most of our patients never use sitting position. This is the average, 10 minutes to preparation from the entrance to the operating room to the start the skin incision. So this is first step. The next step, I'm going to show this quickly video. As you can see, we do a subarterial approach, less than 20 millimeters. Of course, we have to use all the technology very, very accessibly for us. MIDAS, microscope, to tool, etc. We never start a surgery without the complete team. In this case, we want to show this sample. And the base of the approach is the sigmoid sinus. This is the angle. And in this case, this space is enough to prepare the surgical, microsurgical field. I want to show, this is a simple cases. As you can see, they represent the transverse and sigmoid sinus. We have to be very careful. In only this point, we are close to the sinus. To this technique, we avoid injury to the sinus. Let me show. Another example. This is the dural incision. This is another example. As you can see, the surgical field is very limited. So we have to open with very narrow space the dura, but anyway, it's enough. The green area is enough to go entrance to the pontocerebellar angle. Again, 20 millimeters. I guess it's the same that the endoscopic approach. We don't like endoscopic. It's very risky for us. However, I know that there's many countries, many centers are very experienced in endoscopic surgery. As you can see, the bone approach, we have very care to the mastoid cells. And in this case, we are preparing the venous preservation of the superpetrosal venous complex. We prefer never cutting, except it's in very rare cases. As you can see, after open the cerebellar fissure. In some case, we have to sacrifice and start the microsurgical dissection of the arachnoid surrounding the trigeminal area, as you can see. And in some cases, microsurgical dissection of the arachnoid membrane around the venous complex, looking for the chuka, for the ICA arteries, and there are different variants, as well as the cistern of the angle, transcerebral or horizontal distal fissure approach. It was described in Japan, in the Noken Center. Some case, the arachnoid is very tight, very rough, so we have to be very careful. And in most of the patients, we prefer don't damage the circulation. For this case, I guess in Italy, we are very comfortable with this Capabianca. This is a modified Capabianca tool. Sorry for the screen, but it's very easy to reach a deep venous system and coagulate it without occlude the corridor, the surgical corridor. Besides that, we observe this suprameatal tubercle. We also described 3 grades together with Dr. Mendez from Mexico. And in some case, as we were described yesterday, the day before yesterday with Dr. Aron, we have to have a very hard work of the bone, of the tuberculous suprametal. I recommend that never do this for the young neurosurgeon. We have to spend more than 100 cases on cadaver, on lab, and after that, we are really ready to work this area. As you can see in this video, after removal the suprameatal tubercle, we have a very easy, straight, microsurgical corridor. Let me show. This is very important. I want to insist for the young neurosurgeon. I know that today we have more than 25,000 neurosurgeons around the world looking for this, but this is a very master surgery. As many of our professors say, this is not for first grade, second grade resident. This is not for beginner. This is a very serious neurosurgery. So to do this drilling, here is the ICA, here is the 7th and 8th cranial nerve. In the bottom is the trigeminal nerve. Pons is in the part of behind. So you should be very careful. This area is less than 2 or 3 millimeters. So this is a rare surgery. This case was presented the day before. Yesterday, this is a very rare osteoma, compressing trigeminal nerve, as we commend. I want to skip. And okay, this is our recommendation. Microsurgical exploration and release with the 180 degrees, left and right, or one side, another side technique described by us, should be the goal. As you can see, once finish the first decompression, we are able to do the next decompression. In several cases, we have found more than 7 contact points. As you can see in this example, this is very common. After the 180 degrees exploration, we found this small vein touching the bottom of the trigeminal nerve. And after exploring the other sides, we found the other side of the venous. So I strongly recommend it. Not stop the exploration at the beginning. This is very common. The most easiest compression, vascular compression by the SUCA, described by Professor Janetta. We dislocate very carefully, and then we are able to put the, in this case, microfibrillae Teflon. So, okay, finally, this is the message, the final message. This is a case operated 20 years ago in another institution. Of course, we found the trigeminal recurrent and found this granuloma. We have found about 3 granulomas in cases very good operated 15, 20 years ago. So this is a rare clinical situation. And in this case and the other case, we remove the tip, and that's enough to release the facial pain. This is, as you can see, part of the Teflon and a lot of arachnoids and fibrosis and a remnant of the trigeminal nerve. So this is a very, very complex cases. The artery is involved. So most of the patients we put Teflon without any problem, as you can see in the video. No difficult. However, in some cases it could be very complex like this. I want to show you. This is many circles. I don't know, maybe ICA, maybe pontine, maybe a combined arteries surrounding the trigeminal nerve. Before that, we removed the SUCA, and before that, we removed the ICA. So the message is we have no stop at the beginning. The compression, we have to continue up to find 80 degrees compression on the other side. Finally, for dural structural bone muscular poneurotic plan and scan reconstruction, we also use microscope. We have found this, a small defects on the dura. After that, adhesive of fibrin, osteum bone, serum, and finally duragen. So in this case, we have reduced the cephalospinal leak less than 2%. This is our time of surgery in about 150 minutes, 1 hour and a half. And also this is a very complex cases, simple cases. And in this case, of course, this is no matter of this presentation, but more than 92% of recovery. In our experience, as conclusion, in our expert opinion, the surgical management of the trigeminal neuralgia syndrome should be approached with a global vision with a multidisciplinary team of experts. The classic trigeminal neuralgia is recommended to be accessed by a multidisciplinary team using a variety of therapeutic options, available such as palliative, percutaneous, and microsurgical, with free technology access. This is the most important, not escatimate. The minimum decompression is highly specialized centers, saw a high number of cases, being the minimal invasive microsurgical decompression, the approach recommended in our expert opinion. The minimal invasive microsurgical compression of the trigeminal nerve is recommended to be performed in the final phase of the neurosurgeon training for those with experience in skull bud surgery. In our case, in Latin America, we should strengthen the training of these specialists. I want to say thank you, and this is my message. That was, I want to.
Thank you very much, Professor Seguro. It's pretty impressive. I know that you have got a huge experience with trigeminal neuralgia compression around 2000, and there's a question for you from Dr. Parak on the chat box, but I think if you can answer that. But can I just ask? I have seen all the skull-based surgeons intently looking at the screens. Professor Arath, could you interpret what you saw for us who are not skull-based surgeons? Thank you.
Well, thank you very much. I think this is, first of all, I'd like to congratulate on this vast experience on trigeminal decompression. I think this is a wonderful presentation about the technique, and I think this is important to me. I think the most important issue is just to emphasize the concept of 360-degree exploration and decompression in order to completely free the nerve and trying to assure the better possible outcome. So congratulations on this presentation, Dr. Segura.
Thank you. Thank you very much. Dr. Jagili, do you have any comments? And Mr. Kyrillos? Thanks.
I have to congratulate the authors. I think, you know, and I agree with him, this procedure, which seems very simple and easy, it requires significant training. There are complications that can occur with this, hearing loss and other issues. So no question that it requires someone with adequate anatomical understanding. So it's a procedure that can be very easy, but it can also be very difficult, as was shown.
Thank you. Mr. Kyrillos?
Thank you. I agree totally that the primary aim of the procedure is to look 360 degrees around the nerve. Otherwise, in recurrent cases or cases that failed, you will always find an additional vessel that was obscure. But what I have changed over the years, I use the same short incision, but because cosmetically it's the same, but I have been enlarging the craniotomy rather than making it small. And in that way, I could have an angle of view. I did not have to remove a suprameatal tubercle because I can angle the view of the microscope. And I agree that sometimes you try to preserve the petrosal bridging vein, but if that is obscuring your view, sometimes we take it, but the primary aim is to look at the nerve 360 degrees. So my only modification of that I thought the lateral position and the larger craniotomy allows that with more preservation of the nerve and not needing to drill the suprameatal tubercle.
Thank you very much, Dr. Gaul. It's like all the gods of skull-based surgery has descended here. Thank you very much, Dr. Gaul. Your observation.
Yeah, Dr. Segura, that was a wonderful presentation. Microvascular decompression for trigeminal neuralgia is a fantastic operation. And it is a fantastic operation, but as Professor Fred Gently said, that it is good, but it is not easy. It is a perfect microvascular surgical operation. And you have to do it beautifully. And if you do it satisfactorily, you give new life to the person who is suffering from pain and all those things. So there is no question about this operation. I would like to ask Professor Segura if you can give some information about his experience on hemifacial spasm. What is your little bit 2 or 3 sentences? What is the difference in microvascular decompression that you have done for trigeminal neuralgia and for hemifacial spasm? Do you have some good experience in this, Dr. Segura?
Yes, thank you, Professor Goen. I want to say hello. Last time we met in Madras.
Yes.
Anyway, yes. First, it's very, very rare. Only 113 cases against 1,000, 10% experience. And the other point is facial nerve, of course, is motor nerve, and we never see facial nerve. We always see vestibulocochlear nerve and separate, and the recurrence rate, it's about more than 20% in hemifacial span. So very particular is similar, but in another is not the same result. The rest is the same technique. However, the compression is modeled for arterial. In very rare case is venous contact in facial span.
The other thing, Dr. Segura, I want to touch on is the petrosal vein. The petrosal vein that has to be preserved. It is lateral to the trigeminal nerve, and you said it is better to preserve, and rarely you have to sacrifice it. This is what you have said, and I completely agree with it. On the other hand, in cases where you get a petrosal vein bleeding, then it can make the whole operation become very, bloody and difficult sometimes to get hold of it is a possibility. So if there is any issue, I think I will like to sacrifice the vein rather than struggling. It is not such a huge thing not to sacrifice the vein. What do you have to say about this?
No, we make all this effort to don't sacrifice any vein, especially the petrous complex. I don't know, in the trigeminal cases, for facial spans, it's very rare to touch the petrous vein.
Of course. Anyway, very good presentation, Dr. Segura. Happy to see you.
Thank you. Thank you very much. Congratulations. So it brings us to the eagerly looked forward lecture of Professor Fred Gentili. I have gone through the British system, and there are very few departments that doesn't have a consultant who has not been trained by Dr. Gentili. Yeah, I think if you talk to Dr. Ramesh Kyrillos for 20 minutes, you will hear Fred Gentili, and it goes on and on and on. It's like pediatrics Rutka and Gentili for skull base. Every British unit has been trained. So, but I got introduced to. I have followed Dr. Gentili for a long time, and because I have heard his name for so long, but I finally got to meet him last year in Ancona, Dr. Iacanangeli's course. So if I may ask Professor Iacanangeli Maurizio to introduce Professor Fred Gentili, please. Thank you.
You didn't say that I have to introduce my friend and mentor, Fred, but it is really a pleasure to introduce Fred. Every one of you should know that I'm from Rome, but actually I work in Ancona, a small town in the east of Italy. And Fred was born a few kilometers from here. Of course, then he moved to Toronto and became one of the greatest neurosurgeons in the world. But still, he likes to spend the summer vacation. So we get the most from this the presence of Fred in our region. And we started many years ago to organize a sort of, we call it the convivial meeting. It's a sort of meeting in which everyone can speak free, but staying behind or beside this great neurosurgeon. So Fred, for us, is a great resource. And what I have to say is one of the best tutor in the world. Everyone I go to the Congress, I always met the people that spent a few time from at his department or at some fellowship with Fred. And besides the professional value that I cannot stress more, Fred really is a very nice person. He's really very humble and really good mood, always smiling. He's really a good person, besides an outstanding neurosurgeon. But I have no other words.
Thank you. I have to ask Dr. Ramesh Kyrillos, Professor Kyrillos, I think you spent your fellowship with him. I know that if I don't ask you to mention some word, I don't think I'm going to live for so long. So Professor Kyrillos, please, thanks.
I cannot thank Professor Gentili enough for all the inspiration. It is a pleasure just to watch him practicing, as mentioned, not just surgically outside the OR. It's a huge inspiration, and the greatest thing is the continuous change. I went there before the endoscopy era, and I meet him regularly, and I changed a lot according to his advice that keeps changing and very progressive. It is so impressive. Thank you, Dr. Gentili, for everything.
Thank you very much, Professor Kyrillos. So, Professor Fred Gentili, we look forward to your lecture on your experience over 35 years and your lessons learned and what you can impart to us. Thank you, sir.
Aaron, thank you very much. Let me see if I can share my screen.
Thank you.
I had the problem the last time in terms of, if I go down here. Can anybody see my screen now?
Not yet, Dr. Gentili.
Yeah, I think as it's coming through my screen. Yeah, the last time I had the same thing because it's coming through a flashcard. So Okay, so let me see. This is my presentation, but you cannot see it.
Yeah, can you see the green share button underneath the?
Yes, I see that, and I'm. It doesn't show me when this is in there. That's the problem. Let me see here. Desktop. Let me see here. Okay.
Great. We are just about to see it. Fantastic.
Can you see it now?
Yes, absolutely. Yes.
Okay.
Thank you.
So first of all, what can I say? My head is now as big as a thing for all those amazing comments, and I'm very, very humbled. I cannot say anything else. It's so amazing to me to see my friends, to see Miguel, to see Atul, all of these, and Ramez and Maurizio. It's just amazing. So I must say for you guys, this is not for you. So you can shut off your computer and go and have a nice Sunday, because this talk. I sent Naren. First of all, Naren, I have to thank you very, very much, for inviting me, but also for what you're doing. The educational webinars that you've been doing are excellent educational formats in this time, this very tumultuous time, and we are all having this tumultuous time. Toronto has just gone back into phase 1 lockdown, and I know the rest of the world is in this incredible pandemic that we are in. But your educational things that you're doing are very important for young people and around the world. And I was amazed to see the number of people that you have in this webinar. In any case, I sent Naren a number of topics, from chordomas, craniopharyngiomas, and then I sent him, this topic here about lessons learned, and it was Naren who picked this, so he's responsible for this. If it turns out that it's not, what you're doing. But I think, as I said, this is I think more for younger neurosurgeons. I hope that some lessons that we older neurosurgeons learn, that maybe they can learn something from this. So thank you very much, Naren, again, and I will continue. So my talk is on skull-based surgery, a changing landscape, reflections on a 35-year career, and the issue of lessons learned. So let's proceed. So the evolution of skull-based surgery, say here, where have we come from? And as Carmen Aditi said, everything must come from something. Nothing comes from nothing, just like paper comes from trees and glass comes from sand. It's my feeling that we have to know the past to better understand the present and maybe predict and maybe improve the future. So open skull-based surgery is like any new innovation that comes in. It goes through different phases. And this is from Jeanette Shaw in New York, who came up with the issue. There's always the initial introduction, the skepticism. And when we first started these open procedures, people thought we were crazy. The idea of doing these major operations. Then there was some enthusiasm, the idea that maybe something new was this, to the point of being too enthusiastic. And we developed the different techniques. There was an incredible aggressiveness. And then we came to the sober realization that these did have complications. And there were limitations of these. And then finally to the phase of where we look at outcomes, the quality of life issues, the cost effectiveness, and the ethical issues of this. So the open skull-based surgery is an amazing time. This is, our initial publication on a thing for anterior skull-based. We put it into 3 regions that you can see here. And these are the procedures that we were able to develop. Some of these were new procedures, thanks to also our head and neck surgeons. Some of these were just extensions of a traditional neurosurgical procedure. But with this procedure now, there was no place in the skull base that we could not go. Everywhere that we could go. And And then, so the question then comes up, did we make a difference with skull base? Have we made a difference? Because as Martin Luther King said, that no work is insignificant, that all labor that uplifts benefits humanity and dignity and importance and should be undertaken with painstaking excellence. And then the issue is we may think we made a difference, as shown here, but we thought we made a difference. But even if we haven't, at least we tried, and maybe somebody else will be able to make a difference. I think the determinants of success in skull-base surgery were a number. First of all, the better understanding of anatomy. We know that anatomy equals surgery. You have to be an excellent anatomist. The Yasser Gills of our era were all excellent anatomists. Magnification, microsurgical technique, the innovative approaches that I just mentioned. Improved imaging was very critical. I remember when I started my neurosurgical career, neuroencephalography we were doing to localize an arteriogram to localize brain lesions. Anesthesia, of course, preoperative care is critical for our patients, and intraoperative monitoring, image guidance. But I think one of the most important thing was, and we've seen this here, the issue of the interdisciplinary cooperation, multidisciplinary team. Now, interdisciplinary now is a catchword. Everybody is into multidisciplinary, but in fact, skull-base surgery is one of the first disciplines that really went to the multidisciplinary approach. The North American Skull-Base Society had, ENT surgeon, head and neck surgeon, neurosurgeons. They had radiation oncologists, and I think this was really the very important part for skull-base surgery. And I've been fortunate in Toronto to have an excellent skull-base team, as you can see here, of head and neck surgeons, rhinologists, and of course neurosurgeons. But we also see we had radiation oncologists part of our team because we know that sometimes that's necessary, and of course pathologists, etc. And I always say when I present these that we have the premier skull-base team in North America, but many of my colleagues in North America disagree with me, of course, and Jacques Marcos particularly, and we laugh about that. But the key here is no question you need a multidisciplinary team to do these. So have we made a difference? I think the answer is yes. If we look at in malignancies, you can see that the changes in at least survival of the skull-base malignancies from the 1960s, 70s up to the 1990s, there was a definite improvement in survival in skull-base malignancies. And so now we've done over about 5,000 open skull-base surgeries in our group. Everything from these lesions that we consider most of the skull-base surgeries are really lesions that transgress the skull base. Now, acoustic neuroma, of course, can be considered skull-base, skull-base meningioma. We don't include this in our series. These are true lesions that transgress the skull base. So this young man with this mesenchymal aggressive chondrosarcoma that we initially was very difficult to deal with these. With our classical craniofacial resection of the lateral rhinotomy and craniotomy, we're able to remove this tumor that you can see here. The patient also had induction chemotherapy and post-op radiation, but 23 years, this patient is alive and well. Likewise, this patient here, 29-year young man with an ethmoid squamous cell carcinoma. The survival rates of these at that time were the same basically as a GBM, 5% 5-year survival, very, very deadly tumor. Again, with the ability to, together with our ENT colleagues, to do a craniofacial resection, lateral rhinotomy, orbital exenteration, and then you can see free flap reconstruction of the rectus facet. This patient, 24 years post-operative, and it remains disease-free. But also, of course, it was the benign tumor that allowed us to do. So this large clival meningioma, previously very difficult to deal with, the use of our ability to do far retrosigmoid far lateral transcondylar approach allowed us access to these tumors. And this patient, as you can see here, is now, I think, 16 years, allowed us access to these tumors that allowed us to resect these tumors. So there's no question that the open approach of skull base were significant. It gave us significant advantages. And while the ongoing, I'll discuss a whole issue of the endoscopic skull base surgery, there's no question that open approaches remain very, very important and necessary in skull base surgery. So young neurosurgeons out there that want to become skull base surgeon, you know, in the issue, of course, is a fancy endoscopic surgery. You must know and learn the open approaches to be a very good skull-based surgeon. So some lessons I've learned from skull-based surgery. Your best teacher is often your last mistake. Some lessons cannot be taught. They simply have to be learned. The past is where you learn the lesson. The present and future is where you apply that lesson. And ultimately, there really is no failure, no such thing as a failure. Believe that there are lessons to be learned, but in different ways, from success, but also from failures. And no question, we learned a lot of lessons from open skull-based surgery, that these were maximally invasive procedures. They carried significant risk for complications. Look at our series that we published in 1999 of craniofacial resection. Almost 50% of patients had some form of morbidity. We learned about the complications that occurred, and we also learned, very important, the factors that increase the risk of complications, such as extended resection, the issue of previous radiation, et cetera, et cetera. And we also learned that, you know, I showed you all those amazing operations, that we learned that, in fact, the maximally invasive skull-based approaches should be used selectively and judiciously, and that the least invasive approach that will do the job is often the best approach. So we are, you know, there's issue of doing huge approaches when you can do a simple approach that will do the job is the best approach. And so this patient here that I operated on over 20 years ago with this medial clinoidal meningioma, vessel encasement, you know, there are many approaches that we sought for this, including orbigozygomatic, et cetera, et cetera. But in fact, this can be done using a standard terional approach. If you have favorable arachnoidal planes, you can get a nice removal. And that's the key. It's not the approach, it's what the tumor and the arachnoidal planes will tell you how much you can do. Likewise, this is the best approach to this lesion, and we saw here there are many approaches that the skull base we developed. The petrosal approaches, retrolab transpetrosal, the Kawase approaches. Well, in my hands, we come back 360 degrees back to the simple posterior fossa retrosigmoid craniotomy. Allows a nice removal of this. As you can see, 17 years, this patient is now free of disease. This is also important, that long-term follow-up, the lessons that I learned, is necessary to obtain accurate data and outcomes in skull-based surgery. And so it's very important to follow your patients. And we know this about meningiomas in terms of the Simpson's grade. And so this is a patient with a chordoma that we operated in 1995, lateral rhinotomy, then a far lateral approach. But this patient is 7 years, recurrence, 3 further recurrence, dead at 2000 in 1 decade. So if you follow these patients, you know, 2 or 3 years, everything's fine, you think you've done a good job, but no, you have to follow your patients. And indeed, with chordomas, if you follow the patients, this is the Harvard group, 5-year survival 64%, 10-year survival only 42%. But this doesn't even tell the story, because you have to look at a database for chordoma in terms of surveillance and epidemiology. The SEER bases, databases, 400 chordomas, 5-year survival, 10-year, 20-year survival, only 13% of chordoma patients are alive. This is the important that you have to understand with these tumors, that they'll come back to you again and again. Also, this is very important, and you know, we are all feel that we are excellent technical surgeons. You know, that's the key. We drive in that, but that surgical virtuosity, I call it, surgical excellence, cannot overcome tumor biology. It doesn't matter what a good surgeon is. So we found out that certain, particularly high-grade tumors of the skull base, certain malignancies, the high-grade sarcomas, the SNECs, the nasopharyngeal carcinomas, these melanoma, these are not really surgical lesions. And we learned that the hard way. So this young man, you know, a high-grade sarcoma in the infratemporal fossa, we tried to do everything in maximal radical neck dissection. It did the duroplasties. We did free flap reconstructions. None of these patients survived over 2 years. we learned that surgery, while it may have a role, is not the answer to these patients. And now chemoradiation and other techniques are really the key for these patients. Finally, or not finally, but surgical excellence also cannot overcome anatomical constraints. And for certain lesions of the skull base and malignancy, particularly multicavernous sinus, I think there's really, the role of surgery, I think, is very limited here. This is my own personal view, and there are people who may disagree with me. But if you look at this kind of lesions here, involving the cavernous sinus, involving the brainstem, holocavernous, I do not believe that surgery really is the answer for these lesions. And so this came to the issue that we know, despite our extensive exposures and techniques that we have, you know, is a Simpson gray 1 removal possible always in skull-based meningiomas? The answer is definitely no. And, you know, we're really looking at gross total removal rates of 35 to 50%. And I think in these type of lesions, it's probably down close to 0. So this patient of mine, 1994, with a partial third nerve palsy, that's all he had, nothing else, with this petroclival meningioma. So the patient asked me, he said, can you, I said, yes, we can operate. I said, but we can't get the total removal. But he said, will you help my third nerve palsy? I said, well, actually, I said, no, probably it'll be worse. And so he obviously sought out, and at that time, 1994, he went to Pittsburgh. We didn't have a gamma knife radiation, had gamma knife radiosurgery, 25 years. This patient is now stable. In fact, he improved his third nerve palsy. So this brings us to this issue of the therapeutic index in surgical decision-making. And this is very important. So anytime you have a patient, you're going to do something, you should use this therapeutic index. And what is this? This, you look at the probability of tumor-related morbidity. So if you don't do anything in this patient, what is it the tumor going to do to him? But you have to balance that with the probability of treatment-related morbidity. And so for cavernous sinus meningioma, in my mind, there's no question that the arguments are definitely in favor for radiation. It's effective therapy. It's a low post-operative morbidity, more cost-effective. Quality of life. Well, we all know this is, again, a catchphrase. Everybody's now into the quality of life. But in fact, it is important. And as Alexis Carrel said, the quality of life is sometimes more important than life itself. And our job is improving the quality of life of our patient, not necessarily delaying death. And there has been indeed over the last decade a paradigm shift in skull-based surgery, where that quality of life and functional status, we have to be cognizant, and they should be very important determinants when we make decisions. And that attempts at radical removal of certain lesions should be tempered by the serious risk for complications and threat to the quality of life of the patients. And this means we have to be aware of other treatment modalities, because as surgery has advanced, other treatment modalities also advance in terms of radiation, in terms of chemotherapy. So, what is the quality of life? As a surgeon, I remember we had a patient that we removed the tumor, the fact that he was able to walk in, we thought that was a success, but we're learning that quality of life really, the WHO definition is really a patient-centered concept. It's not just the physical, it's a multidimensional, includes the physical, social, psychological, and spiritual dimensions. And this can only be determined by the patient. So the patient will tell you if in fact you've done a good job or not. And we were very interested in quality of life from the very beginning, as you can see here in terms of open skull-based surgery, a number of publications. And then more recently, we have quality of life instruments, pathology, systemic review that we have in our center. And by understanding the patient's needs better will result in improved patient care and facilitate the provision of reliable outcomes data for clinical trials. This is just an example in terms of the quality of life and issue of meningiomas. There's been a significant pendulum swing in meningioma, and the pediatric neurosurgeon, Naren, of course, will know about this. From the radical resection, Naren, I remember as a resident with Harold Hoffman, who you know is a famous pediatric neurosurgeon, the aim was to cure these craniopharyngioma, and he would take these things out of the hypothalamus. And then at the cost, however, significant cost to endocrine, hypothalamic dysfunction, morbid obesity, neurocognitive issues, and poor quality of life. So over the last decades, as you can see, there's been a significant shift over to a more conservative, we call function-sparing multimodality therapy of surgery and radiotherapy, dealing with what the problem is. So if it's vision, deal with the vision. And you know, what's the result of that? Well, we know that at least in the pediatric, that gross total removal and subtotal removal, in fact, the same, whether it's progression-free survival or overall survival. And now we're finding out that this is also has similar results in adults. And so we have to take this into consideration when we're doing surgical decision-making. What else have I learned in terms of, what about complications? What have I learned from my complication? Well, as Publius Ovid back in the before Christ said, some conditions are made worse by treatment, as we see it, and better not to touch. And this is Fred Gentili's sayings. If you think you've seen every complication possible, you have either been blessed from above or you have not been practiced enough. And indeed, after 35 years, I will see a complication that I've never seen before. So it doesn't matter how long you've been out there, you're gonna, you know, see different complications. And then this is again, the decision to not operate is much, much more difficult than the decision to operate. So some basic truths I've learned about complications. First of all, they're inherent in surgical practice, particularly in skull-base surgery. Not all complications are preventable. Complications often beget, one complication begets multiple complications. Different approaches have different types of complications, and be prepared and anticipate potential complications. Report and take ownership. If you've done a complication, it's your fault, take ownership of that and learn from that. And this goes into the important, not to waste one's complication, but learn from them. And very important, complication avoidance, we all know, and prevention is far better than having to treat a complication. So what are my, have I learned about some basic principle of complication avoidance? Well, the first thing is proper training. Whether it's a fellowship, whether it's courses, exactly, proper training is very important. Also, based on your training and experience, know your own limits at each time of your career. In other words, understand your learning curve. Emotion and ego should be out of this, because we all know that the first 5 years in practice is not going to be the same as what you can do in 10 years after, or 15 years. And we know that expertise and judgment results from learning from both good and bad experiences. And also in the area of evidence-based medicine, try as much as possible to make evidence-based decisions. Now we all know in neurosurgery, there aren't many level 1 randomized trials, but at least have an understanding of what the literature shows in your particular instance. Also, proper patient selection and engagement. Have a clear understanding of the patient's expectation of surgery. You have an understanding, but it may not be the same as the patient. So it's important to know that. And we all know there's studies been done that patients who are actively involved in their care have better health outcomes and lower health costs. And do not minimize the risk of surgery. Patients want honesty. And sometimes surgeons, you know, we will minimize that, afraid to tell them that, you know, the issue. And again, as I said before, know not to operate. Also, have a clear objective, the goals. What are you trying to prove or do in this particular surgery? You must have a goal. Now, that goal may not be what you end up doing it, but if you don't go in with a certain type of goal, then that's not really issue. Be aware at least whether your aim is a total, subtotal, and have understanding of adjuvant therapies. And of course, select the right surgical approach. And this goes to the issue, my issue of individualize and tailor the approach to the patient, not the other way around. We often try to tailor the patient to our particular approach, and that's really not the way to go. Know the limitations of the approach. Again, know the anatomy and communicate, because, you know, surgery, you have to understand, is only one phase of the patient's treatment journey. In one specific phase, but there's the whole journey that our patients go through. So, quo vadis, where is we going in the evolution of skull-base surgery? And this is entry from Yogi Berra, a famous baseball manager, that you've got to be very careful, because if you don't know where you're going, you may not get there. And as Albert Einstein said, I never think of the future, it comes soon enough. and Winston Churchill, the empires of the future are really the empires of the mind. What we can think of in the mind, we can make sometime in the future. And then, of course, this brings us to the whole inevitability of innovation and change in your surgical practice. And we can see here from J.F. Kennedy that change is the law of life, that those who only look to the past and present are certain to miss the future. And George Bernard Shaw said, progress is impossible without change. And those who cannot change their minds cannot change anything. Change is inevitable, change is constant, and really nothing endures but change. In fact, the only constant in life, which is I think it is in fact change. And this is very important. This is that it is not the strongest of the species that survives, nor the most intelligent, which is interesting, but the one most responsive to change. And of course, Charles Darwin, in terms of the origin of the species. So we're all aware of the major changes in neurosurgery over the 20th century, the issue of operating microscope, the microsurgical techniques, et cetera, imaging. And what I've learned about change and innovation is this, that first of all, it's an important fundamental part of surgical practice. It's often driven by technology. One must keep an open mind to innovation and change. You have to keep an open mind. It has contributed to improve patient outcomes and quality of life, but one cannot be also a slave to innovation. So every new little thing that comes in, you go on, because innovations can be quite costly. And we know that in some cases, innovation can be detrimental to patients. So we must assess the value of the surgical innovation, although the valuation of these can be complex. So for any innovation technique, we have to look at the safety reliability. The efficacy is very important. We have to look at published studies of that, because we all know that new is not always better. So this brings us to Scott's parabola, the issue of the rise and fall of a surgical procedure or technique that has so much favorable thing. We thought it was going to do everything, and in the end, it falls off the cliff on the other side because it did not have a proper evaluation. So change in innovation surgical practice, amazing from I'd say over my 35 years. The whole issue of intraoperative monitoring now, image-guided endovascular therapy, radiosurgery, advanced imaging, intraoperative MRI, all of these things, and including now the issue of minimally invasive surgery, including pituitary and endoscopic skull-based surgery. So looking at endoscopic approaches, we now have almost 3,000 endoscopic approaches. The majority of these, many of these, of course, are pituitary, but also over 500 expanded approaches. And endoscopic pituitary surgery came from endoscopic sinus surgery that you can see here. And the reason, there are advantages to the endoscopic approach, but also you have to understand there are always some disadvantages. And this is a patient with an endoscopic pituitary surgery. You can see with the usual hardy speculum and the microscope, the incredible difference that you see with an endoscope. Look at the visualization that you can see. It's just like basically another world. And so this large lesion, pituitary lesion with an endoscopic approach, it's beautiful view that allows us, it's my microsurgical technique that we can do exactly, that allows us to remove this tumor. Here's the medial wall of cavernous sinus bilateral. You can see the diaphragma has come down. You know that you've got a nice radical removal in this patient. And this is this patient you can see post-op, 13 years. This is what you want to see, a very nice radical removal of this tumor. And this, the endoscope also allowed us to deal and learn from this, that this is a large, oops, what happened? Somebody else's screen?
Somebody else shared the screen. I don't know what was going on.
Yeah, there's some...
very odd.
Wow. Well, there it goes again. Okay.
There.
Are we back?
No. We have no gallery view. So try to share again, Fred.
Oh, gosh. Okay, I can see my screen.
Probably you have to stop sharing and then start sharing again.
Okay, so let me go here, up here, stop sharing. I don't see the sharing, so let me...
Never seen that before.
Somebody came on.
Yeah.
Okay. here.
Share it again.
My goodness, that was strange.
Really, indeed. It was so unexpected and sudden, but okay, that's like in surgery, some unexpected complications can occur.
Yeah, now exactly. Now I see you, but I don't see my.
No, that's no. I have we see your screen again. Perfect.
You see it. You see it now.
Yes, but that's the whole list of your presentations. So
okay, so let me just go to where I was. Where was I? I was here. You see this one now?
No, you first you only can share the screen that you have opened. So we now see.
But I say stop sharing. Now I'm stopping sharing, but I was sharing before.
Yeah, try to go to your where you were, and then you say share screen, and in the second screen that's
here. Okay, here now I'm sharing the screen.
Yeah, and now where you click on that screen. Yes, now we are again perfect. And
okay, so now let me go here
into presentation mode.
Who can share? Only hold all participant. I'll say.
You can. No, we see your screen. Go to presentation mode.
Go down here again. Can you see it now?
Wait a minute. Let's see. Yes, we see it.
Okay.
The video even. Okay.
You see it now?
We see it.
Okay. So going back, this is a giant adenoma that initially probably would have required maybe an open approach, but with our endoscopic abilities, this was in fact can be done using an expanded endoscopic approach. And you can see here what we do is do a transplanum approach. And then just very quickly to bring this down, we see this is the plenum and tuberculum we took off that allows us to get above this tumor to then take this tumor down. And here's the optic nerve and chiasm. And in this patient, you can see here 9 years off. So this allowed us, the endoscopic approach to pituitary allowed us to think about the possibility of endoscopic for other lesions. So we've done over 1,800 pituitaries, now 2,000, and there's no question in my mind, this is our series back in 2008, that the endoscopic pituitary surgery is really the future current state of the art and will become the standard of care for pituitary adenomas. This then, as I said, the pituitary surgery allowed us to go to the expanded endoscopic approaches. And endoscopic skull-base surgery really went through the same stages that I told you of open skull-base surgery. And now we're basically at the area of looking at the indication, the limitation, and outcomes. And so far, we see that the early results in some pathologies are promising, but the key, as I said, we lack long-term follow-up, and we need long-term outcomes. So this is our series of endoscopic skull-base surgery, now over 500 cases. The pathologies are very similar to the open approaches. And just to quickly go through to show that, for benign extradural lesions, encephaloceles that you can see here, CSF leaks, some of these other pathology, I've not how do you say, dealt with treated a CSF leak with an open procedure for over a decade. This is all can be done using an endoscopic approach. And indeed, this is an anterior fossa encephalocele, a middle fossa encephalocele, cholesterol granuloma of the petrous apex, all done using a pure endoscopic approach. This is a juvenile angiofibroma in a young man that you can see here, capillary hemangioma, hemangiopericytoma again. All of these done through a pure endoscopic approach without the need of any open approaches. And this is just to show you a large meningioma of the paranasal sinus, that any lesion from the posterior aspect of the frontal sinus to the clivus and medial wall of the orbit can be removed using a pure endoscopic approach. And this patient, as you can see, coming out 7 years following the removal, and years after the removal, showing the skull base, basically. Malignant lesions, we learned, yes, that you can do this, but of course, there's patient selection here is very critical. The lessons we learned, that you have to maintain the issue of dural free margins. We did learn that the whole concept of en-bloc resection was not necessarily the key. The key of however, was the free margins. You have to get a free margin. And this is the steger neuroblastoma that you can see that we basically did a craniectomy from below, just the way we would do it from above. This patient is 4 years, clear margins, no CSF leak, length of stay 5 days. And then the literature suggests that in fact endoscopic approaches are is a valuable technique, but again with very clear indications in terms of being able to get negative margins. So preoperatively, if I cannot see that I can get a free margin, in other words, if it goes over the orbital rim or orbital roof, then I do that open. Craniopharyngioma, we touched about this before. There's no question in my mind, and this shows you my changes in my practice over the last decade, a major shift over to the endoscopic technique. And the issue is why? Well, the issue is visualization. This is a patient that was done using an open approach for this craniopharyngioma in a 76-year-old gentleman. And the problem with these is the access, very limited access to the lamina terminalis in these areas. If you look at this patient, was subsequently we did an endoscopic approach, and you can look and see the difference. It's like basically a new, it's a different, it's a different planet that you're on. Able to take this off the medial wall of cavernous of the hypothalamus. That allows us to again, this is because he had a previous approach from above, so they was quite stuck to the nerves there. So this patient, as you can see, was 76, so our aim was not to be crazy and remove every possible in the medial wall of hypothalamus, but this patient post-operative had improvement in his vision, pan-hypopit, and you can see the removal. So there's significant advantages to the endoscopic approach. To me, that is really the approach of choice. So a patient like this with a craniopharyngioma, solid cystic, what approach? Well, to me, there's no other approach than the endoscopic approach. And just very quickly, not to bore you, to show you, this is the approach we use, a transplantum approach. That allows us to remove this patient and spare these very important superior apophyseal vessels to the chiasm, which I think is very critical that you have to do. In this patient, you can see virtually blind, significant vision improvement, 8 years, no evidence of disease recurrence. However, like anything, there's a limitation to the endoscopic approach. These large tumors obviously are not very good for the endoscopic approach. And surgeon preference, you have to have experience in doing these. This is our series recently published that you can see in operative neurosurgery, 40 patients, and you can see our results, only 44%, but 50% virtually were recurrent tumors. When the objective, however, in the primary lesions, 81%, with very favorable visual outcomes. Morbidity, nothing. CSF leak, 21%, very high, but with our nasal septal flaps, we're less than 10%. Now, this is probably the most controversial area of a skull-based surgery. And what have we learned about this? This is meningiomas. And one of the lessons that I've learned in terms of surgery is that, there's a lot of controversy, but to me, controversy is actually good. I think controversy stimulates discussion. It drives progress. What I do not think is useful that I've learned is dogma. And there is a lot of dogma in neurosurgery. The issue of never do it this way, always do it this way, never use radiation, always use radiation. This is dogma, and as Steve Jobs said, don't be trapped by dogma, because what you are doing is living in other people's thinking. So in terms of anterior skull-based meningioma, there are those who will say, never, this is a stupid idea, you must never do an endoscopic approach. And in fact, this goes back to Harvey Cushing with tubercular cell meningiomas. Even he looked at it. What is the best method of exposure? And so the endoscopic approach has some advantages to meningiomas. It's a more direct approach, obviously avoid craniotomy, et cetera, et cetera. Of course, it has its disadvantages too, including reconstruction and CSF leaks. So this young doctor came, she had been offered many approaches. What did she choose? I let the doctor choose, which she chose an endoscopic approach. And this is just to quickly show you that this can be done. It's a small lesion. And this is after the removal of the lesion that you can see here in this patient is repair with a vascular nasal flap reconstruction. You can see after the total removal. And this patient, just to show you, 2 months, 7 years after the removal, remains tumor-free. And this is from 1 year, 5 years, 6 years, 7 years, 10 years with an endoscopic approach. However, we learned several lessons. We learned that, can this be done endoscopically? Like, absolutely not. This is all the characteristics of that is not good for endoscopic. And so I came to the point of view of looking at the favorable. These have to be very small lesions. They have to be midline, no vascular encasement, et cetera, et cetera, et cetera. That there may be an indication, but all of these large tumors are not tumors for an endoscopic approach. This is our series. You have to, at least this is a meta-analysis. And again, looking at open and endoscopic, but the thing that I've learned also again is that meta-analysis and systemic reviews, you have to be very careful. And for the younger people here looking at that, because often these are unreliable, particularly in meningioma, enteroscopic meningioma, there's a case selection bias. Olfactory, they put olfactory groove, planum and tuberculum cella together. These are very, very different entities. And so you have to be very careful. So where is endoscopic surgery on the Scott's parabola? Well, some people would suggest that for meningiomas, it's fallen off the curve, that you should never do it. And my feeling is I don't agree with that. I think we are here looking at very carefully selected patients, and there may be those selected patients where the endoscopic approach is the approach of choice. Finally, we get into the lessons that the skull-based surgeon of the future must be receptive and embrace the concept of change and innovation. So we all are aware of this. This brings us to the issue of training, simulation, and robotics. And really the concept of simulation in surgery, we've been very late in the game, surgery. While aviation, military have, really adopted this concept, surgical simulation really has involved really cadavers, animal, and now we're really in the era of simulation virtual reality. And, can it offer advantage? Yes, in terms of preoperative planning, in terms of skill training and training for residents, fellow in training, maintenance of competence for practicing neurosurgery. And there's been studies to show that in fact, preoperative simulation training for residents, fellow can improve their dexterity, safety, and efficiency during actual surgical procedures. So how real it is? This is an endoscopic simulation, a third ventriculostomy. Here's the endoscopic view, and here's a view. So in fact, it is fairly real. And this is, you can see here, the anatomy and the endoscopic. And this is important because it can at least telesimulation surgery education in third world countries that this can help. And now we have the Canadian system. There's one also in Milan of how to resect the meningioma. So a resident can go in and do that. And now with haptic feedback, it allows the assessment of force and tissue disruption. And endoscopic surgery and transfemoral in the ENT, this is significantly at least is used. Finally, the new solution to training of the skull-based surgery. And we're looking at basically a hybrid model. And this is not a new concept. We know in cerebral vascular disease, the endovascular and open neurosurgeons, spine, orthospine, neurospine, radiosurgeons. I'm a radiosurgeon. I do gamma knife radiosurgery. And now the skull-based surgeon of the future, who is going to be a neurosurgeon, he's going to be an ENT and rhinologist and head and neck surgeon. And the skull-based of the future, as Halstead said, surgery would be delightful if you did not have to operate. Robotics, now in terms of robotics for neurosurgery, to date, there's not been any major robotic system that has been useful for neurosurgery, but my mind is it's only a matter of time that eventually it will be be involved in neurosurgery. Finally, 2 more slides, Aaron, if I had my time. The lessons I've learned from my patients, and I think we indeed learn much from our patients, whether we realize it or not, and that they affect our lives. We may not think it. They are the heroes, at least of my success, if indeed I've had any. It is from our patients and their families that we learn about courage in the face of adversity. It is their strength, their determination, that even in the face of fear, loss, and our own failures, that helps us to carry on, to try harder, and to do better, to succeed. And they've taught me that no one is guaranteed good life and longevity. Life can be unfair. That 5-year-old child who gets a malignant tumor, or the 25-year-old with a GBM, they taught me about acceptance, that you have to accept life as it goes, and how important listening is, to listen to your patients. And above all, patients want honesty, and we talked about it, which helps build the trust they need to weather their storm. That taught from them, I've learned from them to empathy and compassion and gratitude, and the strength of will and the dignity in the face of adversity, the importance of family and friends, and the value of the human connection. The last and final lesson that I've learned, and the answer to a rewarding and happy life. What is it? Mindful meditation. As Dalai Lama said, our prime purpose in life is to help others. If we cannot help them, at least let's not harm them. And do not dwell in the past or in the future, live in the present. And finally, follow the 3 R's: respect yourself, respect others, and have responsibility for all of your actions. So thank you very much for your attention.
Thank you very much, Professor Gentili. That was, that covered, all the lessons that I certainly wanted to know from someone of the experience. I am always of the mind that what you call you learn more from the people who had gone before you, and that's, as you said, that's something that you can't ever learn it from books, from looking at. So thank you very much. I think I'm sure everyone is really enlightened about neurosurgery and life, and this is I had about 4 hours discussion with you over the dinner, in maybe even 5-6 hours in the with the Professor when Maurizio Iacanangeli organized the dinner for us. It was, we covered many areas, and what you call, so it was really great. Professor Gentili, is it okay if I hold the questions for you after the next talk, because both of them marry each other well? So then we can have the questions to yourself and Professor Ghassan Aloussi, if that's okay with you.
Yeah, no, that's quite fine, no problem.
Thank you very much. So it really gives me, the next 3 talks are very personal to me in many ways. It really gives me a great honor, pleasure, privilege, and more than that, to introduce Professor Ghassan Aloussi. He's the professor of ENT and otolaryngology at he works at 2 prestigious London hospitals, one at the Royal London Hospital, the Barts Trust, which is the oldest hospital in England, going back to 1000, the time I think Richard the Lionheart came to Britain, and also to the prestigious UCL. So to be in 2 units in London, which are very competitive, is in itself amazing recognition. I worked with him in Royal London Hospital. He was the ENT surgeon of otolaryngology, surgeon of choice for any doctor, and he's a fantastic surgeon without question, and he does skull-based surgery, extended endoscopic surgery with his colleague, a neurosurgical colleague, Mr. Paraskevopoulos in Royal London. He is very much into training, and he has his registrars love him, and he has got a research lab which is very active. And once again, as Dr. Gentili said, he's a man who can, who's very good at what he does, but it's, he's someone who's change, who's adapt. I think there's a lot for neurosurgeons to learn from ENT and otolaryngology. I'm sure it's the other way around as well. They were quite facile in adapting the microscope. I think, they were before us, and they were also quite adapted adapting the image guidance as well. So I think, it might be that the skull flow might be the separation between ENT and neurosurgery, but we are very much spiritual cousins. And in terms of, the other thing, in my life, there are many people I thank for. And what you call Gus Alusi is one of them, because he operated on me. And, it's actually my mother is logged on to listen to his talk. In terms of, not just me, but any other patient who goes and sees him, or even other doctors, they will come and say, the way he's with the patients is unbelievable. Just to go and see in his clinic is privilege. But more than that, he's more than a doctor, colleague, researcher, but a lot of philanthropy. He is very active in the ground in Nepal and in other places. So great pleasure, Mr. Alusi.
May I share my screen, Naren?
Please, thank you.
Naren, I thank you very much for this fantastic introduction. I really am very honored to be here as an ear, nose, and throat surgeon. Presenting to you guys is a phenomenal honor. This has been a long journey for me. I've been listening to these talks. I am really in awe of everything that's been said and been done. I'm extremely grateful to Dr. Gentili for his presentation, which really just lays the ground for what I'm going to be talking about. I work at Barts Health, which is my NHS practice, and I work at UCH, where I do my anterior skull base and cancer surgery. I'm an ear, nose, and throat and head and neck surgeon, and I have academic positions at both Queen Mary's and University College London. And I've been involved in research now for over 25 years, since the 90s, since the early 90s. What I'm going to talk about today, I'm going to go into a slideshow now. I'm going to talk about my journey, our journey. It's the same, where we've come from, what we've done in terms of endoscopic sinus surgery. On occasions, one group would be a little bit ahead of the other, but over the years, everyone has caught on. And we got to a point now where we can see some fantastic surgical approaches. But how did we get here to do endoscopic skull-based surgery? I want to spend the first half of my talk about how we got there, and then how advances in imaging, augmented reality, visualization, navigation will be the way forward for us, as we will need to move on. We are reaching a limit now. I'm going to talk a little bit about the imminent and very soon introduction of surgical robots, a tiny fraction about artificial intelligence, but then I'm going to spend a couple of minutes talking about some new breakthroughs where we're not expecting to see breakthroughs. What is the expanded endonasal approach, which we all talk about? It's an exposure and an access that gives us access to the whole of the ventral skull base, from the olfactory groove all the way down to C2. It gives us access laterally to the infratemporal fossa and jugular foramen. It's a minimally invasive generic transnasal approach, but it is entirely modifiable based on the pathology. These lesions can be arising from the ventral and dorsal aspect of the skull base. And as we've heard already, there is a limit to what endoscopic skull-based surgery can do. When we started off endoscopic sinus surgery back in the 90s, maybe a little earlier, we're doing procedures like middle meatal antrostomies, ethmoidectomies, maybe even frontal sinus Lathrop's procedure. But then we pretty soon moved on to orbital decompressions, optic nerve decompressions, medial maxillectomies, and even transmaxillary approach to infratemporal fossa. Sphenoidotomy was the key for me personally in my journey to go into hypothectomies and to go beyond that into the transsphenoidal approach to the petrous temporal bone. Eventually, I was tasked with treating patients with recurrent nasopharyngeal carcinoma, and have been involved with nasopharyngectomies, doing those endoscopically, and even some transclival approaches. Anterior cranial fossa approaches were the key, ultimately, to begin to allow me to realize where we can go with this. I'm going to talk a little bit about septal flap reconstructions. I'm only going to choose a few of those procedures just to demonstrate my point about this journey, this skill progression in endoscopic skull-based surgery. The key to me was the anatomy from the very beginning. These are some of the earliest dissections that I did in early 2000. These are cadaveric dissections where I'm trying to understand the anatomy, the endoscopic anatomy. I already understood the open anatomy because I do open endoscopic skull-based surgery, and perhaps that's 50% of my work to date. But I needed to understand the anatomy from this point of view of this distorted two-dimensional fish-eyed view of the endoscope, which is a phenomenal view that gives you access to everything here from the pituitary, optic chiasm, and the internal carotid within the sphenoid. Phenomenal anatomy, and I spent a long time operating on cadavers, both endoscopically and open, to be able to begin this journey before I'd even realized that we can go that far. I was just doing endoscopic sinus surgery, open middle meatal enterostomy, maybe orbital decompressions even, and ethmoidectomies. I was able to get into the sphenoid, and as I said earlier on, that was the key. The realization that endoscopic views of the skull base through the sphenoid opened up an opportunity for us to do surgery that had not been possible before endoscopy was a real eye-opener. I began to learn as from this endoscopic anatomy that there's a relationship of the ostium of the sphenoid to the skull base, that when you find it, you mustn't go up, you must go down with your dissection. So we make these openings into the sphenoid, but we also preserve the other side. We preserve the septum. We preserve the septum for a flap for reconstruction, as we've learned over the years that that's probably the best way to reconstruct. Initially, probably small, very small pituitary tumors. Here we see a small pituitary adenoma. I must say that none of this would have been possible without the work and the collaboration with my neurosurgical colleagues, who were as willing to learn to hold an endoscope and learn to see a tumor from below and the skull base from below, which made it possible that the teamwork allowed us to do more and more extensive surgeries. And when you remove that tumor through this approach, essentially the septum is intact, patient goes home the next day or the day after, and hopefully biochemically would be completely cured from disease. We did about 250 of those before we then started to look at some more difficult cases. Here we see a tumor extending lateral to the internal carotid artery. This is the sphenoid sinus. The original tumor was here, and we're now looking to get into the cavernous sinus. This was really the first time that we progressed in this area in a way which I could not have even predicted a few years before. Here we can see a Doppler being used because image guidance and navigation is not so accurate in the soft tissues as they distort. And we're able to get into, having identified the internal carotid artery, I'm able to open up the cavernous sinus, and then with the help of my neurosurgeon, together we work in unison to remove this tumor. There you can see two instruments, an endoscope and a curette, but you'll also see 3 instruments, which means that the two of us are working together. Just here is the internal carotid artery, and it was a scary journey. It was a very difficult, scary journey, but the good results are always what gives you the confidence to progress and carry on, and the bad results help you to understand your limitations. This here we see is the internal carotid artery. Now, I was already doing open approaches, craniofacial resections for olfactory neuroblastomas, subfrontal approaches, sometimes with the help of my colleagues in neurosurgery doing a bicoronal approach. This is a spectacle approach. And this was all the training of Professor Tony Cheeseman, whose experience goes back decades before this. I asked the question, can we try and go endoscopic for the smaller tumors? He said yes, but only if he can do an open approach afterwards to check. Here we see a post-tumor resection of an olfactory neuroblastoma. With these olfactory neuroblastomas, with the smaller ones, we realized that we might be able to do those endoscopically without causing too much harm to the patient. Actually, we continue the research, and we have a program at the moment doing RNA-seq data, analyzing RNA-seq data, which we've sent off on over 60 tumors to see if we can classify and understand better why some of these are aggressive, to go beyond this high-end classification. Here, the olfactory bulb is in fact excised because I know that there will be a possible 30% chance of tumor being still present in the olfactory bulb. We continued on from there to excise bigger and bigger tumors, and these defects then had to be filled in. And here we see a defect in the anterior cranial fossa. There's the septum on the left-hand side, and the workhorse eventually became the septal flap. With the larger defects, so I always raise a septal flap. Some of my colleagues are now raising what's called a rescue flap, which means an incomplete raise of the flap. But the workhorse for me was, for these big defects, the use of septal cartilage to reconstruct these defects. Fiddly procedure to do here because of the one-handed surgical approach. With here I'm using a sucker to reconstruct the defect. Eventually, with time, though, the use of biologics meant that the smaller defects I could close without any cartilage. The cartilage is inserted, of course, underlay. This is followed by glue, and this technology has moved on tremendously, and I'm not going to spend time about the biologics, but the septal flap really reduced the CSF leak rate dramatically for us, both on these type of defects and also traumatic defects and spontaneous CSF leaks. So that's the workhorse. The cartilage that's left exposed when you have a splint over it remucosilizes, and you get a whole new septal flap over the cartilage as if nothing had happened before. The septal flap, as I say, is raised all the time, but actually it may be that we don't need a septal flap. But as it's been raised already, the flap is then just move on there. The flap, if it's not needed, it's brought back into the original position and sutured in place with a splint. And perhaps in the future, more and more people, including myself, will follow the use of the rescue flap, where not the whole flap is raised, to do the reconstruction. As we've seen earlier from Dr. Gentelli, that it became obvious that a lesion like this, a petrous apex cholesterol granuloma, is just there. It's just right in front, right behind the sphenoid. So it would be possible to drain a cholesterol granuloma this way, rather than using a middle cranial fossa approach with all the inherent problems that this may bring with it. And I'm going to show you a very short video here. This here is the posterior wall of the sphenoid. We're into the cholesterol granuloma. Here you see the middle cranial fossa dura, and as the endoscope is, the view is incredible, of course, but as the endoscope is withdrawn, you can see the internal carotid artery coming into view here. A septal flap is then used to cover the line this defect, and the patient is home a day or two later. As we got braver and began to understand what we can and what we can't do, here we see a post suprasellar meningioma resection and a sellar exploration. You can see the optic chiasm and the optic nerves and the carotid artery, and it is a spectacular view, something that cannot be obtained by anything other than an endoscope. And so on and so forth, to chordomas and transclival approaches, and I'm not going to dwell too much on this, but I'm going to say that we've come a long way, and this was a journey. We couldn't have arrived, even if we were given all the instruments that we had available to us today, and the biologics and so on, we wouldn't have been able to do this. And the pioneers of this journey have come not just from one discipline, but from a multidisciplinary background. Joe, Kassam, Schneiderman, Capabianca, Caro, Gardner, I only mentioned but a few. So we are still looking at improving intraoperative imaging, maybe even MRI, intraoperative MRI, which is already here. We're looking at how we display the imaging, and that's what I'm going to talk about next. And I want to talk about how we can enhance human dexterity. We've enhanced it a lot already, but, through the use of various surgical instruments, but can we go even further? I'm not going to talk too much about hemostatic and biologic material. Well, the future advances to me come from augmented reality, that means visualization intraoperatively, robotics, ultimately artificial intelligence, although that's already being used intraoperatively because of the amount of data that's available. And I want to say a few words about immunotherapy because of the recent announcements that have come our way. Image guidance has become our workhorse. We've been using image guidance now for 20 years or more. And it's incredibly helpful and fantastic, but actually it does have some limitations. Can we do better? Well, yes, we can. We can do this with augmented reality. 26 years ago, I started a PhD, the title of which was Augmented Reality in Skull-Based Surgery. This was finally published after I took my post as a consultant at the Royal Barton, the Royal London in 2001. And this was a subject that's very close to my heart, but this was an area where processing and the computer power that we had in the 90s was really negligible compared to what you guys have, what we all have on our phones nowadays. So we had to resort to some innovative ways using this multiplanar way, reformatting to see if we can try and display anatomy in a way, and the scans in a way that could be used intraoperatively. But then eventually by 1997, we had a grant from the UK government for approximately $1 million, which is where this machine was bought from, called the Silicon Graphics Infinite Reality. And we moved from the normal CPU processor to using graphics processors so that we could now perform really quite spectacularly at that time. Interestingly, I'm going to go back because I want to show you, I don't want to skip over this. This is the type of rendering that we're doing. This is volumetric renderings, keeping all the data of the scan so that we're able to manipulate this. I know that we can do this already on our computers, but it's been a long journey to get to where we are now. I'm talking about 25 years ago. Then we could use volume roaming to interrogate large data sets and try and present data. We've even gone as far as looking at the use of four-dimensional data sets. Here, we looked at an MRI scan of a heart, a beating heart, and we're able to visualize the valves and so on, and looking functional aspects of visualize, as we had so much processing power suddenly available to us. But in reality, the majority of the work on the algorithms that were done by my team, and all this work was done at UCL, was done on image processing, on segmentation, which remains up to date today, the work that's been done. Tracking, that means in 3D tracking, and different types of tracking exist. Registration of the Cartesian coordinates of the scan to the real world coordinates, which we do now with impunity every time we use image guidance. Augmentation, and how to display the information. This ultimately led to the idea of, well, is there a way that we can use this for simulation before we get into surgery? There was no chance of us getting intraoperatively with this technology at the time. And yes, indeed, and here I'm using a tracked instrument. In fact, this is ultrasound tracking, which we developed in our own lab, in my lab in the 90s, in collaboration with French universities. So you can see that the voxels here are being deleted as I'm moving the instrument. And every time it goes red, that means it's touching a voxel, which is bone voxel. So very interesting, very exciting. This has now moved on a lot further. But can you go more than this? Can we go, where can we go with image guidance or augmented reality? Here you see a juvenile angiofibroma on a young 18-year-old young man who I operated on a year ago or so. And I wanted to get my visualization to be a lot better. Here we see a 3D reconstruction. This can be done on anybody's desktop, of course, even with the transparency. This was done by, with the help of Simon Morley, my neuroradiologist at UCH. And we can see the tumor very clearly. He then starts to change the transparency so I can see the relationship to the skull base, how it moves into the pterygopalatine. But, well, can we go even further than this? Well, yes, we need to go to augmented reality. And here we see the use of the Microsoft HoloLens, and this is work that's being done with Professor Mark McGurk, as well as Apoclau, which is a German company, writing the software for us in collaboration with multiple institutions in the UK. We're looking at producing these holograms, allow you to visualize the data, not just preoperatively, but we will be able to display this intraoperatively over the patient with specific data, with specific information that we want to display. You can study the relationship to the skull base, you can study the relationship to the nasal cavity, if you, and you can walk around it, you walk around the scan if it's fixed in space. Here we're looking at it in relationship to the nasal cavity and how I would approach it from the nose, which is what I did. It's a phenomenal way to visualize data prior to the surgery, but it will be fantastic, and it will move on into the operating room. They have already developed the software for display of the endoscopic images into the Microsoft HoloLens, which is what's being used at the moment to show you this film. What's next? It is quite clear that we, over the last 10 years or so, even with various improvement in instrumentation, are reaching a limit. And perhaps in human dexterity, and perhaps there is something that robots that can offer. They're able to perform movements repetitively and precisely. This is the case of active robots. They can have pressure sensors that can be integrated within these instruments. They'll allow us to perform exact movements and avoid accidental movements. This is in the case of master-slave type robots. So the limitation for anterior skull-based surgery and skull-based surgery in general will be the development of what is already in use, which is the single-port robot. That means a single port that will be about 1 centimeter in size. It's almost there. It's not going to be very long before we'll have that single port here carrying the instruments that you need to operate with a colleague and a camera, which is stereo for the first time, although there are stereo endoscopes. For the first time, we'll be able to operate with 3D depth at the same time and having two hands at the same time. This will change dramatically our ability to go beyond the current dexterity that's offered to us with the instruments that we use. We can go to 7 degrees of freedom. We can eliminate hand tremor. We can eliminate accidental movements. We can translate a very big movement with the hand into a very small movement. We can plan and drill using the surgical simulation software a whole mastoid and translab, as we were talking about earlier on, and then give that to the robot to drill for you exactly, precisely, and at a fraction of the time, as being shown in Toronto and in other places who are developing these types of robots. Next will be artificial intelligence, as we see with Da Vinci robot and other robots that are available at the moment for laparoscopic surgery. We are getting a huge amount of data from these mechanical armatures. This data can be then used by artificial intelligence software to predict, to understand, to help the surgeon see patterns that we might not have seen. There's already precedent for this. This is not futuristic, but it's just hasn't happened yet in our specialty. We need robotics to start to be smaller so we can use it in our specialty, and we need to start to collect data about what are we doing with our hands. It's no good having every single person saying that I'm the best at what I do. We need to be able to analyze why they are so good at what they do. Finally, I want to say a few words about immunotherapy. It is very timely that on Friday night, the first day of this conference, Diagnostic have announced their phase 2 results in oncolytic adenoviruses, replicating oncolytic adenoviruses that they've used in glioblastoma with some spectacular results. We must be aware of where the future of skull-based surgery and the development in other fields, and we must be taking this on to be part of it. It so happens that oncolytic viruses are a big interest of mine, and I've really been working on this for about 15 years now. And we've been developing oncolytic viruses. We are getting some in our into clinical trials in our other areas, other tumors and head and neck cancer. But oncolytic viruses have shown remarkable success so far in other diseases and other cancers. But there are also other applications. You can use gene therapy using the same adenovirus with various modifications to insert new genes to increase sensitivity to drugs. This is with the herpes simplex virus, which is thymine kinase deleted to make it selective. You can inhibit oncogenes. There's so much that is going to happen. And we need to be aware of this as a specialty. We need to be aware of where immunotherapy is going to take us, gene therapy is going to take us. These guys at Diagnostic, what they did was they used stereotactic insertion of a catheter into the middle of these glioblastomas. They then injected the virus, left the catheter in place. They then had 2 groups. One of them went on to have surgery and further oncolytic adenovirus insertion, or just a second dose. The results are, I encourage you to go and look this up. The results are spectacular, and it is the future of how we're going to deliver treatments and how we're going to modify treatments or to make certain treatments easier. How does it work? Well, you've got a virus that has been designed. This happens to be one of our viruses. It goes into a cancer cell, it starts to replicate within it, and it lyses the cell. The reasons why it does this is many. If it goes into a normal cell, it is unable to replicate, and replication is inhibited. you'll all have heard of the adenovirus because that's what's being used at the moment for to encode the spike protein. How does it work? I'm going to show you a little video over here now, and this is my last slide, hopefully.
Oncolytic viruses work by priming the immune system in a manner similar to a vaccine. The treatment involves the injection of oncolytic viruses into an accessible tumor site, primary or metastases. The viruses would then infect tumor cells. They would deliver their DNA into the cell, which then takes over the cellular reproductive mechanism to produce tens of thousands of copies of itself. The virus presents a strong danger signal to the immune system through the release of cytokines and chemokines. Oncolytic viruses would then cause lysis of the tumor cells, releasing tens of thousands of copies of the virus that then infect other tumor cells. When the virus replicates in tumor cells and lyses them, it releases hidden tumor-associated antigens. These new previously hidden antigens are now recognized by antigen-presenting cells, most commonly dendritic cells. The dendritic cell's main function is to process antigen material and present it on the cell surface to prime naive cytotoxic T cells against these tumor-associated antigens. These newly primed T cells would then go on to attack and kill other tumor cells that have the same tumor-associated antigens not previously recognized by the immune system. Oncolytic.
This is the end of my talk. There's so much more I could have talked about, but I wanted to limit it to those areas which I feel are most promising in the next 5 to 10 years. Many thanks indeed for this opportunity to talk, Naren. I really genuinely appreciate this.
Professor Alousi, thank you very much for a fantastic talk covering from the beginning and where we are heading. May I ask Professor Gentili to also comment on what he mentioned, in 5 years, 10 years, 15 years, are we, where will we be, Professor Gentili and Dr. Alousi, in terms of skull-based surgeries?
Well, I enjoyed the talk very much. I think I agree. I agree that as much as we're surgeon, as much as we're technical surgeons, there are many, many conditions that the answer, as I showed you already in terms of some malignancies, surgery is not the answer, will never be the answer. Surgery will never be the answer to GBMs. I can give you a little story about in terms of when I did my fellowship with Yazi Yazergil a few years ago. He would spend 30 minutes to clip a very complex aneurysm. He'd spend 5 hours on a GBM. The idea that he wanted, it's like, I don't know if it's Trump or something. He wanted to kill this thing. He was going to do it. And he wasn't able to do it. Now, it improved the outcome because you did not go in and so forth. So there's no question that surgery had a role, but it's not the solution for GBMs, and it's not the solution for many conditions. I don't believe that surgery is a solution for chordomas. I do many chordomas. I've reported on chordomas, but intrinsically, surgery will not be the solution for chordomas. And so, no question that these other things that were mentioned, the idea of immunotherapy, of chemotherapy, radiation techniques, and so forth, is key. And as much as we are, as surgeons, but we have to look at the reality. So absolutely. Likewise, I totally agree with the issue of simulation and artificial intelligence. I think that is the future. And as I said, we have been very slow to come to this in medicine and in surgery. If you look at it, I said, if you look at military, you look aviation. The idea that before you can fly a plane, you have to do 10,000, I don't know how many hours of simulation to look at every possible problem that can come with an airplane. Well, we let our residents come in, and in the end, he has to clip an aneurysm, but he's never clipped an aneurysm before. You're there and you're hoping that whatever. So there's no question to me that simulation is critical. It's going to be a part of our training, and that and it's related also to society. Society will not accept now, and particularly North America does not accept. They want to know who's doing my surgery. Are you going to do my surgery, professor? I said, well, yes, I will do the major part of the. Well, yeah, but I want to know, what is the other person going to do, and has he done it before? And so, the reality is that society is asking us, that they want to know that this person can say he's done 1,000 of these simulations. The idea that he's done so again, simulation I think is critical. Robotics I think is the future. Professor Alusi, I don't know the time frame because of the advantages, potential advantages are incredible. As you say, the idea of tremor, the idea that you can remain for hours. But as you know now, currently there are really no, at least in neurosurgery, I understand in ENT, in fact, that you are using robotics for some of the how do you say, nasopharyngeal tumors, and I don't know what the results there are, but eventually it will be the key. I don't know the time frame in neurosurgery. So absolutely, I think it's key. Whether in other modalities, we have to, as surgeons, be aware of these other modalities. We have to embrace these modalities when they work, and we have to accept the limitation of surgical technique.
Thank you, Dr. Fred Gentili. Dr. Professor Alusi, can I just come back to you? Any reflection on what Dr. Gentili mentioned before I go to the other senior surgeons? Thank you.
I'm absolutely in agreement with everything Dr. Gentili has said. It seems as if I'd known him for a very long time. I haven't met him before. I'll make sure when all this is over to go and visit. But I'm absolutely in agreement. Surgical simulation is the key with the right instrumentation. I think robots are around the corner. They're already making robots which are sub-centimeter in size. We can use, people have tried transorbital and transmaxillary approaches for the robots to give space. But in our oropharyngeal tonsillar carcinoma work, we have a robot, Da Vinci robot. It's completely revolutionized. The results are far superior. The fact that you have two surgeons working simultaneously within the oral cavity is just, you cannot do it. And two people working simultaneously, with a camera, both seeing in stereo, holding multiple instruments, including scissors and forceps and grabbers and diathermy and so on, to perform such precise surgery with such amazing visualization. It's really the way forward, Robert, and it'll come into skull base. Just watch the space. It's not 5 years. It's a year or two before that first robot is introduced, and I envy whoever's going to do this. I hope it's before I retire.
Thank you. Professor Groton, you have been, on the forefront of innovation. You have brought innovation to neurosurgery, both surgical but also in instrument-wise. How do you see improvement of outcomes and improvement of training, and on what the points raised by doctors, Professor Alusi and Dr. Gentili? Thank you.
Well, that would be a long talk if I would bring this up all. No, I have seen several times the lectures of Fred Gentili, but this one was really among the best, because this is so superb. And also, Dr. Alusi, I congratulate you, because also bringing up artificial intelligence and robotics. I saw in your 2 slides that you took a picture of our development, the so-called RoboSculpt. That's the robot that is developed for ENT surgery in drilling the mastoid. I saw that picture. This was...
I saw your presentation on this back in the a couple of years ago here in London at the Skull Base conference, and it was, unbelievably amazing, and I think this is the way forward.
Due to the well, actually, we already plan to do using the patient. The first patient will be in probably now in January. Because of the COVID, we had to move it all. But I think yes, it's difficult to say what it will do to the outcomes. I think when I look to Fred and to others, then after so many years. So being 40 years in neurosurgery, you learn that outcome is not only based upon technology. So I mean, technology helps. This absolutely, and I agree that the possibilities that we will have technically will improve still in the next few years immensely, but that is not the solution to the diseases that we are confronted with. That's the point, that the diseases are still the same as 100 years ago when Cushing started. And maybe because I see also in the participants a very, very, very experienced neurosurgeon and a great friend of mine, Professor Tamás Dócsi, from the University of Pécs in Hungary. In the 90s, we have met several times. I think maybe we also can ask him to reflect on this, because I know, like me, he's emeritus now, and can look back to these developments and reflect on that, because I think technology is important. But again, as Fred was saying, this is not the final solution. It's perfect that we have all these developments, but we have to put it into the right perspective.
Thank you, Professor Grotrius. Professor Doxy, can I please, if you can, come on your microphone? Thank you. And your reflection. Thank you. Dr. Doxy, can you hear us?
Tamás, can you hear us? You are unmuted, so you can talk.
Sometimes the microphone plays up.
Yeah, that could be.
While we are waiting for Professor Tamás Doxy to give his opinion, we have got Dr. Haber. Dr. Haber, I will introduce at the meeting. He will be giving us the next talk, but he was at Penn State, they have a huge bioengineering department, massive bioengineering department. And Dr. Haber has been an innovator in neurosurgery, but also in, one of the people who was instrumental in getting neurosurgeons to do endovascular and clipping in US that really secured vascular neurosurgery in US. Dr. Haber, there was Dr. Gentili mentioned in his talk about the interface between neurosurgeon and the ENT surgeon. Do you see a dual training in that area as well? Thank you.
Yeah, so first, Naren, thank you for setting this up. That was a terrific talk. This whole conference, I think, is outstanding. And I agree with almost everything that's been said. I mean, there's going to be a lot of cross-training. I know at our institution, we have a skull-based center that's co-directed by ENT and neurosurgery, and we work together seamlessly. I think that the technology is going to help as that gets better. We're going to be able to do things we just couldn't do before, and we're going to be able to do things safer. Artificial intelligence, I think that is a huge field coming forward. I mean, right now, we use it primarily in diagnosis, but we are going to start using artificial intelligence to direct our treatment. We have a project going on in our neurocritical care unit now where we collect all of the myriad forms of data that we collect on neurocritical care patients, imaging, clinical status, intracranial pressure, labs, et cetera, et cetera, et cetera. And you know, right now it's the neurointensivist who kind of integrates all that information and it says, okay, how do we need to intervene to achieve the best outcome? But you can use a machine learning algorithm to look at all of that data, and the more data it analyzes, the smarter it gets. It's basically the same approach we use for predicting, the weather. And the idea is that we can look at where this patient is now, what's the state of the system now. Left unperturbed, what will that patient look like in 6 hours? And if we intervene in this way, how will that change the outcome? That's where I think a lot of this is going. We're going to get a lot of information on our patients from artificial intelligence that are going to allow us to refine our treatments in a way that we can hardly imagine right now. So just in summary, we're going to have new biological treatments. We're going to have new insights from AI. We're going to have new technology that helps us do things better. And we're going to need all of them to address some of these disease processes that have thwarted our best efforts, for 100 years.
Dr. Haber and also Dr. Aras, in terms of Dr. Haber, you are obviously, as American neurosurgery as one can get, in terms of the residency training and fellowships, when simulation was done 4 or 5 years ago, 6 years ago, to be honest, my impression I got was, I didn't do simulation research, but, it was thought to be, these people are just playing around. But where do you think, because of the patient expectation and legislation, where do you think simulation is going to come in the training part of the a formation of a neurosurgeon? And what's American neurosurgery doing?
Well, I think simulation in regard to things like endovascular treatment has really come a long way. I mean, you can now have, and we have endovascular simulators where you can load the angiographic pictures into the system and actually do the procedure before you do the procedure, and the feel is right, the visualization is right. So I think in some places it's come quite a long way. In open surgical procedures, it's a little more difficult because the biggest problem has been the haptic feedback. It's not what it looks like, it's what it feels like. And that's a hard problem, but robotics may take care of that. We may not have to have if we're doing our surgery without that immediate haptic feedback, we may not need the simulation to have that haptic feedback. So I think everything's coming together to say, if you look into the future, we're going to do a lot more training with simulation, we're going to do a lot more surgery with robotics, and we'll probably have better results because of both.
Thank you very much. Professor Miguel Aras, if you are there.
Yes, I'm here.
Hello, Professor Aras. I know you have an active department and active education center and Spanish neurosurgery. Anything, where are we with what do you think about, first of all, what Dr. Fred Gentili and Dr. Gasalusi in terms of the lesson learned from Dr. Fred Gentili and future from Dr. Alusi, and what Dr. Haber said? Thank you.
Thank you very much. First of all, I'd like to congratulate both of them. Outstanding talk. I think that the presentation of Dr. Alusi, just final part, did focus on two important issues, robotic and simulation. I think that we have seen outstanding progress in robotics, for instance, for abdominal, prostate, and other abdominal operation with the Da Vinci system, We even did years ago some attempt of using the robotic Da Vinci system for transoral surgery. It wasn't successful because of, because of the design of this robot. So, well, there are some other system not much popularized because of limitation and because of some important issues for microsurgery and neurosurgeons cannot be yet being solved by robotic. This is my understanding. So for that, we are still far from having robots doing a skull-based surgery. One of the issues is the difficulty to maneuver inside, the difficulty to feel the consistency and some other characteristic important in surgery and skull-based surgery. Regarding simulation, we have been seeing, I remember maybe the last WFNS, we saw an amazing system for simulation and 3D view, holograms and so, but let's say that we have a perfect model for simulation, that is the anatomical lab and the cadaveric courses and training. And I think this is something that we nowadays must implement in the training of our young colleagues, anatomical lab. The future robotics for skull-based surgery simulation is about to come, but we do have this very important aspect that maybe we all devoted to skull-based have been doing over decades. This is something important. These are my comments regarding the presentation of Dr. Alusi. And just, I don't want to take much of your time, but I was very much happy hearing the presentation of my very good friend, Fred Gentili. I think we have to highlight several issues. I think that Fred spoke about evolution and history of a skull base, and this is very important to know where we can and where we want to go. Otherwise, we will never get there. This is absolutely true. This is some saying from the north of Africa. And you talk something about complication. We have to keep in mind that 1 out of every 3 publications in skull base includes the term complication. So this is so high, so frequently seen and so important, deserving many words and many discussions about that. He also talked about quality of life. What is the situation of the patient after doing aggressive, more or less aggressive resection, trying to save his life? What about their quality of life? This is something very, very important. I think these 3 points must be, underlined. And Fred, behind that, behind all these comments, we have seen and we know the vast experience you have in a skull base and the wisdom that is just in between all slides and presentation. So I like to make, in regard to those presentation and the presentation of Fred Gentili, some comment for the youngest colleagues in the audience, because I think all these activities are mainly devised, and Naren is absolutely great about that, are mainly devised just to transmit something to the youngest colleagues in the audience. So I think Fred has shown how he is a very good example as a skull-based surgeon. We all see in the international arena discussion between open approach, endoscopy, yes, not, and so. Well, the answer is the attitude Fred has been showing. He has an incredible experience and expertise in classical skull-based techniques, and at the same time, in the proper time, early, if I may say, 1997 was the very beginning of the endoscopic technique in the hands of Dr. Joe in Pittsburgh. He embraced the nascent skull-based endoscopic techniques that are absolutely outstanding. we cannot do anything without that. So the message for the young colleagues is just trying to embrace both techniques. We cannot think that doing a wonderful endoscopic procedure we are able to solve, not now, not even in the future, we cannot solve all the problems. Maybe we can beautifully solve some part of the problem, but not all the problems. And I think that, well, we have been seeing in this presentation 35 years of very hard work. That is also something exemplary for the youngest colleagues. And very important, this is not related to technology. This is not related to artificial intelligence. I like to also highlight honesty and humbleness that are these are qualities that doesn't need any sophisticated technology, but the good heart that Fred has for everything. So I'd like to finish my comments on your talk with these words. Thank you, and sorry for taking some of your time, but I think the presentation of these colleagues deserve that comment.
Thank you. Thank you very much, Professor Arad. I thank Dr. Gentili and Prof. Alusi. And as I finish this and move to Dr. Harbour, I just want to, as much as we talk about technology and advancement and simulation and everything, and as I said, I have been a patient of Gus, Prof. Alusi, and I think we have to always remember that doctors are healers. And the way you talk to a patient, the way you put the patient at rest, that makes a huge difference. And so it doesn't matter how technologically we come, we should go back to that fund. We never should, that is, I think we are first of all healers. Sometimes we can't treat everything, but patient wants us to first of all treat them as humans, not as tumors. And on that note, I'll move to Dr. Harbour's presentation. Dr. Harbour, could I please ask you to share your presentation? So thank you very much. And so we come to Dr. Harbour's presentation. And Dr. Harbour, I mentioned to you earlier that the last session is all people very close to me who are eminent as well. I mentioned my mother, otherwise I will not be able to do 24 hours of this work. I have a busy pediatric practice, and these 3 days I have been basically like a F-16 having mid-air fueling. So we had the 12-hour session on Friday. I think that's the longest neurosurgical session in the history. And so then I came to Dr. Alusi, and now I come to Dr. Harbour. I met Dr. Harbour back in 2005. I started an internet conference, and Dr. Harbour was the chairman of the technology, digital and technology committee chairman, and Dr. Radka introduced me to Dr. Harbour. I was not even a neurosurgeon then. I was a locum registrar in Manchester, and it was an eminent committee, and it was very gracious of Dr. Harbour to invite me to the committee to give my thoughts on internet conference. So, we have gone 2005, and now actually we are having a fully fledged conference in 2020. And for 9 years, we had an internet conference as well through the listserv. We had good presentations and good discussions. That was the one that created the listserv. And since 2005, Dr. Harbour has been like my mentor, supported the listserv. If listserv goes, that's because of the support I have from my family, then Dr. Harbour and Dr. Grottenhuis. And Dr. Harbour, we pretty much, he pretty much supports me on everything. Every week we'll have an email. And even with this listserv, 2 years ago, I was moving from one job to another job. I was going to be in between jobs, and he kindly gave me a an honorary adjunct post in his hospital to carry on with the work. So, the contribution to listserv or whatever activity I do, I'm very grateful to Dr. Harbour. In terms of Dr. Harbour, he was the past president of he's the professor and chairman of the Department of Neurosurgery in Penn State, past president of the WFNS and a past president of the Senior Neurosurgical Society. We are all the elite neurosurgeons, the Society of Neurological Surgeons. That's only a few things to mention. He has represented the neurosurgery in the Senate, and I've been to his department a few times, and once again, he's a great mentor. And in the American neurosurgery, he's absolutely well poised for the 21st century. And one of those people in terms of the dual training that I know of vascular surgeons and also the national registry. Dr. Haba has been instrumental. And one of the shared interests we have is unruptured intracranial aneurysm, and no better person to talk to us on this. For vascular neurosurgeons, I'm sure this comes every time patients worried that they have got a bomb in their head. And so, it would be great to hear what Dr. Haba has to enlighten us. Thank you, Dr. Haba.
Well, Naren, first, thank you for the invitation. Second, I'm very proud you're one of my faculty members. I couldn't be happier. And just in regard to the last discussion, one of the things I tell our residents when they start is they have to be good doctors before they can be great neurosurgeons. We just can't forget that part of things. It's not all technology. If we become technicians, we'll regret that. So at any rate, my talk today is on the management of unruptured intracranial aneurysms. This is my disclosures. None of these represent a conflict of interest with the presentation to be given today. Let me start out with the case report that I think points out some of the difficulties we have. So this is a patient of mine seen in clinic February 8th, a healthy 74-year-old woman, had a long history of headaches. Outside, a neurologist had ordered an MRI because of this history of headaches. And the MR showed a right frontal cavernous angioma, but the outside radiologist read it as a vascular malformation. Because it was read out as a vascular malformation, the neurologist then requested an angiogram, which was obtained, and you might be able to see this little tiny aneurysm here, and she was referred to me. So nothing about her headache sounded like a sentinel headache. I talked a long time with her and her family about the natural history of unruptured intracranial aneurysm, and that this was a small, very smooth intracranial aneurysm, and that at 74, I thought unquestionably the best option was just to observe this, maybe get some serial imaging to see if anything was changing. And they left very happy that she wasn't going to need to have any surgery. And then less than a month later, she was sent to our emergency room as a motor vehicle accident. But what had really happened is she had driven her car off the road. And she was found obtunded by our emergency medicine technicians. And this is what her CT scan looked like. So of course, that little aneurysm that I told her she didn't need to worry about had ruptured and caused her motor vehicle accident. And as I was walking down to talk to the family in the emergency room, I mean, this is how I felt, that it might be that the only purpose of my life was to serve as a warning to others. You just talk to people about why they don't need their aneurysm treated, and less than a month later, she's in with a ruptured aneurysm. And I think this points out, some of the difficult decision-making that we have in these unruptured intracranial aneurysm cases. And we'd really like to be able to better predict which aneurysms are going to go on to rupture and which can be safely observed. So, this is a hard problem. We're finding more and more intracranial aneurysms incidentally as our surveillance imaging improves. If you look at imaging studies, you find anywhere from 0.5% to 2% of the population will harbor an intracranial aneurysm. If you look at autopsy studies, depending on what you're willing to call an aneurysm and how closely people look, it goes up to 9% of the population. We know that many unruptured intracranial aneurysms will remain asymptomatic. I've followed hundreds of patients in my life who have an aneurysm, doesn't change, same year after year. But we also know that if there is an aneurysm rupture, there's probably a 30 to 50% 1-month mortality rate with that. And to complicate it even further, all of our aneurysm treatments do have a risk of morbidity and mortality. I think that's getting less over time, but still there's no treatment that's risk-free. So, of course, we'd only like to treat, whether endovascularly or open, those aneurysms at a higher risk for rupture that have a worse natural history. And how can we choose which aneurysms to treat? Well, we've looked at an awful lot of risk factors over many years. And I think the things we know, size seems to be a factor, that larger unruptured aneurysms have a greater relative risk. It seems to be an independent predictor, but defining a critical size threshold remains very difficult. We'll talk more about that in a minute. It's pretty clear that enlarging aneurysms are at a higher risk of rupture, so changes in aneurysm over time, but often you don't have that opportunity. Like the case I showed you, that aneurysm might in fact have been enlarging, but with only one point in time, all you saw was a small aneurysm before it ruptured. A previous subarachnoid hemorrhage from another aneurysm, the ISUIA investigators determined that if a patient had another aneurysm rupture in the past, that the small aneurysm seemed to be more dangerous than in those patients who'd never had a subarachnoid hemorrhage. We know location plays a big role. It's much more dangerous to have a basilar apex aneurysm than it is to have an intracavernous aneurysm. And then there are patient-specific factors, age, sex, comorbidities that influence the relative risk of rupture. Female sex and cigarette smoking have been independent predictors of aneurysm formation, growth, and rupture that have been repeated in a number of studies. Untreated hypertension also seems to be in that group. And then finally, aneurysm shape seems to have an effect on the risk of rupture. If you have multiple lobulations, that increases the risk. A high dome to neck ratio increases the risk. The angle of the aneurysm coming off the parent vessel may affect the risk of rupture. And my long-standing bioengineering collaborator, Madhavan Raghavan, and I have been trying to quantify aneurysm shape and look at that as a rupture risk, for 15, actually more than 15 years now. And it's pretty clear that the aneurysm shape does determine the hemodynamic stress on the aneurysm wall, and that it's also associated with the biological behavior of that wall. Well, just one example of that is it looks like high shear stress areas respond to that shear stress by depositing cholesterol. So you get atherosclerotic change at that point, and that's often at the neck of the aneurysm. But it's the low shear stress areas of the aneurysm that seem to result in the aneurysm wall thinning and expansion. So lots of things to try to understand to decide which aneurysms are really at risk. I would like to recommend this recent 2019 publication from JAMA Neurology. This looked at over 8,000 patients in the literature and looking at the incidence of aneurysmal subarachnoid hemorrhage. And some interesting findings are that worldwide, we have seen a substantial decrease. It's gone from 10.2 per 100,000 in 1980 to 6.1 per 100,000 in 2010. But there are large regional differences, with Japan, as an example, actually showing an increase during that period of time. Another interesting finding is that these declines in subarachnoid hemorrhage seem to parallel the decrease in cigarette smoking in the various countries and decrease as we get improved blood pressure control. So it suggests that preventive measures are also of value in preventing aneurysm rupture. So let's look at some of the data that we talked about in a little more detail. We'll start with size. And if you take a size of 2 to 6 millimeters in the greatest dimension as the base, at 7 to 9 millimeters, this is ISUIA data, the whole cohort, your relative risk doubles. If the aneurysm is 10 to 15 millimeters, it's 6 times as high. 16 to 24, it's 10 times as high. And in the giant aneurysms, 25 plus, it's almost 30 times as high. So size does seem to be an independent predictor of aneurysm rupture. If you dig into this a little more detail, ISUIA looked at group 1 patients. That's where there was no history of subarachnoid hemorrhage. And then at group 2 patients, where the patients had had an aneurysm, a different aneurysm rupture in the past. And what you found was for those small aneurysms, if you had a previous subarachnoid hemorrhage, that substantially increased the risk of rupture. So a small aneurysm in group 2 didn't behave like a small aneurysm in group 1. In the 7 to 9 millimeter range, they behave similarly. In the 10 to 24 millimeter range, what you found was that right after diagnosis, for some reason, there was a 7% per year risk of rupture in that first year, but then it dropped off to about 1% a year. And in the 25 plus millimeter, 17% in the first year, and then dropped off to about 2% a year. And there were no data in group 2. People who had previous subarachnoid hemorrhage, giant aneurysm, basically didn't exist. So if you look at ISUIA, systematic reviews, pooled analyses, some selected short-term cohort studies, have concluded that small unruptured intracranial aneurysms have an exceptionally low annual risk of rupture. And so, they can be safely watched. But that really raises a difficult question. So if small unruptured intracranial aneurysms don't bleed, why are most ruptured aneurysms small? There's a real cognitive dissonance there. And if you look at the ruptured aneurysm data, it's 85 to 90% of ruptured intracranial aneurysms are less than 10 millimeters. 70 to 80% are less than 7 millimeters. And 50% are less than 5 millimeters. It's only about 10%, actually less than 10% of ruptured intracranial aneurysms are greater than 10 millimeters. So the original ISUIA recommendation of watching all aneurysms less than 10 millimeters is really hard to accept in view of what we know about ruptured aneurysms. So how do you interpret ISUIA and similar data? So I think what we need to remember is that all ISUIA patients were evaluated by cerebrovascular specialists, and in some, they recommended treatment. Why was that? And in others, they recommended surveillance imaging, observation. Well, why was that? The ISUIA data sort of assumed that these two groups would have the same natural history, but there's no reason to believe that. The group that was chosen for observation is very highly selected. And I think the most parsimonious explanation for those results is that the evaluators involved in the ISUIA studies selected low-risk aneurysms for observation in high-risk aneurysms for treatment, using a lot of factors that weren't measured in the study. And then in addition, I think, many of the aneurysms initially chosen for observation weren't just left alone. They were followed. And if there were changes in the aneurysm, they went on to be treated before subarachnoid hemorrhage occurred. So ISUIA doesn't tell us a lot about the natural history of the aneurysms chosen for treatment, and or in fact the aneurysms chosen for observation. So let's look at this a little bit. Can we explain this disconnect? That if small unruptured intracranial aneurysms don't bleed, why are most ruptured aneurysms small? And people have tried to explain that in a variety of clever ways. And one is just saying, well, the vast majority of unruptured aneurysms are very small. So even if you have a low rate of hemorrhage, the majority of the hemorrhages will occur in small aneurysms. But when you really look into that data, that doesn't hold up. If you look at the size distribution of ruptured and unruptured aneurysms, there's not a lot of difference between the groups. So here's ruptured intracranial aneurysms from ISAT and other studies, as well as unruptured intracranial aneurysms from ISUIA. And you see the less than 5 millimeter group, very similar. Less than 10 millimeter group, not a lot different. Greater than 10 millimeter group, a little bit higher in ISUIA, but that doesn't support the contention that it's just that there's so many small aneurysms that even though their rupture rate is very low, they make up the majority of the ruptured aneurysms. So another attempted explanation is that, well, aneurysms may grow very quickly and rupture at a small size. They may grow more slowly and stabilize at a small size, or they may continue to grow and become larger giant aneurysms, which eventually go on to rupture. And so the thought is, well, the ones that you see, the ones that present to you as unruptured intracranial aneurysms, they're very unlikely to continue to grow. But the ones that present as a subarachnoid hemorrhage grew very quickly and ruptured. Well, you can never really prove or disprove that, which makes it kind of more religion than science. But when you look at it, there are also some real concerns with that. We know that larger aneurysms and aneurysms of smokers are more likely to grow, and that growing aneurysms are more likely to rupture. But how does that really help us if at the time of diagnosis we don't know if the aneurysm is growing? So from a practical standpoint, that's not really a very helpful explanation. It's sort of, well, this is what we see. Aneurysm shape, this is something that Donovan and I have worked for years on. If you look at the difference in aneurysm characteristics between ruptured and unruptured aneurysms in patients with multiple intracranial aneurysm, Bacchus in 2014 found that the largest aneurysm hadn't ruptured in about 30% of the patients. So even though we know size is a risk factor, there are certainly other things that account for aneurysm rupture too. And when they looked at statistically significant features, the aspect ratio of greater than 1.3 was significant in predicting rupture. They looked at irregular shape that was significant in predicting rupture. And those were done both after adjustment for aneurysm size and location. So irregular aneurysm, or an aneurysm with a higher aspect ratio, regardless of how big it was or where it was located, seemed to have a higher rupture risk. Location is another thing. Of course, cavernous aneurysms are much less likely to present with subarachnoid hemorrhage. In fact, if I see someone with just a cavernous aneurysm, it's clearly intracavernous, I don't even follow those patients. I tell them to get back to me if they have a problem. A lot of these are being treated now with things like flow diversion. But again, I think you have to question the rationale of that, because these have an awfully benign history. Middle cerebral artery aneurysms are a higher risk than average. Posterior communicating artery, vertebrobasilar, and then basilar apex, the relative risk is almost 4 times what it is for the base aneurysm. Population-based studies. There have been some really good population-based studies from Finland, Norway, and determined that the risk of subarachnoid hemorrhage was dependent largely on 3 risk factors: smoking, sex, and blood pressure. And that the incidence of subarachnoid hemorrhage from women who smoked and had a systolic blood pressure greater than 159 millimeters of mercury was 20 times higher than among men who had never smoked and had a systolic blood pressure less than 122. And that goes along very nicely with the study I mentioned earlier from JAMA Neurology that looks like intervention with blood pressure control and smoking cessation may have a pretty significant effect on preventing subarachnoid hemorrhage. So we take a whole group of patients out of that risk. So I've just sort of described where we are now. So the last part of this talk, I'd like to ask, how do we gather further data? Because what we really want to know is what is the best option for this particular patient with this particular aneurysm. How do we gather that information? We know that we can observe that patient and do surveillance imaging. We know that we could take that patient to the operating room and clip the aneurysm, or that we could take the patient to the angiography suite and treat the aneurysm endovascularly. And each year we have more and more options of endovascular treatment that seem to be safe and effective. So what I want to talk about briefly is first a decision analysis to sort of help clarify the issues, and then talk about whether we could do a randomized trial or a prospective observational study to get more data. So decision analysis, in our analysis, the patient started out neurologically well at age 40. We chose a natural history of rupture at 1.6% per year. And this was from the ISUIA data overall. We said that clipping has a 11.2% morbidity and mortality, again from ISUIA, but decreases the risk of hemorrhage by 95%. We took half of that risk for coiling, and we say it also was effective, but not quite as effective as clipping. It decreases the risk of hemorrhage by 75%. I'm sure these numbers are not right today. This is when we did the study. And of course, to do any decision analysis, you can vary these numbers in a sensitivity analysis, but you have to start with some assumptions, and these were our assumptions. We took actuarial risks from US health statistics, added a standard discount rate for later years of life, and then using a Monte Carlo method, could assign quality adjusted life years to each of these strategies. And the analysis is interesting. So if you looked at this 1 year, if our numbers were correct, if our assumptions were correct, 1 year from entry into the study, by far the best option was observation, 0.93 QALYs. Coiling was second. It had a lower risk of morbidity than surgery. And clipping was a poor third. If you looked at 5 years from entry, however, now coiling had moved up to the best option because it had a lower upfront risk, was relatively effective at preventing subarachnoid hemorrhage, 75%. And clipping came in second, and observation came in third, but they're all kind of clustered in the same area. If we looked over the lifetime of this 40-year-old cohort, clipping became the best option because of its greater effectiveness. Coiling was second, and observation had now become a poor third. The crossover point for clipping versus coiling was 10.5 years. And once again, I'm not sure, actually, I'm pretty sure the data we used when we did this model are no longer accurate. And you don't know, whenever you do this kind of decision analysis, how accurate the data are. But it is a very good way of kind of looking at all the issues that you need to consider as you try to gather more data. So, people have talked about doing a randomized controlled trial for intracranial aneurysm for years. There was a proposal that went to NIH a number of years ago that, Ralph Dacey and I got to review, among others. There are lots of problems that it didn't get funded. Some of them, and these apply to a lot of surgical RCTs, not just aneurysms. You have intention to treat and crossover. So, someone who's assigned to observation and then gets surgery and they do well for a long period of time after the operation. Well, that good result goes to the observation arm of the study, even though they had surgery. That often the surgeons and even the patients in these studies aren't representative, and we'll talk a little more about that in a minute. And we also know that surgical expertise really has profound effects on study outcomes, but RCTs are designed so that surgical expertise is a standard. It's the same for everyone. RCTs are very expensive. Even a decade ago, the RCT that was proposed was going to cost something over $60 million to carry out. And then as technology changes, the results of RCTs may be invalidated. Using this technology, yeah, that made sense, but look what we have now. And then I think the biggest problem is there's really a lack of equipoise in both surgeons and patients. I mean, look at ISUIA. The people who evaluated the patients and the patients made a decision to treat or to observe. And I don't think that many surgeons and patients really feel that those are equal options. So to expand on that just a little bit, let's say we were doing a randomized trial for unruptured intracranial aneurysms, 3 to 12 millimeters in diameter. We're going to include people who are 18 to 75. And you're in clinic, and the first person who comes in is a 24-year-old hypertensive woman. She has a positive family history of aneurysm rupture. She's a cigarette smoker, and she has an 11 millimeter irregularly shaped basilar apex aneurysm. Ask yourself if you would randomize that patient. When I ask my cerebrovascular colleagues, almost universally they say no. And then when I ask them why, they say, well, we know she has a very high risk of rupture. And so we would recommend endovascular treatment for this patient. Furthermore, the patient has a positive family history. She knows what an aneurysm rupture means. Even if the initial physician recommended randomization, the patient would not listen to that. The patient would find someone who would treat it. Now, the next patient who walks in your office is a 74-year-old woman, no family history of aneurysm rupture. She's a non-smoker. She has a 4-millimeter smooth ophthalmic artery aneurysm. This is the kind of patient in my practice who would simply be observed. But if we were doing a randomized trial and she met criteria, would I be willing to randomize this patient? Yeah, maybe I would. But now look what we've done. You know, we've taken that patient who almost certainly has the greatest benefit from treatment, and that patient gets done outside the trial. We take the patient who has the much lower chance of benefiting from treatment, and we say, okay, we'll enter this person in the trial. You then run the trial for what, 2 years, 5 years, 15 years? And at the end of the trial, you find out that in a randomized trial, the best treatment for, best management for unruptured intracranial aneurysms is observation. Now you have, quote, level 1 evidence, close quote, for observation of unruptured intracranial aneurysms. You'll probably not be able to treat that 24-year-old hypertensive woman because of evidence-based medicine constraints. And you know, I think that kind of trial is not only likely to lead to incorrect answers, but very dangerous answers. So is there another option? You know, one thing to do is to use a prospective observational database approach, a registry approach, and design that registry in a way that we can account for confounders. So the one I'm going to talk about is propensity score analysis. It's not the only option, but I think for many reasons it's the best. And if you think about it, a randomized trial differs from a prospective observational study in only one design element, and that's the use of randomization to allocate patients to treatment groups. And we randomize patients to ensure that our treatment choice within the trial will not be confounded by baseline characteristics. You know, the outcome is dependent on a lot of these characteristics, these confounders. And if we equally distribute all of those confounders among the treatment groups, then we can compare treatment effects directly by comparing outcomes. It's scientifically nice, it's easy. But again, unless every patient, unless there's equipoise in the patients and the treating physicians, so that you really do get the whole range of aneurysm patients involved in the study, there's a problem. If you're only randomizing within a small subgroup in the patients who really are at high risk are treated outside the trial, you can get very misleading answers. In an observational study, like a registry, we know that treatment selection is influenced by these covariates, these other factors, and that they'll differ among groups. So we have to find out a way to account for these differences before we determine the treatment effect. And that's what propensity score matching does. So what a propensity score is, what propensity analysis is the propensity score is simply the probability of treatment assignment due to baseline covariates. In the example we gave before, the 24-year-old hypertensive smoker with an 11-millimeter irregular basilar apex aneurysm has a much higher chance of being assigned to endovascular treatment than the 74-year-old woman with the small aneurysms. So you have a whole list of things that you have to consider. But if you get patients with the same propensity score, then they'll have the same distribution of covariates, and they will differ only in regard to the intervention. And what it does is propensity analysis allows a properly designed, non-randomized observational study to mimic randomized controlled trial. So it's sort of a pseudo randomization. Couple of caveats. If there is some unrecognized confounder, it can't be addressed by propensity score analysis. And finally, in a propensity score design registry, you are going to find that there are patient cohorts where there is such a consensus of management options that you'll never get people who have the same propensity score in different treatments. And I think the young woman we discussed earlier would be one of those. That, however, is very valuable information because your study then says, for this type of patient, this patient with this aneurysm, the consensus is so strong that if we did a randomized trial, we would get inaccurate results. So let's just look at a little bit at these trial design components. If you have a well-designed surgical randomized trial, a retrospective database, a prospective registry, and then a registry designed for propensity score matching. So let's ask ourselves, we know that the three things that introduce inaccuracy in clinical studies are, bias, confounding, and chance. The only way to get rid of bias is to have a double-blind study. Are any of these double-blind? Whether it's an RCT, a database? No. Very, very few surgical studies are blinded. Is it prospective? Well, you have both a surgical randomized trial, a registry, and a propensity score matched registry or prospective. Do we address confounders? Well, two of them do. In one, we address the confounders with randomization, and in the other with propensity score matching. And then finally, are the data generalizable? Can you really apply them to the population? Well, even a very well-designed surgical RCT in this situation, the answer is no. If we lack equipoise and have highly selected patients and surgeons, then that's not going to be the case. And most retrospective databases, the answer is no, because these are single center studies, they're unaudited, they're often submitted to demonstrate good results. It's just not representative of the general population. But a prospective registry is generalizable because it includes all patients. And if you do propensity score matching, I think it's actually superior to a randomized trial in looking at reliable data for the kind of patients we're going to see. Up until recently, the NIH had interest only in NIH for my colleagues around the world's National Institute of Health. They fund a lot of research in the United States, and they had interest only in RCTs. But a few years ago, we did manage to get a symposium at NIH where we looked at effectiveness research to guide practice in neurosurgery. And the conclusions of that were that we may be able to use a science of practice approach, a registry approach, to generate really reliable clinical data. And then in 2019, NIH, through its National Institute of Neurological Disorders and Stroke, came out with a new funding mechanism looking at comparative effectiveness research in clinical neurosciences where clinical trials were not allowed. So a randomized study was not allowed. And that's a major step forward. So here's, if you wanted to do this kind of propensity score analysis database for unruptured aneurysms, you ask yourself the following questions. What randomized experiment do you want to model? It's observation versus endovascular or surgical treatment with unruptured aneurysms. Who are the decision makers for treatment assignment. We know it's the physicians, the patients, and the family members. What key covariates do these people use to decide? There are a lot of patient-specific factors listed there, aneurysm-specific factors, physician-specific factors, all of which you need to collect information on to get a good propensity score match. But we can define and quantify these key covariates well, and we know what clinically meaningful outcomes we want to measure, mortality, functional health status, quality of life, aneurysm rupture, et cetera. And we can do traditional power calculations to say how many patients would we need to enter to be able to do this sort of analysis. So this is a grant that I submitted within the last few months, prospective observational database comparing aneurysm surveillance and treatments that's designed to do just this. We've got 25 centers in the United States to agree to participate. The initial review by NIH suggested we needed to add a few more centers, so we're trying to do that, and they had some other suggestions. I don't know if this will be funded or not, but I think if we can do this, this would be a significant step forward in collecting information on unruptured intracranial aneurysms and allow us to better decide which patients should be managed with observation and surveillance and which taken initially for either surgery or endovascular treatment. So thank you for your attention, and if there's time, I'm happy to answer any questions that you might have.
Thank you very much, Dr. Haba, for this very thoughtful and very practical, and also how we can proceed in this very complex area, because in a pediatric practice, I get so many incidental chiaris. It's usually easy to explain to them, not to worry, we'll follow up, etc., etc. But it's chiari. But when you have an aneurysm, patients are coming with what do you call, I have got a time bomb in my head, etc., etc., much more loaded, and trying to give to get a judgment on that is very hard. And so I'm sure that those who have listened have benefited from your lecture. Please let me know if you have questions for Dr. Haba. But in the meantime, I have got two questions, Dr. Haba, for you. In terms of doing registries, are you going to have all the neurosurgeons, or you are going to have neurosurgeons with, this little complication rate? And if you go to the elite neurosurgeons, how would that be applicable to general neurosurgeons? So that's my first question. And my second question is, the risk of rupture is something that you can quantify, in the sense that the actual rupture you can quantify because it's an event, but the psychological effect of having an aneurysm, nowadays most of us want to be perfect, and we are not happy with not being perfect. But to have an aneurysm, even after counseling, people are going to change their lifestyle, because for my chiari patients, when I say to a kid, don't do the trampoline, and in the same way, how much is the life of a patient whom we are observing is changed, and has there been studies on the psychological aspects of it? So these are the two questions. Thank
you. Yeah, so let me take the second one first. I think that's a very important observation, very important question. And when we decided on what our outcome measures would be, that's why we put a quality of life measure in there. And the quality of life measure will include, psychological well-being. I think you're absolutely right. There's a big difference between a person who has an unruptured intracranial aneurysm that's untreated and an unruptured intracranial aneurysm that's now been obliterated in regard to anxiety and other things. And I think, those of us who've done a lot of vascular neurosurgery have found those patients that, other than their anxiety, we probably would not have recommended treatment, but they tell you, look, I wake up in the morning worrying about my aneurysm. I go to bed at night worrying about my aneurysm. This is not how I want to live. I'm willing to accept the risk to get rid of it. I think that's a legitimate reason for surgery. And again, a prospective observational database approach, you have to recognize that as one of the things that determines treatment assignment, that you have to be able to put that in your propensity score match. And if you can do that, and if you can measure outcomes, there's no reason you can't evaluate those patients as you do anybody else. In regard to do we have a representative group of patients and practitioners if we pick 25 or 30 centers around the country? Not completely. There may be people who do a few aneurysms a year and maybe don't do them so well. I think that's more likely to happen in the endovascular realm than it is in the neurosurgical realm. One of the things we've seen in this country is there has been a regionalization of aneurysm care where, a lot of the aneurysms, people in a non-academic practice don't want to deal with them. They just as soon send them to someone else. So I think we're going to get a very representative group of patients, and I think we're going to have a reasonably representative group of physicians and surgeons who take care of them, but that is a concern.
Thank you. Dr. Grottenhuis, any questions for Dr. Haber?
What are you asking?
No, because of the aneurysm. Do you have, now you nodded your head, so I thought that you had a question.
Let's say that this is an. I love the approach because the thing is, randomized clinical trials were the holy grail. That was that everything was RCT, and that solved all our clinical problems, which didn't. And that was precisely because of the questions. When aneurysms of 7 millimeters are of no risk and you can just observe them, why are all or the majority of the aneurysms we see with the subarachnoid hemorrhage are 7 millimeters? So that is, and then you come to this point that I think this prospective databases are much more let's say, giving the reality of what we are dealing with, so real life data, than RCTs. And exactly because of the equipoise that you were saying. And I remember that very vividly still after so many years when I started to do and trying to do an RCT in 1995 between either a shunt or an ETV. Many surgeons said, no, ETV is too experimental. We will not randomize them. And when I retried it 6 years after that, they said, we cannot withhold our patient an ETV if it is so obviously a clear case for an ETV. That happens. And that is, this is the equipoise that we have in the development of technology and also the patients. Patients coming to you and say, but I have been referred because you are doing that aneurysm endovascularly. So why are you discussing clipping with me? Or vice versa. So this is both from patients and also from the surgeon, which will always hamper surgical RCTs. So I'm absolutely in favor of what you have proposed, and hopefully, I hope that your study will be funded. You would say maybe in the US, 25 centers is not a lot, but I think that's a beginning. Yes, absolutely. This is the start. We should do this. It's so important to realize this. So from your Robert, from your presentation, that is the essence for me, that we should try to do this for real life situations. And that is what I missed in all the RCTs, what is so-called evidence-based medicine now. We should be very careful. So thank you.
Thank you.
Well, thank you, Andre. That's very nice and nice comment. Yeah, I mean, the centers that we've got to agree, we're pretty sure that we can enroll 10,000 new aneurysms in 2 years.
Come on.
And then we'll be able to follow those regardless of their, whether they're treated or observed, and follow them for up to 5 years and get an idea of, which groups of aneurysms, is there a consensus on treatment? And I think it will be the young person that, I described earlier. There will be some aneurysm patients where we say, the consensus is so strong, we can't get a good propensity score match, but you couldn't evaluate those patients in a randomized trial either. But now we know what factors lead to that consensus.
Exactly, but you take out the equipoise of both surgeons and patients.
Yeah.
And that is what troubles all the surgical RCTs.
I mean, I really worry when we reviewed the proposed randomized trial, it was really a concern because exactly for that reason, we said, well, there are going to be a lot of patients that are going to be done outside the trial who probably really need treatment, but the way this is set up, the randomized trial results are likely to show no benefit of intervention, and then we won't be able to treat the people who really need it because we're going to have a level 1 evidence that says that's not the right thing to do. So I think that could be really dangerous.
And that is why all the RCTs comparing conservative management and intervention management never have been in favor of a intervention. Because already the people considering intervention were, as you said, that 24-year-old with the family history, already knowing family members who had a subarachnoid hemorrhage and having an 11 millimeter, no surgeon wants to randomize that.
Right.
And then who wants to randomize a 74-year-old with a 4 millimeter ophthalmic, and maybe that lady would, after randomize, end up in a surgical arm, and you would put her into surgery. So all that is the problem. That there was so clear and so wonderful examples that everyone can understand where we have these difficulties in conducting surgically oriented RCTs. And therefore, I think these prospective databases are just giving us more real life data. Absolutely.
Thank you. Dr. Hava, I have one more question, slightly in with the times, but I see Dr. Boop, who has kindly joined us. One of the criticism of the MOMS trial was that all the people who were in the trial, or majority, were of Caucasian background. And I worked in Royal London, Mr. Hafiz there, and it's as a large immigrant population from Bangladeshi origin. And I don't have the data, maybe our staff has data now, but it was always in that community, the aneurysms were complex. And the question is that, any study that, if your study is published, it will have a huge impact. Obviously, prospective studies will have less biases in that sense in terms of who gets recruited. But the applicability of these studies, now we see with COVID that, different races have higher risks. And how would a study that's mainly based on maybe in elite centers with rich people as a patient will apply to poor people? I think you probably have answered it, but I just wanted to still put that question. Thank you.
Yeah, so I think in the United States, very often it's the academic centers that are the safety net hospitals. And actually, one of the things we looked at in talking to our collaborators on this, is we asked them to, let us know what the distribution of unruptured aneurysm patients was in regard to, sex, to race, to socioeconomic status. We're going to collect all of that data, but it looks like we have a very representative population based on the region. So, for instance, University of California in San Diego is going to have a much higher Latino population than we do in Pennsylvania. Some of the academic centers in urban areas are going to have a higher African American representation than in non-urban areas. So I think when we look across the numbers we've been able to collect, though, it looks like it is going to be very representative.
Thank you. Thank you very much. It's a great talk, great lectures, all on the YouTube. As I mentioned earlier, this is, to my knowledge, the first webinar that's simultaneously being streamed on Facebook, YouTube, and LinkedIn. I don't know if the LinkedIn is working, but certainly the Facebook and YouTube streaming, which has a reach of over 25,000 neurosurgeons. And so I'm sure, as I mentioned, pretty much many of the leaders of neurosurgery from India to Europe to America here and South America as well. I'm sure next year there will be conferences in the internet. I'm glad that I got this one. I hope this is a trial that you can see, but I think next time the big societies will have a fantastic time. So it gives me real honor, pleasure, privilege. You can't, as I mentioned, Dr. Boop, before you came in the last session, I have kept to all my neurosurgeons, distinguished neurosurgeons, and Professor Alusi, who are very close to me and who are distinguished. So Dr. Boop is going to give us the next lecture. Dr. Boop is the chairman and professor of neurosurgery at the University of Tennessee. He's the chief of neurosurgery at St. Jude's and Labonia Hospital. In pediatric neurosurgery, I think no one will argue if I say the last word in brain tumor is Dr. Boop. He inherited a prestigious center, St. Jude's, from Dr. Sanford. And if I may say so, he's taken it to even a higher level, which I'm sure Dr. Sanford would have expected. And I had the privilege of spending as a visiting scholar with Dr. Boop, and as I always mentioned, it was more of a, he adopted me, and I went around like a shadow the time I was with him, and I asked questions and discussed, and it was an amazing time, and got to know his family, and we have kept in contact, and he's a great mentor to me and a supporter. And to give us this last lecture on how molecular biology impacts on clinical practice, certainly in pediatric neurosurgery, has really, to its credit, I might be biased, have used, have really benefited from, have actually used molecular biology for the patients very well, particularly brain tumors. So this is going to be a fascinating lecture on where we are going, how it's impacting, how it might impact. Thank you very much, Dr. Boop.
Thank you, Naren, and thank you for the invitation. It's great to see so many of my friends who I miss dearly. Can you hear me?
Yes, absolutely.
Okay. Well, this is a modification of a talk that I gave at the ISPN virtual meeting a couple of weeks ago, and Naren had asked me to share it with you. I would like to begin with the disclaimer that even though I do a lot of work with brain tumors, my experience is clinical, and I will not claim to be a molecular geneticist. So I am part of the discussions at our weekly brain tumor conference on treatment alternatives for children with a variety of tumors, but I won't claim to be an expert on monoclonal antibodies or on molecular genetics. Let me start by saying that the ability to modify a tumor's biology by understanding its underpinnings, molecular underpinnings, is nothing new. If you look at this paper going back almost 35 years now, understanding what prolactinomas are composed of, and then applying the use of bromocriptine and now other more advanced medications to modify its biology has turned out to be the advantage of many skull-based surgeons. And we've all seen the child with or the young person with a large skull-based prolactinoma who gets started on one of these medications, the tumor shrinks up, and then they come in with CSF rhinorrhea because they've responded so nicely to treatment. More recently, but still 2007, we're talking about the time period in which Steve Jobs introduced the iPhone, and the understanding that tuberous sclerosis types 1 and 2 are influenced by the MEK-ERK pathway, and that those tumors may be responsive to mTOR inhibitors, has now become standard of care for our neurologists in managing patients with subependymal giant cell astrocytomas. And just to show you a picture of a typical child who responds quite nicely to the medication, and as long as they can tolerate the side effects of the medication, they can live on the medication and avoid surgery for long periods of time. And I'll point out that now our nephrologists are also using mTOR inhibitors for the management of the angiomyolipomas that these children get in their kidneys, with a majority of the children showing responses to the kidney tumors as well. So this is a picture from our own institution, and I'll say our neurologists nowadays are managing these children on these medications without even involving the oncologists. They're comfortable enough with the side effects. And as a consequence, the ones we see are the ones that can't tolerate the medical therapy, or the ones who stop the medication and the tumor starts to grow again. So has molecular oncology affected our practice? I would say it's changed our whole world. And nowadays things are changing so quickly that every couple of months we're looking at new phase 1 trials. We're looking at new treatments for tumors that we thought were untreatable. And I'll tell you, we've had a recent experience of a child, 3-year-old, who came in with multiple hemorrhages and anaplastic ependymoma with a specific molecular profile that was comatose. We put him on palliative care, and when we found out that he had this molecular genetic abnormality, offered the family to try a new monoclonal antibody, and his tumor rapidly shrank, involuted. He woke up, and we took out a very small remnant several months later at a point in time where the child's awake, talking, running around the room, and you'd never know he was comatose a few months ago. So in some instances, we're seeing dramatic effects from these new drugs and trying to figure out how to make this work. So if we go back a couple of decades, it wasn't that long ago that we were basing our treatment decisions and our prognosis upon what the pathologist saw when he looked under the microscope. And just to take ependymomas as an example, we learned in a hurry that tumor location may all look the same, and we aren't sure what to do, for example, with a tumor that is mostly low grade but has a focus of anaplasia within it, etc. And a couple of decades down the road, we know that the WHO classification of brain tumors in its next iteration is going to change myxopapillary ependymomas of the phylum from grade 1 to grade 2 tumor, because of the realization that the biology is not predicted by the classification scheme presently. And this is a paper by David Ellison, who's our head of neuropathology at St. Jude, looking at patients from prospective multi-center trials in the United States who were enrolled in treatment protocols, and looking at the central review by expert neuropathologists in these trials, and just showing that even amongst the best expert neuropathologists, trying to predict outcome based upon what they look at under the microscope, there is about 20% disagreement, even amongst the best of the best. So we now know that when we see a posterior fossa ependymoma, supratentorial ependymoma, spinal cord ependymoma, we know as clinicians that these are not all going to behave the same, but under the microscope, they may look very similar and the prognosis is uncertain. Nowadays, with our advanced understanding of the molecular subtypes, we now look at 9 different subtypes of ependymomas, and we know that some are more likely to occur in adults versus infants. We know that some are going to be more curable than others. And as time goes on, this is a recent paper from Acta Neuropathologica by our center, in which our pathologists now feel that there are 9 different subtypes of posterior fossa type A ependymomas. So as we get more knowledge and as we move more towards personalized medicine, we're stuck between the lumpers and the splitters trying to decide how granular to make these classifications, but also understanding that when you get this granular, there is no way to design a prospective multi-center trial anymore, because you can't accrue enough patients in any one subtype to be able to answer a clinical question. And so we're having to look at other decision-making processes to decide how to deal with this granularity of information. So we are to the point nowadays in the molecular era of medicine where we can take a piece of a patient's tumor, send it into Foundation 1, and they'll come back to us and say, this patient's tumor has 6 genomic alterations. We've got 2 therapies associated with potential clinical benefit. Here's what their abnormalities in their tumor are according to our studies. Here's what medications may be available to them based upon these molecular subtypes. Here's an explanation of what the genetic abnormality means, what its relevance is, how it affects prognosis, and what sort of therapeutic strategies could be used to treat that particular genetic abnormality. We can then look at potential targeted therapies, and we can even see on the website where the patient can be referred, where enrollment is open in these multi-center trials for their particular molecular subtype of tumor. So we're in a different era now, and it behooves us as neurosurgeons then to make sure that every patient has tumor tissue sent fresh to the pathologist, stored in the tissue bank, and available for molecular profiling. And in many instances, if we have a family history of cancer, if we have siblings with cancer, then we want to do germline testing as well as testing of the tumor itself to see if this is something that is an inherited disease that runs in the family or not. This paper from Sick Kids in Toronto, Michael Taylor was one of our fellows in 2004 who helped author this paper, I think is a neurosurgical variant, and I suspect everyone here is familiar with it. But to Dr. Grotenhaus's comment earlier that even back in Cushing's era, we had the same pathologies to deal with, I think this is a great example of how what once was one tumor is now no longer one tumor, and it's not treated as one tumor. Our decision-making on these children is now made based upon the molecular subtyping of their disease. And we know that the Wnt tumors are virtually 100% curable, whereas many of our Group C and Group D tumors are what we would call non-Wnt, non-hedgehog tumors at our institution, can be very difficult to treat. And to the point about lumpers versus splitters, we by consensus have agreed to 4 different subtypes for medulloblastoma. But for example, at St. Jude, we classify them as hedgehog, Wnt, and then non-Wnt, non-hedgehog because of the diffuse overlap you can see between groups in this region. And then if you look at the Boston group, they've published a paper saying that there should be 7 different subtypes of medulloblastomas based upon molecular profiling. So sometimes this can all become very confusing for those of us in the clinical realm. And yet we can see dramatic differences in the subtypes of these tumors based upon the molecular genetics of an individual's disease and whether they have average risk or high risk features. And that's led to our most recent protocols enrolling patients based not only on our historical significance, looking at M+ versus M0 disease and extent of resection, but also looking at things like MYC amplification and immunohistochemistry of these tumors, classic versus large cell anaplastic tumors, for example. We also have agents nowadays, such as this smoothing inhibitor that we've had some years of experience with now, but still don't completely understand, except to know that if we can block this pathway, we can see dramatic responses in some of these patients' tumors. Here's a patient with a recurrent hedgehog medulloblastoma, started on a smoothing inhibitor, and within weeks, a dramatic response of their tumor to that agent with very minimal side effects, except to say that this effect only lasted 2 or 3 months, and then the tumor started to grow back. But we know with these molecular targeted agents that we can influence the biology, and now we're trying to figure out how best to integrate this into clinical practice. This is an example of a 5-year-old who was referred to our center following a gross total resection of this fourth ventricular medulloblastoma and had no evidence of metastatic disease. So by historical protocols, he would be relegated to an average risk treatment arm based upon gross total resection and no evidence of metastatic disease and being over 3 years of age. But when we looked at his tumor, we now find that he has MYC amplification in his tumor, which is a negative predictor of outcome. And so in our current protocols, he's now relegated to a high risk arm of treatment, which is more intensive chemotherapy and higher dose craniospinal radiation than he would have in our prior protocols. When we look at our low-grade gliomas, for example, we also know that anatomical location may influence the behavior of these tumors, with BRAF fusions being prevalent in, for example, 80% of gangliogliomas, and in different regions may be more present and less likely to be present. So again, it behooves us as neurosurgeons not to just place these children on chemotherapy based upon the way their tumor looks on an MRI scan, but to actually rely on getting tumor tissue to the pathologist so that we can look at molecular profiles and see if we can enter that into our treatment decision. If we look at the cure rates for children who are placed on low-grade chemotherapy for pilocytic astrocytomas, historically, we see a dramatic response in a number of children, but the long-term cure rates are between 5 and 10% only. And when you stop to think that a medication like carboplatin vincristine confers a 5% risk of future hematologic malignancy treatment induced, we have to think about that when we talk about using these medications versus their chance of cure. So we've got potential targeted therapies for low-grade tumors now, depending on their molecular subtype. And in the United States, solumetinib has now been FDA approved for patients with tumors and neurofibromatosis. We're trying to figure out where that may fit into the schema. And we're seeing anecdotal cases such as this child with a large hypothalamic chiasmatic glioma that may show dramatic responses to vemurafenib or other BRAF inhibitors that make us think this has a great future, and yet we see other children who may have a transient response or may not respond at all. And this is a group of patients with high-grade gliomas, some of them even with the H3K27M abnormalities, but entrectinib is an NTRK inhibitor, and you can see dramatic improvement in these children in response to this monoclonal antibody. What we don't know is how long it'll last. And equally important is we're just trying to gain an understanding of the side effects of some of these monoclonal antibodies that we think of as being less toxic than standard chemotherapy. We had a child last week on a new monoclonal antibody who, on screening without any symptoms, had an outphos of 6,000, and trying to figure out where that came. We've seen other monoclonal antibody therapies that in follow-up have been shown to affect growth plate and skeletal maturation in children, making us have to think twice about using them in young children. In terms of supratentorial tumors in infants, we look at these congenital glioblastomas, and for years we've thought of these as similar to adult glioblastomas. These kids are all going to die. Why are we treating them? And yet we know now that based upon the molecular profile of these congenital glioblastomas, there's a dramatic difference in the prognosis based upon the molecular profile in these children, with some of these children being imminently curable with both upfront chemotherapy and gross total resection versus others being very difficult to cure, such as these children with the midline tumors and the RAS-MAP kinase alterations. And so nowadays with a simple biopsy through a burr hole, which can be done easily in these infants with congenital glioblastomas, may completely alter our decision-making on how we're going to take care of these children. I'd like to take a word on DIPGs because I think we've done ourselves a disservice in these children when in the early 1990s, we made the decision to stop biopsying these children because their disease was diagnosable based on MRI findings plus their clinical presentation. And 20 years down the road, we made no progress in the management of these children until over the last few years, we've started biopsying them again. And now we've started to see a number of interesting factors, including the fact that 20 years down the road, our biopsy techniques have gotten good enough that the chance of significant damage to these children is much lower than it was 20 years ago. But we've come to understand a bit about these histone mutations and their influence on all of the midline gliomas, not just the pontine gliomas. We've also understood that in the past, whereas we would like to target the most malignant portion of the tumor, the enhancing portion of the tumor, so that we could see what the most cellular portion of the tumor is, we have to understand that historically that was also the most likely portion of the tumor to bleed, hemorrhage, and cause a surgical disaster when we biopsied these children. Whereas nowadays, we know that we don't have to target that area because in the newest classification of these tumors, cellularity no longer matters, and the molecular profile is going to be the same throughout the tumor with little difference in the most malignant compartment compared to an adjacent compartment that may be safer to biopsy. And so we're more willing now to biopsy these tumors, particularly now that we have animal models of these histone mutations, and we're looking at HDAC inhibitors and other novel treatments for these H3K27M midline gliomas. A word about craniopharyngiomas. This was a landmark paper from Boston just showing the BRAF mutations noted in the papillary craniopharyngiomas. And since that time, we've seen the emergence of both case reports, anecdotal cases, and clinical trials in which patients, typically adults with papillary craniopharyngiomas, can go on to targeted therapies, sometimes with dramatic responses within a very short period of time to these tumors that previously had failed surgery, repeated surgery, or surgery plus radiation. And another case here of a dramatic response to MEK inhibitors, in this case trametinib, of a papillary craniopharyngioma in an adult. We've also, through this same research group, come to recognize that the adamantinomatous tumors that we see in childhood craniopharyngiomas have involvement of Wnt pathway alterations. And this is a patient from the NYU group who was recently reported in a letter to the editor, who had a significant response to a MEK inhibitor for an adamantinomatous craniopharyngioma. And you can see here the response of the tumor in a fairly short period of time to binimetinib, which, as I mentioned, is a MEK inhibitor. So now we're looking at clinical trials for some of these children who've had multiple operations, failed radiation, and don't have any chemotherapy options for management of their tumors. We've seen similar applications of these pathways and these monoclonal antibodies in other cancers. And it was this paper looking at plasticity in colorectal cancer that led to the idea of trying that monoclonal antibody in these children with the Wnt adamantinomatous craniopharyngiomas. So I'll leave it there for questions. It's an interesting time for us. I think the important lessons are that it's very important for neurosurgeons taking care of patients with tumors to bank tissue, get fresh tissue to the pathologist. Much of what we're doing with molecular profiling today can be done with FISH or immunohistochemistry from paraffin-embedded samples of tissue, but as we move forward in the future, storing fresh tissue is going to become more important, and this whole landscape is changing so quickly, it's hard for us to keep up with things. So I'll stop there. Thank you very much, Naren, for asking me to participate.
Thank you very much, Dr. Boop. That was a fantastic talk. Certainly pediatric neurosurgery and the neuro-oncologist and the researchers, they have done a fantastic work the last 10 years, and it's, as you said, it's going to get accelerated. Before I come to my own questions, I first of all, there's a comment from Professor Grottenhuis. Professor.
Thank you, Naren. Well, Rick, thank you for such a wonderful overview. You briefly commented my remark on the disease is still the same as Cushing dealt with 100 years ago. But the thing is, we know much more nowadays over those diseases. And I think what I learned of medulloblastomas in my residency is completely different nowadays. At that time, we already knew that some did so very well and others did very poorly. And now we start to understand why. And I think of all the things, and I think even in the talk of Fred Gentile, it was already mentioned that the molecular biology will really change this, not our technology, not having new instruments, new refinements, a better microscope or anything. It's important, but it is not decisive. Decisive is the biology of the disease. And especially if what you showed on these lesions treated with everolimus, and then having this response, we know that now also in an NF2, the patient with NF2, if you treat him with vedolizumab, that they can have a long-term result. So that is the real change that we will do. I think still that we need surgery at one point in time during the disease, maybe only to take the biopsy to find out the biology of these lesions. And then we have to learn to perform that with as small as morbidity as possible. And I was so happy that you mentioned the diffuse intrapontine gliomas, the IPGs, because they were left aside for indeed 2 decades. There was a kind of, if you saw that on the MRI scan, it was done. It was not surgical anymore. As neurosurgeons, we were not involved. This was a non-surgical case. I'm so happy that you mentioned this, because I strongly believe that we get to get involved in this again, and with the current technology, we'll be able to do this with minimal morbidity, and providing then the basis for the real therapy, at least to control, not cure the disease, but control the disease. I often said that maybe many of these brain cancers will turn out to become chronic diseases, like a diabetes that you have forever in your life, but and hypertension, and it will be a chronic disease. That would already be one of the best possible results that we can hope for until there is no real cure. So fantastic overview of this very rapidly developing biology that we now know. And as you said, as neurosurgeons, we are not so, we are not scientists, we are not so close to molecular genetics, but we should try to keep up with this to understand what is going on. And I think your lecture really brought this up front. Thank you very much.
Thank you. My partner, Paul Klimo, just published a paper on our experience with biopsies in the DIPG kids. And we've seen, now that we're doing biopsies, the majority may have the H3K27M mutation, but we've seen children who had brainstem P and ETs, brainstem ETMRs, where the histology and the molecular profiling has completely changed our thinking about the treatment. Not that we're curing these kids yet, but Mike Taylor's comment when we started into these discussions was, well, it'll probably be or like treating HIV, where a single medication is not going to be curative, but a combination of 2 or 3 may be enough that the patient can live with their disease and we can halt the progression.
Yes.
Thank you. Dr. Boop, I have a question. You are part of the American establishment, former president of the American Society, the chairman of the pediatric board of US, but now you are the president of the ISPN. Dr. Grottenhuis, he mentioned to me, I hope he remembers, about several years ago, he said, Naren, I think when I went to actually his house for dinner, Naren, neurosurgeons can't, come to be a day that the neurologists come and say to us, do the, the molecular biology is rapiding very fast and it's going to go even faster. And if neurosurgeons don't keep up with the molecular biology, pediatric neurosurgeons or the pediatric neurosurgeons with oncology don't keep up with the biology, then we will be like same with vascular surgeons, skull-based surgeons. We will get this oncologist will come and say, Naren, come and do a biopsy tomorrow for me, or put this needle and inject the solution. We become technicians. What's IS? Do you have any thoughts how establishment neurosurgery, establishment pediatric neurosurgery? Do you think this is how it is going to go? It's inevitable, or is there some place for pediatric establishment to make neurosurgeons still the carers of the patients because they came to us? Thanks.
Well, I think the role of all of the components of an oncology team are going to be redefined in the future. I mean, no question, surgeons are going to be necessary to obtain tissue from these tumors, but there are always going to be tumors that grow despite treatment or patients that don't tolerate treatment that are going to require surgery. There are always going to be tumors that are better off removed by a surgeon than they are to be treated by medications that may have significant side effects over time. And likewise, as our radiation techniques become more precise and better, we have to look at the role, for example, of proton beam therapy in the management of these. Can we shrink a tumor from a 3 centimeter tumor down to a 3 millimeter tumor and then give proton beam to that small piece of residual rather than treating the whole hypothalamus and chiasm? These are questions that we debate every week now when we have our oncology conferences. And we're going to learn the answer in the next generation of neurosurgeons for sure.
And how much a pediatric neurosurgeon can keep up with the technology and with the molecular biology? Is it important for them to keep it up, or do we just keep as technicians?
Absolutely, it's critical. It's critical. It's funny. I'm not sure that there's going to be a subspecialty of genetics anymore, because every medical student is going to have to be an expert in genetics just to be able to take care of their patients. Our pediatric neurologists' epilepsies are almost all molecular subcategorized nowadays. And the newest building that we're building at St. Jude is a $430 million molecular medicine building, where their whole plan is to do gene replacement therapy. We're already doing it for the spinal muscular atrophies in children. We're going to be doing it for all these other diseases. And so it's not just tumors, it's other diseases that affect these patients, whether they're children or adults, that we're going to have to understand at a molecular level to be able to make decisions about treatment.
Thank you very much, Dr. Boop. Thank you very much for this fantastic lecture and your thoughts on what young neurosurgeons have to look forward to. This almost brings us to the end of the proceedings. And I said, please view the posters. If you go to the website or conference website, you will see posters, and any questions you can put it on the YouTube comment section. So I will say my thank yous at the end, but it's really, from my point of view, it's always impressive for me to see Professor Grottenhuis, Professor Atul Goel, two people who know everything that anyone could know. Professor Atul Goel is always, there, Friday, Saturday, Sunday. And as I said, it always inspires for me to see someone who's such a master still wanting to learn. So I just want Dr. Grottenhuis to sum up, and Dr. Goel and Grottenhuis to give the last closing words before I thank everyone. Thank you. Professor Grottenhuis, thank you.
Oh, Aaron, well, thank you for the opportunity. It is, well, difficult to say this. This is a 3-day web conference. It's not only because of the COVID pandemic that we are doing this, because you have in the past already conducted several very well attended webinars, but I think this one was certainly an outstanding gathering of neurosurgeons around the world, and 3 days, because I to be honest, I have checked on the participants. So that's possible. You can down there not only share your screen and chat, but check on the participants. Many of them have been here around for 3 whole days, and that's amazing. It's but it also shows the commitment, and I think that is also most of all due to you, Naren, as a person, your personality, your commitment, your dedication to deliver such an educational, well, difficult to express, but an educational opportunity to the neurosurgical community, and especially young neurosurgeons. They are at your heart. And together with, and I have to mention that the support of the Nadiraja family, that you can also do this. But it's incredible. Many of us will probably take this for granted, that this is available, that we do this. But you have a unique thing in you. You have managed to get many senior neurosurgeons as much as dedicated to this effort as the young upcoming generation, the young residents, young neurosurgeons. And this makes this conference really unique. I can only say I congratulate you. In French they say chapeau, because this is exceptional what you have done and what you have achieved in the past 3 days. And I think 2020 will be a memorable year for all of us, but also this worldwide web conference in neurosurgery that you organized was extremely special. And the odd thing is, although I recently retired, I learned so much. That's odd to say, but no, it's maybe not even odd to say, but I really learned. I learned because when you really listen, you see this vast development, the pace in which our specialty is developing. And you brought this all together. I think people who have really participated 3 whole days, they have a complete overview of the state of the art of our wonderful specialty, neurosurgery. So thank you so much, Naren, for doing this.
Thank you very much, Professor Grotonius. Thanks a lot. Professor Atul Goel, you've been there from the morning on the Friday. And, and not only this one, but, you are, with Professor Grotonius and you, and, it's real. I'm sure all the juniors and all the other seniors who are here, to see you here learning, it is, it is, as I said earlier, you're always young if you learn. And, so please, your closing remarks for the young neurosurgeons and the seniors and everyone. Thank you.
Thank you, Naren, for organizing this fantastic show. I know it is not easy, particularly for a neurosurgeon who is actively involved in high-profile clinical work like you, who is busy all the time doing complex pediatric cases, thinking about complex pediatric complications and work and all those kind of things that you talk about all the time, talking to me about Chiari malformation and working on those patients, and being able to organize such a huge meeting single-handedly. I think your contributions to neurosurgery in general, to pediatric neurosurgery in particular, are now very strongly written in the history of neurosurgery of this world. What you have organized, a huge congregation of neurosurgeons in listserv, where you involve neurosurgeons and pediatric neurosurgeons in particular in discussing their problems, in discussing various regional issues, political issues, personal issues. You talk about condolences, you talk about greetings, you talk about birthdays, you talk about history, you talk about so many things. You have brought the entire field of neurosurgery together in this huge umbrella with such big stalwarts on the screen that I can see in front of me, who have blessed you and blessed the neurosurgical world with all their teachings and all their favors and all their wonderful work and technical nuances that they have taught in their lifetime and during this meeting. So Naren, I have no words but to congratulate you very heartedly and to say that people like you are very few who are dedicated to the purpose of teaching. I call them silent crusaders of this neurosurgical world. I wish you all the best, and I hope that your wonderful, wonderful work teaching the world of neurosurgery, the art and science will go on unabated, no matter Corona, no matter what. Thank you very much, Naren, for inviting me to give this closing remark, and best wishes to you.
Thank you very much, Professor Atul Goel. It means a lot. And once again, I have to thank what you call all the distinguished speakers who have taken their time to give the lectures. As I mentioned earlier, for them it means a lot to teach. They have learned the hard way and they want to give things to the next generation so others do well. And their generosity is the heart of this meeting and heart of the listserv. And this is, although it might appear that I am doing, and all the patrons who supported it, and all the listserv members who supported it over the years, I think, and I work with so many people who actually are behind it. And to be honest, I can't do this on my own with a busy practice, and I got a very good. I'm blessed with my mother, who has really kept the whole thing going. And one observation is that I will tell you, those people who presented in this meeting and those who attended, in 10, 15 years' time, they will be the leaders of neurosurgery. So thank you to all the people who put the abstracts, because they are pretty special. And thank you to all the people who put the abstracts and all the participants. Thank you very much. And can we get a group photo? If you all put the videos up, I'll take a group photo. Thank you.
Wait, that would be nice.
Yeah. If you take, all of you, please put your videos on. Then we can take
please.
Videos on, please. Thanks. If you can put all the videos on, please. Maybe it's. I shall take anyway the one here. Thank you very much. Let me just take one last one. Just a second. Great. Thank you very much, everyone. Wishing you a nice evening. Thank you very much again. Hope to meet you soon. Bye for now. Take care. Thank you.
You all.
Bye-bye.
Stay safe, please, and until next time.
Until next time. Thank you very much.
Until next time.
Thanks.
Bye-bye. Thank you.
Bye. Ciao, Fabio.
I see Pierluigi Longatti is also here.
Ciao Maurizio, bellissimo. Oh, nice to meet you.
Maurizio, we will meet. We will meet.
With coffee and Isetta, don't forget.
No, certainly not.
Andre, how is your recorder flute?
Oh, Pierluigi, great to hear you. Hope all is well. All is well. Well, these are special times, and I hope this is wonderful to be able to connect, and I hope really all stay well, and see you all soon. Hopefully, face to face again. All the best.
Absolutely.
Ciao.
Thank you.
Friends. Bye.
Thank you.
Ciao,
Maria,
Maurizio.
good to see you. Ramesh also.
What happened?
Hello, Dr. Doxy. Hello, Dr. Doxy, Professor Doxy. Sorry you couldn't join us on the microphone earlier.